I will go with Rajesh Yadav.
Yes, sir.
Yes. Actually, I was supposed to go with you, but then I decided to wear pink today.
Yes.
Ah,
It's being live on YouTube. So
Hello.
I will go.
Just a minute. Okay, just a minute. Pramesh.
Yes, sir.
I think Dr. Santosh John Abraham is in the attendees list. You have to take him to the that Association of Surgeons of India. You see in the attendees list. I think that's Dr. Santosh John Abraham. Take him in the panelist link.
Done.
Okay. I can still see him. Ramesh, done कुठे झालाय रे?
He is rejoining as panelist, sir.
Okay.
Santosh sir, good evening, welcome.
Welcome, sir. Good morning. हाँ सर. Good morning. रमेश को फोन करो. मैं बोलता हूँ उसको. मैं बोलता हूँ आप टेंशन लो. रमेश, डॉक्टर जाडली वाला को लिंक नहीं आया है. फैमी?
Yes, sir.
हरे बोलते जा. बोला है ना तेरे को. सुनता नहीं था.
We are live.
Santosh sir.
Okay. You are going to give the countdown?
good morning, Dr. Santosh.
Good morning, Dr. Santosh. Good morning, sir. Yeah.
Good morning, Dr. Sandeep.
Santosh must be still doing some other job also simultaneously. I can assure you.
I got a couple of meetings lined up.
Yeah,
with,
see, I told you. I told you.
Yeah, the committee for the SARC meeting. So we're meeting at 9:30. Then I'll be coming back again as here.
Thank you for joining, sir.
Pleasure always.
So we are good to start. It is 8:30. I request Dr. Sandeep sir to start the proceedings, please.
So, Ramesh, am I audible?
Yes.
Yes.
Okay. So, good morning, everyone. And on behalf of the Mumbai Surgical Society, it's an honor and privilege to welcome you all for this virtual update on breast and thyroid. It's said that one must always share one's knowledge and experience with others. And I'm humbled by getting this opportunity to do so along with these esteemed faculties from national and international faculty today. So welcome one and all this esteemed platform where we'll be together sharing and learning the knowledge. So I'm very grateful to all participants who have put together this wonderful events. So enjoy the day. We have very tight schedule, so I request everyone to adhere their time slot. And let's move on the first part of the session for inauguration. So I would like to call Dr. Rajesh Yadav to take for the proceeding. So let me introduce Dr. Rajesh Yadav. He is a professor and consultant and PG teacher. He is a HPB and GI surgeon at Bombay Hospital. He is a professor of surgery at JJ Hospital, Mumbai. And currently, he is a secretary for this Mumbai Surgical Society. And he is an EC member of IHPABA. He has authorized many chapters and he has a lot of national and international publication. It's handed to Dr. Yadav, please.
Yeah. Thank you, Sandeep. Good morning, everybody. Welcome to our webinar on breast and thyroid. Welcome all our dignitaries, speakers, chairpersons, and delegates. As the Secretary of Mumbai Surgical Society, it gives me immense pleasure to welcome you to our webinar on breast and thyroid surgery, which is endorsed by MASI, APSI, the Association of Breast Surgeons of India, and the Association of Endocrine Surgeons of India. Before we start the inauguration program, I would like to introduce our dignitaries. Dr. Abhay Dalvi. Dr. Abhay Dalvi is a senior renowned HPP and GI surgeon, endocrine surgeon with special interest in minimal access surgery. We know Dr. Dalvi as President of Associations of Surgeons of India, is a current president, was the President of Association of Gastrointestinal Endosurgeons in the year 2015. Having a huge experience in laparoscopic surgery, his interest of surgery is in adrenal surgeries as well as splenectomies. He has probably the nationwide the highest numbers of adrenalectomy done till date. Dr. Dalvi sir has delivered 16 oration at national and state level. He has more than 15 index publications to his credit. Welcome, Dr. Dalvi sir. Next slide, please. We have none other than Dr. Sanjay Kumar Jain. Dr. Sanjay Jain is the Professor of Surgery at Department of Surgery, Gandhi Medical College, Bhopal. He is a consultant surgeon at Hamida Hospital, Bhopal. Dr. Jain is an honorary secretary, presently the Association of Surgeons of India and honorary treasurer of Association of Breast Surgeons of India. He has delivered Professor M.L. Sharma Memorial Oration 2015, and he has multiple national and international publications and presentations. Next slide, please. Yes, welcome Dr. Santosh John Abraham. We all know him. He is a senior consultant and head Department of Surgery, Lord's Hospital, Pachalam, Cochin. He is a surgeon at Pushpagiri Hospital, Trivurala, Surgeon Hospital at St. X Cross, UK, Surgeon Leeds General Infirmary, UK, Surgeon Regional Cancer Center, Trivandrum, Surgeon at Malankara Orthodox Syrian Church Medical Mission Hospital, Kolancheri, Senior Consultant, Lord's Hospital, Kochi, Deputy Medical Superintendent, Lord's Hospital, Kochi. Presently, he is our treasurer at ASI and is a life member of Indian Society of Gastroenterology, Kerala. Welcome, Dr. Santosh John. Yeah, we have next dignitary as Dr. Someshwar SP. Dr. Someshwar SP is head of Department of Surgical and Gynec Oncology at Manipal Center, Cancer Center. He is a director, HIPAC and PIPAC program, director of Gynecology Oncology Fellowship, Manipal University. He is a director of Manipal University Breast Oncoplasty Surgery Fellowship, director Robotic Surgery Fellowship Program, Manipal University. He is a MCH oncosurgeon from Regional Cancer Center, Ahmedabad with University Gold Medal. He is a fellow of Royal College of Surgeons from Edinburgh, recipient of Gujarat University Gold Medal and record holder. His major achievement has been awarded prestigious Dr. D.D. Patel Gold Medal for excellency in oncosurgery, authored for several textbooks of oncology, director board studies, Manipal University, Manipal Hospital. Has over 300 publications in national and international journals. He is an ex-professor and HOD, Department of Surgical Oncology and Gynecology, Manipal Cancer Center, Bangalore, and robotic surgeon and chairman oncology, Manipal. So next slide, please. Now, next dignitary is Dr. M.J. Paul, who is a professor and head Department of Endocrine Surgery, Christian Medical College, Vellore. He is a president of IAES 2021. He is specialized in endocrine and breast surgical training in France, UK, and Australia. His special interests are endocrine tumors, thyroid and breast disease, minimal invasive surgery of adrenal, parathyroid, thyroid, and pancreas, surgery of advanced endocrine tumors. He has more than 100 publications and has chaptered more than 6 books. Awards and honors is Dr. N.D. Jayashankaran Oration, ASI, Nagar Coil 2014, Professor T.C. Goel Guest Lecture, Professor Krishnamurthy Oration, and Professor K.D. Verma Oration, IAES. Next slide, please. We have our own Masi President, Dr. Rajendra Ganeriwal. Dr. Ganeriwal is President of Maharashtra State Chapter of ESI. His special interest is GI endoscopy and breast surgery. Dr. Rajendra Ganiwal has many national and international papers as well as publications. He has authored in 2 or 3 books also. Dr. Ganiwal's special interest is in laparoscopic surgery and endoscopic surgery. Next slide, please. Yeah, and our own Dr. Niranjan Agarwal, our president of Mumbai Surgical Society, is the president of Associations of Colorectal Surgeons Society of India. He is an executive board member of International Society University of Cologne and rectal surgeon, trustee Cologne Foundation Trust, Colorectal Foundation Trust Mumbai, trustee and past president of Association of Medical Consultant Mumbai. Dr. Niranjan is consultant colorectal surgeon at Bombay Hospital Institute of Medical Sciences and Wokhad Hospital, Zen Hospital, and Salasar Nursing Home. His major achievements are Fellowship of ACRSI, awarded International Traveling Fellow of ACRSI, Board of Examiners of FACRSI, delivered many lectures at national and international conferences, many scientific papers and chapters in textbooks. Next slide, please. So, welcome all the dignitaries, and we'll start the lighting of the lamp.
Arogyam dhana sampadah Shubham kurutvam kalyanam Arogyam dhana sampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam Arogyam dhana sampadah Shubham kurutvam kalyanam Arogyam dhana sampadah.
Thank you all. Thank you all. And we start with a few words from our dignitaries. May I call upon Dr. Rajendra Ganeriwal to do the honors to start and say a few words for us. Dr. Rajendra Ganeriwal.
Good morning, all. Respected Dr. Abhay Darvi, sir, President ASI, Dr. Sam Shekhar, sir, President APSI, Dr. Paul, sir, Dr. Niranjan Agarwal, sir, President Mumbai Surgical Society, Dr. Sanjay Jain, sir, Honorary Secretary ASI, Dr. Santosh John Ibrahim, sir, office bearers and AC members of ASI, Maharashtra State Chapter of ASI, and Mumbai Surgical Society, faculty members and moderators and chairpersons for today's webinar, convener Dr. Sandeep and Dr. Ritesh, and dear delegates. I convey greetings to you all on behalf of Maharashtra State Chapter of ASI, and thanks Mumbai Surgical Society for inviting me for the inauguration ceremony of this webinar. Today's webinar is going to cover very common, but at the same time, very important topic in day-to-day practice of general surgeon. With new methods of surgery, with new methods of management pouring in, one has to keep pace with these recent advances. This webinar gives us an excellent opportunity to know what is happening in the management of thyroid and breast diseases, and to know what is the standard of care today. With eminent speakers and other both national and international, I'm sure this webinar will be a good learning experience for all of us. I convey good wishes for the webinar on behalf of Maharashtra State Chapter of ASI. Thank you so much.
Thank you, Dr. Ganeriwal. May I request Dr. Niranjan Agarwal, the President of Mumbai Surgical Society, to officially welcome all our dignitaries before we start the 2 words of all our dignitaries. So over to Dr. Niranjan Agarwal.
Thank you, Rajesh. Good morning, all. President ASI, Dr. Abhay Darvi, Honorary Secretary, Dr. Sanjay Jain, Academic Convener, Dr. Santosh John Ibrahim, President ABSI, Dr. Soma Shekhar, President Endocrine Surgeons of India, Dr. MJ Paul, President MASI, Dr. Ganeriwal, all my faculty, delegates, and my dear friends. It is indeed my proud and privilege and a pleasure to welcome you all on this Sunday morning, 8th of August, for an update on breast and thyroid diseases. Friends, there are three kinds of people. First, those who only remorse on adversities. Second, those who just sit back and relax on an adversity. And third, those who convert adversities into opportunities. I am happy to say that the Executive Committee of Mumbai Surgical Society is among the third one, and it has a body of less than 10 years duration, less than 5 past presidents, less than approximately 10 executive members, and less than 500 total membership, has gone forward and converted this COVID pandemic adversity into opportunity, at least as far as the academic contributions of the societies are concerned. Being second in a part of 6 such theme-based series, the breast and thyroid update, which we are witnessing today, has seen an apt selection of faculty with an apt program for the what is absolutely current scenarios in these two subjects today. And I'm sure at 5 p.m. today, when we leave the virtual platform, we will be all much enlightened on this subject. I must congratulate and compliment my two conveners, Dr. Sandeep Bipte and Dr. Ritesh Agarwal, for doing an excellent background work so that the program which you're seeing today could be delivered. I am thankful to the presidents of the societies of the breast surgeons of India and the endocrine surgeons and MASI for immediately endorsing our program, which is a city chapter program, but the National Society and the State Society readily agreed to endorse our program. And I have no words of appreciation to appreciate the ever encouragement given by the headquarters of ASI, led by Dr. Dalvi and Dr. Sanjay Jain and the academic convener, Dr. Santosh John Abraham. There is no program which would be complete without any fallacies. I'm sure something will turn up during the whole course today, and I take full responsibility as the leader of the MSS for the same, and I apologize right in the beginning if there are some fallacies, and I'm sure you please point that out to us so that we can correct it in the future program. I must also welcome Dr. Girish Lad, who is the MMC observer and has joined over here. Thank you, sir, for being with us. Delegates, you have paid and logged in today. That itself shows how interested all of you are in a subject, theme-based subject to update your knowledges. Please be logged in. Please deliberate. Please put in your questions on the chat. Don't feel shy about it. And we will make sure that all your doubts are cleared at the end of the day. With this few words, thank you everyone and welcome officially.
Thank you, Doctor. Thank you, Dr. Niranjan Agarwal. Hereupon, I will call Dr. M.J. Paul to say a few words. Dr. M.J. Paul.
Thank you for this. I would like to congratulate the organizers for this excellent program. On behalf of the Indian Association of Endocrine Surgeons, we are really happy to see the focus on the thyroid, and you have a group of stellar speakers and a very wide range of interesting and valuable topics. So I really look forward to this and wish you all the best for a successful conduct. All the best.
Thank you, Dr. Paul. May I call upon Dr. Soma Shekhar to say a few words? Dr. Soma Shekhar, please. Hello.
Rajesh, move on to the next. I don't see him here right now.
Okay. May I call upon our next dignitary, treasurer of ASI, Dr. Santosh John Abraham, to say a few words.
He's not he's the academic convener and a past president. And he's the past president.
It doesn't matter. Good morning to all of you. No, it's perfectly fine. Good morning to all of you. The office bearers of the Mumbai Surgical Society, led by Dr. Niranjan Agarwal, the headquarters team led by Dr. Abhay Dalvi. I bring in greetings from the Academic Council of Association of Surgeons of India. As Dr. Niranjan has rightly said, COVID has kept us from a 3D meeting and we moved on to a 2D meeting. And at least we are capable today to meet each other on a virtual platform. Just like Mumbai Society, we also at ASI has brought in the same concept for the last 1.5 years. We have never let down the academics go down in ASI, and it's very, very heartening to see. It's very good to see that the Mumbai Surgical Society is having a regular meeting on this, and they have moved on to a theme-based conference, and I wish the deliberations of this meeting are very good. And I'm sure that by 5 o'clock, as Dr. Niranjan has rightly put it, we would be much better off in understanding the intricacies of both thyroid and breast disease. I wish all the best to the deliberations. Wish every speaker a good deliberation, and the attendees, the delegates, to learn more from the deliberations. Thank you very much.
Thank you, Dr. John. May I call upon Dr. Sanjay Jain to say a few words? Dr. Sanjay Jain.
Thank you, Dr. Rajesh. I will say good morning, Mumbai, because we know that yesterday there was enough reasons to celebrate on a Saturday, on a weekend. So still I see about 90 attendees on the platform. It is the magic of none other than our Niranjan Agarwal, respected Professor Abhay Dalvi sir, President of ASI, Dr. Santosh John Abraham, Director Academics, past President. I also see Dr. P. Raghuram, the immediate past President of ASI. Then I have Dr. Rajen Ganeriwal, Dr. Paul Somshekhar, I could not see, Dr. Rajesh Yadav, Dr. Shirish, Dr. Sandeep, Dr. Ritesh, and galaxy of the faculty which we are going to see throughout the day. I welcome you all. At the outset, on behalf of the ASI, I would like to congratulate Mumbai Surgical Society for conducting academic activities par excellence. What I have witnessed in past few days, you know, the Mumbai being the queen of Bollywood, and our Niranjan is the real hero and he is playing the double role. Sometimes I get confused whether the Ram is playing better or Shyam is playing better, whether he is acting better in a role of President of Mumbai Surgical Society or ACRSI, but he is a wonderful organizer. I congratulate him. I would like to make a request to our President, sir. Actually, sir, what has happened that this COVID pandemic has really and surprisingly thrown us a challenge with. But I am proud to say the ASI, including all the branches, have equally or answered it in a better way. Whether the social cause, we have done enough of philanthropic activities, and the academic activities, we can see that there is flooding. But amongst this flood, I have never found that something going below standard. What I feel that in future, it will be prudent to give the responsibility of organizing some organ-based or some system-based things to individually. They can conduct very well program at the national level, and the whole nation should be benefited. Second thing, sir, which I would like to make a request, this all virtual meetings are a new thing which has been added to our armamentarium. They were not in before, so there is no award also. Sir, when the people are performing, it is our duty to appreciate. I think you will accept my request, and we will be giving appreciations to all the societies and all the branches, city branches, who have done excellent academic programs. With these few words, I wish all the best for a very successful event today. As usual, thank you very much. Thanks for inviting, and have a good day.
Thank you, Dr. Jain. I would request Dr. P. Raghuram, past president of ASI. Dr. P. Raghuram, are you there to say a few words?
He is there, but I just talked to him. He is unable to come onto the video because he just returned from somewhere.
Okay, okay, that's fine, sir. Thank you, sir. May I request Dr. Girish Lad, who's the observer of MMC and is the Surgeon Excellent Par, to say a few words before we start our program. Dr. Girish, you have to unmute yourself.
Good morning, everybody. I'm very happy to be an MMC observer for this particular program because it is my program. It's a program related to surgery. I am a surgeon and a secretary of IMA Mumbai branch. So I was very much, normally I usually don't accept this MMC observer post, but I was very eager to take this post because when I saw name of Dr. Yadav, I was sure, and all of these names of giants, I was sure that this program is going to be a big success. And it will definitely enlighten me as well as all others with the knowledge regarding breast and thyroid. So I wish you all the best, Dr. Yadav, and the entire team for arranging such a program, and request you to arrange many more. Thank you.
Thank you, Dr. Lad. May I call upon our President, ASI, Dr. Abhay Dalvi sir, to address the August gathering. Dr. Abhay Dalvi sir.
Thank you and good morning.
Good morning.
ASI immediate past president Dr. P. Raghuram, OBE, Secretary Dr. Sanjay Jain, Director Academic Council Dr. Santosh John Abraham, Dr. Paul and Dr. Somshekar, Presidents of IAES and APSI, Dr. Ganeriwal, President Maharashtra State Chapter, President Dr. Niranjan Agarwal, Mumbai Surgical Society, Dr. Yadav, Secretary, Mumbai Surgical Society, conveners of this today's program, Dr. Ritesh Agarwal and Dr. Vipte, all other faculty and attendees. I bring you greetings from the headquarters of the Association of Surgeons of India. And I thank you for organizing this wonderful program. Mumbai Surgical Society was initially decorated as Bombay Surgical Society, and somewhere down the line in 90s, after the ASICON that was held, I think in 1994, vanished. About 4 to 5 or 6 years back, Mumbai Surgical Society came back again and is slowly putting its own stamp, not only in the state, but nationwide. Under the able leadership of the past presidents and now Dr. Niranjan Agarwal, Mumbai Surgical Society is actually taking huge academic strides in spreading surgical knowledge. So in short, I can say vibrancy to being actually vibrant is what has happened to Mumbai Surgical Society. COVID in itself has increased academics, as Dr. Santosh John Abraham said, from 3D to 2D, but the number of academic events that go on have increased. And as an ASI president, I know that I also have to jump from one place to another just to be there because I'm invited because of my position. Maharashtra, somewhere in 2013, got the Best State Chapter Award and has been missing this award narrowly in last 2 years, as I see. I hope, I do not know, but Maharashtra has done enough to again vouch for the Best State Chapter Award. Let us see when the charts are full. Specialty section started somewhere in World War II when various specialties came up. We have reached a level of MCH in, say, surgical gastroenterology or endocrine surgery, etc., etc. But now I'm looking at things which are becoming organ-based. Breast and thyroid are organs of interest with multiple surgeons and sticking to only that organ of practice. Today's scientific program is packed with single organ based, which is wonderful to see. And I'm sure I'm going to attend just to learn what are the intricacies in single organ based theme program. We have been celebrating yesterday's first ever gold medal in athletics, and many other medals. I can assure you, as India goes past in various fields, we from the Association of Surgeons of India and on behalf of Executive Committee of ASI, we should go ahead and strive ahead, because through these COVID meetings, we are identifying real gems in surgery who will lead Association of Surgeons of India to the future. Thank you so much and all the best. Before I end, I will go by what the Honorary Secretary has requested me here, that a lot of cities have been doing an excellent academic programs. There is only one award, but I can assure you that every city that has done good will get an appreciation certificate from the Association of Surgeons of India. Thank you so much.
Thank you, sir. Thank you. Yeah, thank you so much. Good day, all the dignitaries, and welcome to our programs of breast and thyroid surgeries. I would conclude this inaugural function and hand over the proceedings to Dr. Sandeep Pipte to start the session. Thank you once again, all the dignitaries on the dais and the speakers. Thank you so much. Good day.
Thank you, Dr. Rajesh. And that was really a wonderful and excellent inaugural function. I think the well began is almost half done. So we had very good ceremony. So we are on the right time, and we will start with the first session. So the thyroid session. So the first session in thyroid is a master video. So for this master video, I would like to invite the chairperson, and Dr. Rajiv Joshi and Dr. Aparna Deshpande are the chair session for this session. So let me introduce Dr. Rajiv Joshi. Dr. Joshi is consultant HPB and GI surgeon. He's practicing at the Vocard and Saifi Hospital, Mumbai. He's a former professor of surgery and head unit at TN Medical College and the VL Nair Hospital, Mumbai. He was teaching faculty at above institution more than 31 years. He's a former dean in COVID Jumbo facility in last year at Worli. He's editorial board member and reviewer at Surgical Metabolism and Nutrition. He's a reviewer of HPB section and Grey's Anatomy, and he had more than 70 publications in a pure national and books. So please welcome Dr. Joshi for one chairperson. Or another chairperson is Dr. Aparna Deshpande. She is a consultant laparoscopic GI surgeon. She is a professor of surgery at GS Seth Medical College and KM Hospital. Her area of interest is HPB surgery, advanced laparoscopy, and endoscopic hernia surgery. Ma'am is also an EC member, ex-EC member of Indian Association of Gastrointestinal Endosurgeon, West Zone. He's an ex-treasurer of Maharashtra State ASI. She has more than 40 publications, and she's also a reviewer of national and international journal. So welcome you, Mom, as a chairperson. So kindly proceed for the further session. Thank you.
Am I audible?
Yes, sir. Yes.
Yes.
Good morning. I'm Dr. Rajiv Joshi. After a super sporting Saturday, let's make it a super academic Sunday. Welcome to all of you all to this inaugural session on the master videos in thyroid surgery. When we started robotic surgery, one always thought about prosthetic surgery as the main indication for a robotic application. But today here we have Dr. Amit Agarwal showing us a video on robotic thyroidectomy, and I'm equally excited to learn about the precision offered by robotics in thyroid surgery. Please go ahead, Dr. Amit Agarwal.
Thank you, Dr. Joshi, and I must thank, am I audible?
Yes.
Yes, yes.
At the outset, I must thank the office bearers of Maharashtra Surgical Society for having me there, and a special thanks to Dr. Ritesh, who's a student, and I am sure he's doing good work in Mumbai. So let me share my screen. So as rightly said, the robot was initially meant actually for the cardiac surgery, but the bullet landed in the prostate, and the prostate became the main surgery done by robot. But in last decade, there has been a lot of application of robotic surgery as applicable to endocrine surgery. No, nothing to declare. You would agree with me that the traditional thyroidectomy produces a long scar on the neck that is difficult to conceal at times.
I can't see your presentation yet.
I have shared it.
No, it's the you can't see the presentation.
Okay, let me unshare and share again. Can you see it now?
Yes, full slide, please.
Yeah, I'm doing that. Is it visible now?
Yes, sir.
Okay, so I have nothing to declare. You would agree that the traditional thyroidectomy scar at times can be bad and is difficult to conceal. And in this part of the world, there is a great cultural sensitivity to the anterior neck scars. So because of the patient-centered efforts, there has been development of alternative approaches. And mostly these approaches have been along the two divergent avenues. One was minimally invasive anterior cervical approaches, and the other was the remote access approaches. And these are some of the approaches. And this shows a development from 1999 till date, how first endoscopic surgery came, followed by robotic surgery. So the application of robotic technology to thyroidectomy was a logical step, and it has potential advantages in the form of more precise dissection, improved visualization because of the excellent magnification that is achieved, and there's a surgeon-controlled visualization, which makes the procedure very safe and faster. And there is a hand tremor filtering system, which improves the efficacy of the procedure. Mostly robotic surgery started with the transaxillary approach. This was followed by the bilateral axillobreast approach, which is the Barber technique. And then came the robotic facelift thyroidectomy, which is more popular in the US. And then the robotic THYROID, which is being popularized, especially from Southeast Asia. I follow the robotic axillobreast insufflation thyroidectomy technique, which is the rabbit approach. And this was popularized by Nayak et al. From Bengaluru. The advantage of this technique that it provides a symmetrical view of both the thyroids. And therefore, it very closely resembles a conventional open thyroidectomy. And so it's easier for surgeons to pick up and learn the technique. Besides this, it has the largest operative angles between the instruments, so there is no crowding and clash of the instruments. Excellent cost messages, of course, can be achieved. And there is no redocking of, if you want to do a total thyroidectomy, no redocking is required. And unlike transaxillary, where you would need a Chung's retractor, in the rabbit technique, you do not require any special retractor, and therefore it reduces the cost as well as the learning curve for the use of that special Chung's retractor. Now, the technique that I'm going to describe today is similar to Barber technique, but the difference is that the flaps are elevated under vision through the initial axillary part. And the last part of the flap elevation is actually done with the help of a robot, which is very fast and easier, unlike an endoscopic flap raising, which is required in the Barber technique. This is a patient who had a solitary thyroid nodule. And this you can see the flap being raised under vision. This is the initial part of the flap. And then the flaps are raised when the robot is docked with the help of a robot. So without wasting time, I'll come to so the surgeon sits on the console, and these are the various steps. I'll skip these. And so I'll just start with the video. We use the XI robot. The advantage of the XI over the previous robot is that all four arms can be used interchangeably with the telescope and the instruments. So this is the position. The precaution that has been taken is that the arms should not be abducted too much. And these are the four ports. This is the axillary port and then the breast port, and this is similar on the opposite side. And you can see the flaps being raised initially under vision. So this part of the flap, we cross the midline. And after that, then we dock the robot, the two arms first, and then do the flap dissection with the help of the robot. So this part initially is also not too slow, because under vision, you can go up to almost crossing the midline. So we take the help of the telescope, robotic telescope, to provide light, because it's a bit of dissection in the deep. So the first trocar is being put, and we'll put in gas to insufflate. The pressure that I like to keep is between 6 to 8 millimeters of mercury. So we'll put in sutures to avoid gas leak. Now, somebody may argue that the incision is big, but ultimately we have to enlarge the incision to take out the specimen. So here the advantage is that you would raise the flap under vision, and it takes less time as against an endoscopic raising of the flaps. So now the gas is being, this is the incision on the areola. So what we do is we put an intra-areolar incision so that this scar is almost invisible after a couple of weeks. It's just the width of the trocar, so it's 8 millimeters. And this is given between 12 and 2 o'clock position on the right side. So now the robot is being docked. Docking has become very easier with the XI version, and mostly it is the OT staff that is trained in docking, and they know how to, start the robot and dock it. So as I mentioned, these are the 4 arms, and but the interesting thing is that you can put any instrument, including the telescope, in any of the arms. So this brings a lot of flexibility. You can keep changing the telescope depending on your vision in any of the arms. Unlike the previous version, which was the SI version. So here one arm of the robot is docked to the trocar. There's another arm being docked to the second trocar. Initially, only 2 arms are docked, so I put in a telescope and a scissor in the other arm to raise the remaining part of the flaps. This is the third trocar being put on the left side. This is the breast trocar. And this is the fourth one put on the left side of the axillary port. And this is the remaining part of the flap being raised with the help of the robot. So for those who are interested in taking a robot, this part is very important, and one should not hurry to go to the midline. adequate flaps should be raised so that you have proper insufflation and proper vision. So I use 3 instruments. We have put in the other instrument. This is the bipolar scissor, and one more instrument, that is the progress, will come later. So 3 instruments. So you see 3 instruments here. This is the progress, the scissor. Now we have come to the midline. So you can see these are the 2 sternomastoids, and this is the midline here. I'm opening up the midline. So it's almost just like a conventional surgery, conventional open thyroidectomy. This is the midline. As I tell my residents, the thyroid surgery of layers. So you have to take all the layers in the midline and then go laterally to deliver the thyroid. So now this is the left side of the strap muscle, right strap muscles, and we are dissecting in between the thyroid nodule and the strap muscle. So head end on this side. This is the right strap muscles. This is the nodule, and we are dissecting in between this. So you can see the nodule, and we are trying to deliver it from the strap muscles, underneath the strap muscles. Now we are going to superiorly towards the pedicle. Still a bit of thyroid has to be delivered. Near the top portion of the thyroid. Now we are looking for the superior pedicle. So you can appreciate this is the superior pedicle, superior thyroid artery and vein, and we are looking for the external branch, and this is the external branch of the superior laryngeal nerve. So we try to save this. This is very important to maintain the pitch of the voice. Supplies a cricothyroid, so this has to be. So any thyroid surgeon would like to preserve this external branch of the superior laryngeal nerve. And now we are buzzing the superior thyroid pedicle with the help of the bipolar. So you can appreciate the magnification is amazing. You can all see the structures very nicely. I hope the video is clear.
Yes, sir, it's clear.
Oh, thank you. So we have taken down the superior pedicle. Portion is left, so we are doing that. So initially this was artery and then the vein.
Dr. Amit, you'll have to hurry up. Your time is up.
Okay, just a few minutes. So next step is isthmus, and we take down the isthmus followed by the. So we are taking down the isthmus here. Next, I want just to show the nerve. So here you can see looking for the nerve, and the structure as this is a lateral approach, and I'm sure thyroid surgeons will appreciate this is the most common approach. So nerve is somewhere here, and this is the parathyroid, the superior parathyroid. So as soon as we take down this tissue, you can see the recurrent laryngeal nerve. So there you can see the nerve posteriorly. This white structure, this is the nerve.
What is the energy source, Dr. Amit?
This is the bipolar. This is a special bipolar for the robot.
Okay.
You see, this is the recurrent engine nerve here. This white structure here. So, and these are the small vessels coming from the inferior thyroid artery, which will be taken down.
So, Dr. Agarwal, I think your time is.
Just give me 1 sec, 10
Yeah.
seconds. Yeah. So
Because
this
there
is
would
the
be
nerve you can
questions and we
appreciate.
would like to discuss a few
Yeah.
things.
So this is the recurrent engine nerve, and this is the thyroid being taken.
So, in both hands, you have a bipolar.
No, the right side, this is scissor, which has a unipolar,
Okay.
and the left side, this is the bipolar.
Okay.
So scissor has a unipolar.
So, does it have any, adverse effects because of the temperature rise of the monopolar
No.
and
So
the spread of current?
any vital structures, we use only the bipolar. Yeah. So just a photograph to show this is the initial incision, and you can appreciate that the breast scar are hardly visible. This is the left side axillary. You can hardly see the breast incision site. Again, you can see these are well hidden under the bra and no scar on the breast.
Yeah, thank you, Dr. Amit. That was very good. There is So one of the questions is, what is the magnification that you are getting?
See, magnification is 20x in this.
Okay.
Aparna, I would request Dr. Agarwal to answer those questions in the chat and you move
Sure,
on
sure.
to the next one.
Okay, sure.
Speakers, please understand you are given 12 minutes time for your talk and 3 minutes for discussion. At the end of 11 minutes, there will be a bell, which will be an indication for you that it is 1 minute left and you must finish between that 1 minute. Please oblige.
Yes, Niranjan. Thank you. So shall we move ahead to the next talk?
Yes, yes,
with
please.
Dr. Bhargav, transoral thyroidectomy.
Is audible?
Your
voice is breaking.
Voice are echoing.
Sir, you have to mute one of the device. Both the devices sound is on.
Yeah. Is it okay now?
Yeah,
Yes,
better.
full screen, please.
You could start the slideshow.
My screen visible?
The screen is visible.
Yeah, it's visible.
Visible.
Yep.
Okay.
I would just take that moment to wish good morning to everybody and Dr.
Yeah.
Rajesh Joshi, my co-chairperson. And let's hope the transoral thyroidectomy starts in a bit.
Just a seconds. Good morning, all of you. It's a wonderful occasion. I'm very happy to meet all of you, and most of who are my friends and colleagues, senior and junior colleagues. So at least virtually we're meeting these COVID times.
Sorry to interrupt. Can you make the
Bhargav,
full
you have
slide?
to go to slideshow.
Yeah. I'm going to.
Just go to the top of the screen to slideshow and start the show. Uh, Niranjan, should we go to the third?
Yeah,
speaker?
please go to the next speaker. He can come back once he sorts it out. Ramesh, help him to sort it out.
Him to sort it out because the slideshow is just up there.
Yeah, just on the down, just do full screen, sir. Maximize it, and down you will see a slideshow. Just click on that.
Ramesh, talk to him personally, get it sorted. Let the third speaker come in.
So can we go
I think
to Dr. Sadacharan?
he's ready, ma'am. We should go ahead.
Okay. Dr. Rajiv?
Yes. Are we with Dr. Sadacharan, please? Ramesh?
Yes, sir. Sir has logged in. I'm just sharing the CV. You can introduce and sir can start sharing the screen.
Okay, so we just saw a video on robotic thyroidectomy and about to see a video on transoral thyroidectomy. Now, the major advantage that the speakers were trying to say that it's going to be a scarless surgery. So now we talk about an open sutureless thyroidectomy, a video by Dr. Thalpathy Sadacharan. Without further ado, may I request him to start his talk and show us the video. Dr. Sadacharan, please.
So you're on mute?
The audio is not.
We are not able to hear you.
He needs to unmute Sandeep.
Sir is unmuted, sir.
You may have a recorded audio.
Sir, when you share the video, please share the sound also.
Or you can at least talk, let the video play and you can talk, sir.
Yes.
Dr. Sadacharan, you can talk.
We are not able to hear you.
Ramesh, just call him, please. Ramesh?
On it, sir.
Yeah, just call him and.
Dr. Sadacharan, we are not able to hear you.
Ritesh, will you please talk to him? Ritesh?
Yes, sir.
He just has to increase his speaker volume. That's the problem.
Yeah, or he could speak. I mean.
No, he is unable to speak because the
Okay.
speaker volume is very low.
Okay.
So all what is required is
Yeah.
he has to go to the icon and increase the speaker volume.
Is Dr. Bhargav ready?
Yeah, I'm
Ramesh?
ready. I'm ready.
Yeah, just take his presentation.
Yeah, my screen is visible now. Slideshow with screen.
Not yet.
Not yet, sir.
Initiated the slideshow. I think we should stop the telepathy.
We are with Dr. Dalapathy even now.
Once it is left, mine will be ready because my screen is ready. Slideshow.
Ramesh?
I am on call with sir. 1 minute, sir.
So you stop sharing his screen. We can't lose time like this.
Done.
Stop sharing his screen and allow Dr. Bhargav to share his screen. let him finish now. Dr. Sadajana, is there no commentary? It is only music.
Is there a commentary in this? Is he able to hear us, Rajesh?
Maybe ma'am, the video is for 6 minutes. We'll finish it and then we'll have.
Yeah.
Yeah.
I mean, can we move ahead a little bit? We are a bit late in the time.
Chairperson, please move to the next talk.
Okay.
Uh,
Aparna, take over.
okay, I think we will go back to the are we going to the transoral thyroidectomy or Dr.
Yeah,
Bhandari?
Dr.
I am
Bhargav,
ready.
if is, yeah.
I am ready. Is the screen visible? My slide?
Yes.
Yeah, visible, sir.
Okay. So we will go to Dr. Bhargav and the video of transoral thyroidectomy. So the sutureless thyroidectomy has just got over, and we are going ahead to the transoral thyroidectomy.
So good morning, all of you. Thank you for giving me this great opportunity to meet all of you, and thank the organizers for this opportunity.
Sir, your screen, please.
Your skin is not visible. Yeah.
Please share your screen.
Here it's showing you as if it's shared. I don't know, some technical problem is there.
In that case, can we go to the next one?
Yeah, you go on to the next one, sir. Before
Next one.
Ramesh, yeah, can we get in touch with Dr. Bhandarwar, please?
Good morning.
Hello, Dr. Bhandarwar.
Hello, good morning, good morning.
Good morning.
Welcome. And it's my pleasure to introduce Dr. Ajay Bhandarwar, who is the professor and head of surgery at the Grand Medical College, Mumbai. He heads one of the most academic departments in the city and in the country. And it's my pleasure to invite him to show his video on parathyroid surgery. Dr. Bhandarwar, please.
Thank you. I will share the screen. Is it visible?
Yes, please go ahead.
Yeah, visible,
I'm
sir.
talking on this
Perfect
parathyroid surgery. So the parathyroid adenoma is, as you know, is the spectrum of parathyroid disease that also includes the parathyroid hyperplasia and parathyroid carcinoma, and is broadly classified as primary, secondary, and tertiary. We will restrict the talk to the primary parathyroid adenoma disease. So this hyperparathyroidism, certain facts are there. It can occur at any age, but it's more frequently seen in the age group of 50 to 70 years in post-menopausal women. The current presentation of hyperparathyroidism shifts from the classical symptomatic form to the asymptomatic form. However, the parathyroid is still a treatment. Parathyroidectomy is still the treatment of choice, whether it is symptomatic or asymptomatic form. In past, the bilateral neck exploration and intraoperative identification of all the 4 glands was the standard of treatment. The current trend is toward the preoperative and intraoperative localization techniques with the help of advanced imaging, radio imaging, and the minimal invasive parathyroidectomy is the emerging gold standard. I will start this video with the audio presentation.
Endoscopic parathyroidectomy, dawn of a new era. Hyperparathyroidism is one of the most common endocrine disorders. Its incidence varies from 66 per 1 lakh person years in females to 25 in males. Parathyroidectomy is the most effective and apparently the only available cure. The approach towards parathyroid surgery has evolved significantly over the past century, from the conventional four-gland exploration in the 1900s to the open minimal techniques of 1980s and finally our endoscopic approach. Our first case is a 38-year-old female with pain in her right thigh. MRI suggestive of brown tumors and raised serum calcium and parathormone levels confirm the diagnosis of hyperparathyroidism. CT images revealed a heterogeneously enhancing lesion in the left lower pole of thyroid, and delayed system B images showed abnormal tracer concentration in the left lobe of thyroid, suggesting an ectopic parathyroid. The patient was planned for a transoral endoscopic approach in view of an intrathyroidal location of the gland. Here, as you see the depiction of the steps of surgery, first the isthmus is divided, followed by division of the superior pedicle. The middle thyroid vein is tackled next, and the thyroid is carefully lifted to divide the inferior pedicle using energy source. After the placement of the patient, the port sites are marked in the oral vestibule as shown. Subplatysmal plane created using a 10 mm blunt trocar, which follows the introduction of a 30-degree scope. Two 5 mm working ports are then inserted at a slightly higher level to prevent injury to the mental nerve. Dissection is carried out inferiorly till the sternal notch and the deep cervical fascia is opened in the midline. This leads to visualization of the thyroid gland. The left lobe of thyroid is dissected away from strap muscles, and percutaneously placed sutures are used to further aid our dissection. The isthmus is then lifted off the trachea and divided using ultrasonic energy. The superior pedicle is identified and carefully divided, similarly flush to the superior pole of the left thyroid lobe. As in 10 to 15% of individuals, the middle thyroid vein was absent in our patient. The thyroid lobe is then carefully dissected of the tracheoesophageal groove, where upon careful examination, the recurrent laryngeal nerve is identified. After safeguarding the nerve, the inferior pedicle is carefully taken down using ultrasonic energy. The intraoperative parathormone levels fell to 25% of the preoperative value. This signifies complete excision of parathyroid adenoma according to the Miami criteria. The strap muscles are closed with barbed PDS sutures. The histopathological examination confirmed the presence of the intrathyroidal parathyroid, which tested positive for chromogranin stains. Patient developed hungry bone syndrome 1 week after surgery, which was treated with oral calcium and vitamin D. A comparative postoperative bone scan at 9 months highlights significant improvement in brown tumor. And after a thorough research of the world literature, we found that this is the first ever documented transoral endoscopic parathyroid surgery for an ectopic gland. Moving on to a second case, a 27-year-old female with history of bilateral renal calculi. She presented with pain over right knee since 2 years. Her metabolic evaluation was diagnostic of hyperparathyroidism. Here we display a CECT neck of the patient, and as you can see, there are multiple brown tumors, one in the left maxillary region and another lobulated mass in the right lower lobe of thyroid. We proceeded to perform a technetium 99 Sestome B scan in this patient. As you can see, there is tracer retention in the right lower lobe. This further prompted us to perform a global skeletal survey on this patient, which showed thinning of both iliac wings and brown tumors in the long bones. As you can see, this led to a lurching gait in this patient. This CT loop shows the brown tumors in lower limbs. And as we slowly pan across the axial cuts of the inferior extremity, you will appreciate the involvement of iliac wings as well as the long bones. Primary hyperparathyroidism is so called due to hypercalcemia from an unsuppressed, elevated parathormone source. This patient's clinical findings have been very synergistic to the early description of primary hyperparathyroidism, which were dominated by ostitis fibrosa cystica. And like in our patient, almost 80% present with renal calculi or bony pains as the initial complaint. In our patient, in view of the lower gland involvement, a decision was taken to go ahead with an endoscopic parathyroidectomy, this time through the lateral approach. And once again, we show the steps through this graphical representation. After gaining entry, the two heads of sternocleidomastoid are separated, and the parathyroid adenoma is carefully identified after opening the intervening fascia. Its pedicle is divided with an energy source and the specimen is retrieved. Moving on to our operative video, a 10 mm blunt trocar is employed to create a subcutaneous plane, after which it is replaced with a 10 mm camera port and carbon dioxide insufflation takes place. The two 5 mm working ports are then used, which help to create a further surgical tunnel up to the sternum. This helps to expose the clavicle, and the sternal and clavicular heads of sternocleidomastoid are carefully visualized. The two heads of sternocleidomastoid are separated superiorly and inferiorly. This helps us to reach the last barrier to our target, that is the pretracheal fascia. And careful opening of this fascia will help unveil the strap muscles. The strap muscles are carefully separated and an enlarged right thyroid lobe is seen. Studies show almost 80% of individuals have a singular adenoma as the cause. As this is demonstrated in our patient by the previous investigations, and a similar finding was seen intraoperatively. And hence, intraoperatively, it was decided to go ahead with a right hemithyroidectomy, considering the possibility of an intrathyroidal parathyroid adenoma. This minimally invasive approach is also known as a focused approach. It has similar cure rates to the cervical exploration with lower rates of postoperative hypocalcemia, operative times, and potentially lesser pain and better cosmesis. As we fast forward this procedure video, you can very well appreciate the meticulous dissection that is being carried out all around to separate the thyroid from the strap muscles. And once again, the use of ultrasonic energy aids in this dissection due to a very minimal amount of lateral thermal spread. With some amount of difficulty, we were able to clearly dissect out the isthmus from the trachea, and we proceeded with the final excision of our specimen. After excising our specimen, we will carefully visualize the recurrent laryngeal nerve and then deliver the specimen outside. On saline water suspension, parathyroid adenoma sank and the fat floated. Post-operative control of parathormone levels along with a histopathological confirmation, we have confirmed that it was an intrathyroidal parathyroid adenoma. And the clear advantage of this approach is visible with an excellent post-operative cosmesis as delivered here to this patient. Our case series of endoscopic parathyroidectomy consists of 11 patients who underwent transoral approach and another 16 who were operated through a transaxillary approach. The spectrum of complications witnessed is quite varied and comparable to that seen in open surgery. However, one unique complication was that of subcutaneous emphysema. This resolved spontaneously. Coming to our initial question then, why adopt an endoscopic approach? Excellent imaging modalities and intraoperative parathormone monitoring makes focused exploration the current standard of treatment. Better illumination and magnification reduces the risk of iatrogenic recurrent laryngeal nerve injury. It leads to significantly lower analgesic requirement and much better cosmetic satisfaction. So when exactly should you offer endoscopic parathyroidectomy and which approach should you follow? The proposed Bhandarwar criteria dictates a simplified protocol for the management of hyperparathyroidism at our institute.
Sorry to interrupt you. Last 1 minute is remaining, sir.
Conclude, endoscopic parathyroidectomy has the potential to transform parathyroid surgery in a pattern reminiscent of laparoscopic cholecystectomy. It should be considered an initial and a safe surgical intervention for hyperparathyroidism. Thank you.
Aparna, you want to take over any questions?
I think we'll take as a question in chat box, sir. We'll move to the fourth one.
Fine. Okay, fine. Okay, that will do. So we're back with Dr. Bhargav.
Yeah, I think my screen is visible now.
Yes, please go ahead.
Yeah.
Please go ahead, sir.
Yeah, my presentation is video lecture on transoral thyroidectomy. You can see few illustrations of the operative pictures. The approach is through the lower gingival sulcus in the subplatysmal plane to approach the thyroid. Usually I use 3 ports, 2 10 mm and 1 5 mm ports. So directly I'm going to the video, a very short video. First I start with the 10 mm port incision, the lower gingival sulcus at the tip of the frenulum of the lower gingiva. Next, hydrodissection is done with Verus needle and saline injection in the subplatysmal plane, and sometimes I top up it with 1 drop of adrenaline, which ensures avascular plan in the subplatysmal plane. This hydrodissection to create the enough adequate operative space. So other 2 incisions in usual triangulation concept is done, and enough space is created by using hemostats, hydrodissection, and some blunt dissection. Now the trocar introduction is done, 3 trocars. Sometimes I use 1 or 2 stitches to lift the skin for extra operative space and to decrease the carbon dioxide insufflation part. Now you can see the subplatysmal plane operative space, anterior jugular veins are visible. So the dissection is gradually done to remove all the loose areolar tissue adhesions and connections. Now you can see the anterior jugular veins, the midline is being opened up between the strap muscles. Initially I use hook and later the energy source, usually harmonic shears is used. The anterior jugular veins are buzzed. The midline is now more widened. Usually I go in the plane between sternohyoid and sternothyroid. Sternohyoid is separated. Sternothyroid is stripped off the anterior surface of the right lobe of thyroid. Here, this case is about the right hemithyroidectomy. So the thyroid surface is being visible, and all the muscular attachments are stripped off. Gradually, we are seeing the pretracheal and trachea and the midline. First, the isthmus is cut in most of the cases. Now we are approaching the superior pedicle, vascular pedicle. Usually I apply 1 clip and later the superior vascular pedicle is dealt and it's cut close to the thyroid. And gradually the posterior connections of the superior pedicle are removed so that the superior pole is totally free. Superior parathyroid is visible just behind the superior pole. The further lateral separation and mobilization of the thyroid lobe is being done, and the trachea is visible. This is the recurrent lesion now with good vasa nervosum is visible, along with the crossing of the inferior thyroid artery. Now the inferior vascular pedicle is being dealt with. It's totally devascularized. Now once the lobe is separated, it is mostly placed in a custom-made endo bag, or it can be removed directly as shown through the middle port. The entire excised the right thyroid lobe. The hemostasis is checked, and a couple of stitches are applied to the midline to strap muscles to close the space. Now post-operative picture, you can see the excellent cosmesis, virtually scarless neck over the skin in the visible part, and excellent mucosal healing. And quite a few papers have published in various journals on this topic. Thank you all.
Thank you, Dr. Bhargav. I can see that there's a very interactive chat session going on. So I'm sure a lot of the panelists would be able to answer the questions individually on the chat session. Sandeep, if there any time, we can go in for an interactive question answer, or shall we call this session?
Sir, I think. Sir, please go ahead.
Sandeep, 1 minute. It's 9:54. You can take 5 minutes question answers.
Okay, fine. Aparna, can you start?
You can include all the panel, the speakers for this.
Sure.
Thank you.
Okay, so I think most of the questions in the chat box have been answered by the speakers. Can I ask the, do we have the first speaker here, Dr. Amit? Dr. Agarwal? Okay, so one of the things noticed was that the positioning of the patient that we normally do for thyroidectomy was not done in robotic. So one of the questions was whether position is not that important for a robotic surgery. I think as far as transoral is concerned, I think the position is the same. Is that right, Dr. Bhargav?
Yeah, exactly. Same as the open thyroidectomy.
Same as the open thyroidectomy. Any inputs about the robotic? I think Dr. Bhandarwar sir's presentation was also excellent. It gave a very good overview of how to select patients for the endoscopic parathyroidectomy, which approach to use. So I think, sir, that it covered almost all the points very well. Do you have any particular selection criteria for your patient in terms of size? Because most of the parathyroid glands are pretty small due to the symptomatology.
Ideally, you can go up to 5 centimeters, but initial for the learning curve, 3 centimeter, 4 centimeter is good. We have tried 7 centimeters, but it poses difficulty because of the space restrictions.
How do you decide between a transaxillary approach and a transoral approach?
Yeah, that's very good.
We are doing most of these transoral thyroidectomies. So this patient, what we shown was they had the intrathyroidal parathyroid. So that's why we did the hemithyroidectomy through transoral approach. But for lower pole lesions, more ergonomic one is transaxillary. Single adenoma in a lower pole. That suits.
Dr. Bhargav, for the endoscopic thyroidectomy, are there any implications for the malignant cases?
Yeah, it's a very good question, madam. As such, there is no absolute contraindication to not do the transoral in malignancy. It depends on the surgeon's convenience, and because the thyroid malignancies are relatively benign in their biological point of view, tumor biology. So we can attempt it. I have done quite a few cases, but nowadays I restrict it only to low grade, grade 1, stage 1 PTC, maybe with prophylactic central compartment negation. That's all. Of course, few cases I have done minimal MRND also. It can be done. It's not impossible, but ideally, from oncological perspective, for R0 resection, my indication is for low stage 1 PTC, maybe with prophylactic lymph node dissection. That's all. Otherwise, it's not contraindication.
So do the oncosurgeons also advocate endoscopic thyroidectomy?
Yeah, yes, madam. Yes, there are quite a few people known to me who are doing. Some few people in Calcutta also are also doing routinely. Even with post-auricular approach also they are doing.
Dr. Joshi and Dr. Deshpande, we are well within the time.
Yeah,
So,
I think, and
Yeah, it was, although it was like an Olympic relay race, we still could manage.
Yes. And I think the organizers require a big, congratulations, because the first session itself you have kept so interesting that it has ensured more than 150 people listening into this.
thank you.
So congratulations.
So I would like to thank you all these the chairperson Dr. Rajesh Joshi, Dr. Aparna Deshpande ma'am, the Dr. Amit Agrawal, Dr. P.K. Bhargav, Dr. Sadasharan, and Dr. Ajay Bhandaravar for this lovely session. So let's move on to the next session then.
Thank you.
Thank you, everyone.
Thank you, everybody. Thank you.
So next session, we're going to start the session 2 in the thyroid. So that's the invited lecture. And for this invited lecture, I would like to call chairperson Dr. Rajesh Yadav. I had already introduced you, and he's a professor consultant PG teacher, and he's a HPB GI surgeon at Bombay Hospital and professor at JJ Hospital. He's a secretary at the Mumbai Surgical Society, and he's an AC member of IHPAB, and he has various national and international publications. Our second co-chairperson is Dr. M.J. Paul. Sir is professor and head of Department of Endocrine Surgery at Christian Medical College, Vellore. He's the president of IAS 2021. He's specialized in endocrine and breast surgical training in France, UK, and Australia. His field of interest is endocrine tumor, thyroid, breast diseases, minimally invasive surgery of adrenal, parathyroid, thyroid, and pancreas, and surgery of the advanced endocrine tumor. He had more than 100 publications and wrote 6 book chapter. He has been awarded with honors like Linnaeus Palm Visiting Teacher Awards in Sweden 2009, Dr. N.D. Jayakrishan Oration in Nagarkoil 2014. He's a Professor T.C. Goel guest lecturer at Lucknow 2016, Professor Krishnamurthy Oration, ASI Mysore 2016, and Professor K.D. Verma Oration at Tirupati 2018. So I welcome you, Dr. Yadav and Dr. Paul, to introduce your speaker, and I would request you all to keep them in time session. Thank you.
Thank you, Dr. Sandeep, and I would request Dr. Paul to introduce Dr. P.V. Pradeep, and then we take on with the second. Dr. Paul.
Thank you very much. Am I audible?
Yes.
Yes, sir.
Yeah, it's my great privilege, first of all, to be here, and thank you to Dr. Ritesh and the organizing team, and happy to represent the IAS. So I'll first introduce a good friend of mine, Dr. P.V. Pradeep, who we know through the association, and he is a senior consultant of endocrine surgery at the Baby Memorial Hospital in Kozhikode. His achievements include a Community Surgeon Award of the ACS. He's had several travel awards and grants. He's associate editor of the BMH Medical Journal, vice president of our Indian Association of Endocrine Surgeons, a reviewer for many journals, and he has publications, 70 articles in endocrine surgery and book chapters. He's a member of several associations, including the American Thyroid Association. So he will be a fit person to deliver the next topic. Welcome, Pradeep.
Thank you, Dr. Paul. Am I audible, and is my screen visible?
Yeah, you're audible. Your screen is visible.
Yes, sir.
Okay. So at the outset, let me thank the Mumbai Surgical Society as well as Dr. Ritesh Agarwal for this invite. My talk is on the newer investigations in thyroid and parathyroid diseases. But as such, I believe that it's not the newer investigation, but it's actually the optimal utilization of the available investigations, the judicious use of the available investigation, plus the additional investigations which is available at your disposal, that makes the management of thyroid and parathyroid diseases better. Now, I will go through just two small cases where you think about additional investigations, or where you start thinking what is optimal to do, what more to do before I intervene in that patient. So this is a 55-year-old lady who had come to us, who is a foreign national, who had come to us for a health checkup. And during the health checkup, we found that her calcium is high, along with the PTH, and there is a normal levels of creatinine and vitamin D, suggestive of a primary hyperparathyroidism. So as usual, as a routine, you go for the available and most reliable investigation. So that is the ultrasound, and you see the ultrasound shows a thyroid nodule, but the sonologically there is no reason to believe that there is a parathyroid adenoma. Then you proceed to the parathyroid system. If we scan the SPECT CT, here again you see that there is no scintigraphic evidence of a parathyroid adenoma. So now that's a point where you start thinking whether you should go further and evaluate, or you can just go in and take the parathyroid tumor out. Now, this is another scenario. You can see a patient who has come to us with a biochemical evidence of hyperparathyroidism, but on investigation, on clinical examination, you see that the patient has got characteristic cutaneous lesions called as collagenomas, which is characteristic of association with the multiple endocrine neoplasia type 1. So when you check the prolactin, you find the prolactin is high. So that means we are dealing with the MEN1 syndrome. Now, when the sonologist evaluates, he says that there are two parathyroidomas visible on the left side, but nothing on the right side. And he does a MIBI scan. I mean, we do a MIBI scan, and then we find that there are no local parathyroidomas visible on the MIBI scan. So we have a case of MEN1 where you have one localization positive, other localization negative, and these are his family members, his sisters, who had come to visit him. And on evaluation, I find that all of them have hyperparathyroidism and all of them have hyperprolactinoma. So this suggests that we are dealing with a multiple endocrine neoplasia. Here again, this is another situation where you start thinking, what else should I do? What all investigations should I do? Should I rule out any other conditions? Which any other conditions do they require a first priority over the hyperparathyroidism? So these are things which come to your mind. So as I told in the beginning, it's a judicious use and optimal use of available investigations and plus additional investigations which you have. So before that, you should also, as a surgeon, you should also realize that there are some entities which have come forward now. One is called as the normocalcemic primary hyperparathyroidism, which constitute about 12.5% of the variants in hyperparathyroidism. One is a classical variant, which is the majority. And this constitutes about 12.5%. Then you also have a hormonal primary hyperparathyroidism. So in normocalcemic primary hyperparathyroidism, you will get a normal calcium levels with an elevated PTH. Of course, you have to rule out the secondary hyperparathyroidism. You must realize that if secondary hyperparathyroidism has been ruled out, this is probably a case of multiglandular disease, and you have to investigate to locate the multiple glands, and also you should be ready intraoperatively to do additional explorations to find out whether there is any multiple gland involved. And remember, in such a situation, the sensitivity of diagnostic modalities will be low, and surgical cure rates without appropriate evaluation will be low. And as a surgeon, when you operate hyperparathyroidism, remember, before you interpret and label the patient as a case of primary hyperparathyroidism, you should rule out familial hypocalciuric hypercalcemia. These patients will have high calcium, high PTH, but they have hypocalciuria. And these are the patients who do not require parathyroidectomy. They require only conservative management. Similarly is the case of idiopathic hypercalciuria, where you have biochemical features of mild hyperparathyroidism, but they don't require surgery. So biochemically also, you should be very careful while interpreting the investigations. That's why I said it's an optimal and judicious use of investigations and interpretation of investigations. So if you have a patient like the second case which I showed, you should remember that it is possible that it could be MEN1, it could be MEN2, And in MEN2, you have to deal with the pheochromocytoma first before you go on for the parathyroid surgery. If you are having a patient with hyperparathyroidism jaw tumor, the surgeon should be aware that 15% of these patients are likely to be malignant, having a malignant parathyroid. So you should be ready for additional surgeries like a hemithyroidectomy, and you should get the consent also from the patient preoperatively. The points to remember in a hyperparathyroidism is that about 15% will have multiglandular disease. And if you look at the surgical approaches, whatever be the surgical approach, the surgical approach depends on presence of genetic disease and a positive localization. So, as I said, we'll just look at the available investigation. The parathyroid ultrasound. When you send a patient for parathyroid ultrasound, you always make sure that your sonologist is a person who routinely does parathyroid ultrasound, because this ultrasound, parathyroid ultrasound, is operator dependent. The sensitivity is operator dependent. In multiglandular disease, and when you have obese patient, when you have ectopic glands, you will not be able to locate the parathyroid. But a good sonologist very often picks it up. As per my experience, I have seen patients who have negative scans turning out to be positive ultrasound scan in our hospital, where you have a very good sonologist. Similarly, when you do the MIBI scan, one thing to remember as a surgeon is that sometimes you may get a positive MIBI scan, and then when you start exploring and you send the tissue for frozen section, you find that it is not parathyroid. So false positive MIBI scan, you should always think of in case of follicular neoplasm, thyroid, Hurtle cell neoplasm, and sometimes lymphonodular uptake. Of course, if you have false negative scan, it's okay, because you will do additional investigations, or you are mentally prepared to do a 4-gland exploration. The addition of SPECT and SPECT-CT in the MIBI images has got a higher sensitivity to detect the parathyroid adenomas. If your conventional tests are negative, you should go for additional investigations before you start exploring the patient. That's my personal opinion, even though you can find out the adenomas in about 95% of the cases. So the parathyroid CT is sensitive in about 65 to 70% of the patients. So if properly done, you may pick up the adenoma. Now we have the 4D CT, which with the addition of time as the 4th dimension. It's not widely available, but remember, it gives a thyroid-specific radiation, high radiation for thyroid gland. It has got high sensitivity and specificity for locating ectopic glands with a negative predictive value of 93%. Now, there are studies which have compared 4D CT to SESTA-MIBI, and you find that for a single gland adenoma, the sensitivity is higher than the SESTA-MIBI. For a multi-gland disease also, the sensitivity is higher than the SESTA-MIBI. But there are other studies also which have shown that this advantage may not be very high, taking into account the cost and the availability. And they showed that there's only a borderline increase in sensitivity. So now the current indication will be a reoperative setting. And when you have inconclusive other images, then you can use a 4D CT. These are the 4D CT images which shows multiglandular disease in a patient with hyperparathyroidism, primary hyperparathyroidism. Then if you don't have that, you go for a MRI scan, which has got a sensitivity of 79%, and the sensitivity can increase 90% if you're combining with ultrasound and SESTA-MIBI. The advantage is that there is no ionizing radiation. But remember, there are certain pitfalls of imaging. This is especially applicable when your parathyroid gland is small, less than 200 milligram. You have multi-gland disease, and you have a radiologist who is not very well trained. So you have suboptimal interpretation, and presence of goiters can interfere with your imaging of parathyroid. Now we also have PET-CT. So PET-CT, you have certain isotopes like C11 methionine, which has got a sensitivity of 75 to 88%. Even FDG PET is used, which is sensitivity of 62%, and fluoromethylcholine PET sensitivity of 96 to 100%. But these are all promising secondary modality. It has not replaced the primary modality of ultrasound and MIBI scans. These are infrequently used, availability is an issue, costly. And then you require additional studies with larger samples to say that this is more advantageous. And for a parathyroid surgery to be successful, you should use additional gadgets and investigations during surgery. For example, you can see these are the modalities which we have. Intraoperative PTH, you have frozen section biopsy, you have intraoperative gamma probe, you have intraoperative ultrasound. So you see on this side, I've shown a graph where you can see the PTH basal is 537. It falls after the first tumor excision, but it has not come to normal range. So that is of concern to me. So I explore, and you find that there is an additional tumor, a second adenoma. After its removal, the PTH has come to 42. So this is a very good investigation which you should use during your parathyroid surgery. Parathyroid parathyroid autofluorescence, the intrinsic near infrared autofluorescence, is being tried for intraoperative identification of normal as well as abnormal parathyroid tissue. You can use it in combination with injections of methylene blue and indocyanine green. There are reports of doing that. They say that frozen section can be avoided, and prophylactic thymectomy in a multi-gland disease can be taken care of if there is no autofluorescence visible in that area. This is the radio-guided parathyroid surgery. You have the gamma probe. You can see there's a stamina injected before the procedure. On the gamma probe on the back side, you can see the radioactivity count, and you can put the appropriate incision at the appropriate place, and you can remove the parathyroidnoma, like in the focused parathyroidectomy. The guidelines of surgery has very well said that most of the parathyroidnomas will require surgery, whether it is symptomatic or asymptomatic, and hence optimal and judicious use of the available as well as the rare investigations are important to plan your surgery, be it a conventional parathyroidectomy or focused parathyroidectomy. So now we'll come on to the thyroid diseases. Ridesh has allotted me a very big topic to be covered under a very small span of time. So I'll try to do justice to this also. The thyroid diseases, again, as I said, you have to use what is available judiciously, optimally. So thyroid ultrasound is one which is available at your fingertips, but the problem is it has to be done properly. So the ultrasound is generally done by us to look for suspicious nodules, and on the suspicious nodules, we'll perform the FNAC, and it's for a long-term follow-up also. You can use this ultrasound very judiciously. So the radiologist who is very well versed or with the thyroid ultrasound will take into consideration many factors based on which he or she will tell you that whether the nodule is highly suspicious or it is benign. So based on these points, like hypoechogenicity, microcalcification, which you are very well aware of, based on that, the radiologist will put the scoring as THYROIDS 1 to 6. And as practitioners, as GPs, you should insist whenever you send a patient for ultrasound to your radiologist that you get the THYROIDS score, because very important. If suppose you have a patient with THYROIDS 3 now, and on follow-up it is THYROIDS 4B, you can tell the patient very clearly that because of this, I'm going to operate you, or I am suggesting surgery for you. But very often in general practice, what we are getting is reports like this, where you have nothing mentioned about the size as well as the THYROIDS of a particular patient. So this ultrasound is very suboptimal, and you have to repeat the ultrasound to get a proper THYROID scoring. Similarly, the Bethesda scoring should be used optimally and judiciously. Sent to pathologists who give you the Bethesda score, because Bethesda score and risk of malignancy do very well correlate. Now, just sending an FNAC because you have seen a thyroid nodule is not enough, because to become more accurate, you require an ultrasound guided FNAC. The chance of missing a malignancy will be low. But in practice, I have seen that many physicians do not order an ultrasound guided FNAC probably because non-availability locally, or because it involves another doctor in the procedure, and then it takes time and as well as it costs to the patient. But remember, even if you're getting a ultrasound guided FNAC, the non-diagnostic aspirates are very high among radiologists who do not routinely perform this procedure. I have shown one FNAC report here. Here again, you can see that this is the state of affairs when you get an FNAC report where you do not have the Bethesda mentioned in that. So as per the protocols now, if you have a patient after the ultrasound and the FNAC, you see that you have a patient who have a THYROIDS scoring as well as you have the Bethesda classification. So Bethesda 1, 2 is okay, but Bethesda 3 and 4, this is a group where the malignancy could be anywhere between 10 to 30%. And so these patients will undergo surgery. But here, the addition of molecular tests have now come up. Now, This is an additional investigation, newer investigation, blending with the already available investigation. So the molecular testing is based on three main molecular approaches. One is testing for the somatic mutation, gene expression evaluation, and microRNA based classifiers. So you have the THYROSEC version 3, which is targeted sequencing analysis of about 112 cancer related genes. So you look for point mutations, gene fusion, and abnormal gene expression. Sensitivity is 94%, specificity is 82%, with a negative predictive value 97 and then positive predictive value of 62. It eliminates diagnostic surgery in Bethesda 3 and 4 category in about 61% of the patient in some studies. Then you have the AFFIRMA genomic sequence classifier based on the microarray analysis of mRNA expression profiles, which uses 12 classifiers composed of 10,196 genes, and it again has a good sensitivity. Specificity is at 68% with a positive predictive value of 47, negative predictive value of 96%. Then you have another assay, which is a combination assay, which includes microRNA classification and next generation sequence mutation analysis. This has got a positive predictive value of 74% and negative predictive value of 94%. So the limitation of mutation-based approach is that RAS mutations can be present even in benign tumors. So this table shows that if the risk of malignancy with a suspicious pattern or a positive result with these molecular testing in Bethesda 3, if it is positive result, the chance of malignancy is 51%. If it is negative, the chance of malignancy is 3%. Similarly, in other tests also you can see the chance of malignancy can be very well predicted in up to 64% of the patients. Apart from this high investigations, rare investigations, even normal X-rays can sometimes tell you this diagnosis. This is a patient with a follicular adenoma on FNS. You see the X-ray just shows that you are dealing with a malignancy. So even simple tests will tell you what you're doing. I also thought that I should mention about nuclear imaging, because it is always these patients are sent for nuclear imaging to find out whether it's a cold nodule. Cold nodule per se does not indicate anything. Nuclear imaging is indicated only if the patient is having hyperthyroidism, where you order either an iodine 123 or technetium 99 per technetate scan. As in this case, you can see a patient with hyperthyroidism, polythyroid nodule is palpable, and on the scan it shows that it's an AFTN. Similarly, in this patient, it shows that the technetium scan shows that it's a cold nodule and not a AFTN. So that patient will require a total thyroidectomy. FNAC in toxic thyroid should be considered only in patients who have got cold nodules or a suspicious nodule on ultrasound. In thyroid surgery, additional investigations, additional gadgets can be used, because one of the commonest problem is the recurrent laryngeal nerve palsy. That is because there are certain issues with the recurrent laryngeal nerve. One is the variation in anatomy, two is the branching pattern, three is the proximity to the ligament of Berry, etc., etc. So now you can use the neuromonitoring, where you have the endotracheal tube with specially designed electrodes, which is placed at the level of the vocal cords, and you can stimulate during surgery, get the EMG response, and you can save the nerves. And for saving parathyroids, especially this is meant for surgeons who are not very experienced in identifying parathyroids, you can use this newer identification techniques like indocyanine green fluorescence, and you can identify the parathyroids. And as with any surgery, thyroid surgery also, we can use daycare surgery, but the problem is, even though it reduces the cost, the problem is that many of these patients may develop a delayed hypocalcemia, and that is very difficult to manage, especially in Indian settings. So now we have, you can use a multiple investigations together, both pre-op investigations, post-op investigation, commonly available, and a blend of these investigations, and you have a scoring system which was put up by myself when I was in Nellore. And we have a predictive, we can have a prediction of hypocalcemia following thyroid surgery and plan elective early discharge. So to conclude, in hyperparathyroidism, the newer thing is that you have to identify the variants. Non-localization or fault localization with conventional imaging has made additional imaging a requirement for successful surgery. 4D CT and C11 PET are additional localization in modalities, although at additional expense. Intraoperative investigations like frozen section, PTH, etc. will identify which aid you in successful outcome. Thyroid nodule evaluation requires judicious use of currently available investigations like FNAC and ultrasound before going on to additional tests like molecular testing. Diffuse toxic goiter needs nuclear imaging. Surgery is much safer and more radical when you use neuromonitoring. And daycare surgery is facilitated by using judiciously additional investigations pre-op and post-op so that hypocalcemia can be predicted. So thank you very much for a patient listening, and I hope I have completed on time. Thank you.
Thank you, Dr. Pradeep. That was very well covered and so large an area. You did it extremely well. I would like to just ask you to elaborate on which of these newer modalities. I think the important ones that have come up are autofluorescence or parathyroid, choline PET or methionine PET for parathyroid. What is your personal experience and the availability in the country?
Yeah, that's a very good question. Regarding the autofluorescence, I have no experience. I have only literature knowledge, what I've read about it. And regarding the choline PET, I think I had sent 2 patients for that. It's available in Bangalore. You send over the patients to there. I think it's costly. Around 30,000 was the cost for the choline PET for parathyroid imaging. Of the 2 patients, I had 1 localized. The other one was not localized.
There's one question which is asking about RLN monitoring device. Can you shed a light on it? The details of RLN.
The neuro monitoring device. Do you have any more details have been requested?
Okay. The neuro monitoring device has been in use for many years now. And I have also completed about 100 cases with the neuro monitoring. It's a very good modality where you have the specially designed endotracheal tube where you have the electrode placed at the level of the vocal cords. But of course, you should have there is an initial learning curve in that, because there are some issues which can, even if unknowingly your anesthetist has given the relaxant, you will find that you will not get a signal, and you may get panicked that the signal is not there. You have identified the nerve, whether you have injured it. So there are a lot of issues with that. The initial, even the surface electrode which is placed on the patient may not be, you would have used for 3-4 patients, and the 5th patient it may not be working, and you see that the signal is not shown on the screen. So you have to use it before you get comfortable with it. Initially, you will find that there are a lot of issues with that, especially the learning, the teething problem is there. But however, one thing is important is that towards the ligament of Bury, you can be more radical, and because you know where the signal is, where the nerve is exactly entering. Of course, you see that with the loop also, but still you become more confident, and you don't feel that the smaller fibers which you see are the nerve fibers, the branches of the nerve. Because as you operate more and more in this area, you will be wary of the branches of the nerves, not the main trunk.
Yeah, thank you so much, Pradeep. We have come to the end of our time. I would like to encourage all interested thyroid surgeons to look carefully at these techniques, evaluate for themselves the utility in their own practice, and proceed. With that, we'll go to the next talk, Dr. Rajesh Yadav.
Yeah. Our next speaker is Dr. Shashank Joshi, who will be speaking on medical management of thyroid hormonal imbalance with relevance for surgeons. Dr. Shashank is the consultant endocrine and metabolic physician from Mumbai. He is the president of Indian Academy of Diabetes. He is a past dean, Indian College of Physicians, and chair of International Diabetic Federations. He is the past president of Endocrine Society of India, Associations of Physicians of India, the Research Society for Study of Diabetes in India, Hypertension Society of India. He has topped all years of MBBS, MD, and DM with gold medalists. I can really vouch for him because I was just across his room. He is fellow of American College of Endocrinology USA, American College of Physicians USA, and the fellow of Royal College of Physicians. He has many accolades. I think it will take a lot of time. I would request Dr. Shashank Joshi to start on his session. Dr. Shashank Joshi.
Thank you, Dr. Rajesh Yadav. At the onset, I would like to thank the Mumbai Surgical Group and Dr. Ritesh Agarwal in particular for including this topic, which is very relevant, of thyroid and surgery, the medical issues. And I'm really, some of the parts which I may discuss might be very, very elementary, but I will straight go to the topic, because we know that thyroid hormones virtually affect every organ system, and complications associated with thyroid dysfunction are very numerous and diverse. And in the limited time Dr. Ritesh has given me, I will try to just focus on what is relevant perioperatively on thyroid states of hypothyroidism and hyperthyroidism. We currently understand that it's the peri-op period which may exacerbate underlying thyroid disorders, and that's where surgeons like all of you come in picture, because we want to potentially avoid precipitation of decompensation or death. And those are the two Ds which all surgeons want to avoid. And for that, we need to comprehend the mechanisms by which thyroid disease may complicate surgery or post-op recovery. And we must be very cognizant of all the various ways to optimize thyroid status. It's particularly more relevant for thyrotoxic states perioperatively than hypothyroid states, but both are equally important. And even though we are talking in 2021, we still occasionally do see complications, but maybe 2 or 3 decades back, these were much more. We are currently understand that there are a lot of adverse impacts of thyroid dysfunction as they relate to patients both for thyroid and non-thyroid surgery, and therefore we need to decrease the perioperative risk. So should we routinely screen general population, every patient who walks into you like a triple H test? Should we do everybody's thyroid? And the answer for that is no. But the only thing is, if there is a woman in a premenopausal age, the incidence of thyroid disorders in women population is almost 21%. So that's something which one may look at, because we know that thyroid hormone affects the body, and it may complicate surgical procedure and post-op recovery. So routine screening for detecting thyroid diseases is not indicated in patients for non-thyroidal surgeries if there is no index of suspicion. And that's why it is important to recognize, diagnose, and optimize pre-existing thyroid conditions in people who are undergoing surgery. And that's something which we need to recognize. But in women, we may think of it. So as I said, though it is not routinely recommended for people without history of thyroid dysfunction, a TSH doesn't hurt. But if you have unexplained weight changes, palpitations, tremors, change in bowel habits, skin, hair, or integument issues, and eye changes, which suggest thyroid dysfunction, it doesn't hurt to do a free T3, free T4 TSH. If a physical examination reveals presence of orbitopathy or exophthalmos, a goiter, abnormal reflexes, hair or skin abnormalities, tachy or bradycardia, probably a TSH test may be added. So unless and until you have some clinical symptomatology or physical examination signs, in absence of history of thyroid dysfunction, it may not be prudent to do pre-op screening. But people who are known hypothyroid or hyperthyroid, who are undergoing treatment, a TSH test is mandatory to determine the adequacy of treatment or to ensure that the thyroid therapy is optimized before surgery. And keeping a TSH between 0.5 and 2.5 is optimal. Of course, a lot of TSH upper range of normal is often at 4 and 5, and it doesn't hurt if the TSH is 4, 5, or 6. But remember that ideal TSH should be between 0.5 and 2.5. So the first part is hypothyroidism. We know that there are cardiovascular concerns as complications of hypothyroidism which can impact surgery, because we know that thyroid hormones on homeostasis can have impact on cardiovascular, respiratory, renal, GI, hematologic, and CNS. The primary challenge in peri-op situations is, can hypothyroidism pose a risk for coronary events because of dyslipidemia, prolonged half-life of multiple coagulation factors, and anemia? The low voltage ECG should make you suspect, and non-specific STT changes should make you suspect. Very rarely you can get torsade points on ventricular tachycardia. So an ECG by and large rules out, and each one of you all do an ECG perioperatively. So most of this gets covered in. Now we clearly know that when there is hypothyroidism which is unrecognized, and sometimes it can be not overt, you can have a drop of 30 to 50% in the cardiac output. which will cause both bradycardia and decreased contractility. And clearly the peripheral vascular resistance will go up. There will be increased cardiac afterload, and clearly the diastolic blood pressure will increase and systolic blood pressure will decrease. And we also know that in hypothyroid patients, they do have a predisposition to develop hypotension under anesthesia. And this is very unique because there is downregulation of the beta adrenergic receptor. So this is something which we know, that the catecholamine levels are increased in these patients, but they have a unique predilection to develop hypotension under anesthesia due to downregulation of the beta receptor. The other challenges which we face in hypothyroid patients, if left untreated and operated, are ventilatory dysfunctions and renal dysfunctions. Occasionally pleural effusions, respiratory muscle weakness, and impaired hypoxia and hypercapnic respiratory drive and obstructive sleep apnea may complicate perioperative management. And it can predispose post-op pneumonia and atelectasis. Also, we know occasionally in hypothyroid patients, you may get hyponatremia, particularly in elderly individuals, due to increase in ADH, and also due to increased capillary permeability in the extravascular space. There is a shift and decrease in the intravascular volume and renal perfusion, and the clearance of medications may be hampered. So pulmonary and renal factors contribute to some increased susceptibility to hypothyroid patients, particularly to all anesthetic agents. So you might need lower doses, tranquilizers or narcotics. The other challenge which rarely can occur if you have operated an hypothyroid patient is post-op ileus. And it's not uncommon occasionally to see, and sometimes, in post-op pain managements, when we use opioids, you might independently promote constipation and post-op ileus. And one has to be very cautious and careful when you're operating in hypothyroid case. We clearly know hypothyroidism has been documented to have known hematological effects, particularly on the CBC. We know normocytic normochromic anemia is common. We know B12 deficiency due to autoimmune association is very common, which can be very easily picked up on macrocytosis. Furthermore, anemia can be common, particularly in perimenopausal women because of menorrhagia, secondary to hypothyroidism. And very rarely, you can get some bleeding disorders. We clearly know that hypothyroid state is a state of acquired von Willebrand disease. And that is why having a TSH between 0.5 and 2.5 is crucial, because the factor VIII activity is decreased and there is a prolonged partial thromboplastin time. Very rarely, and I think very rarely we see this now, unless and until we precipitate, the hypothyroid patients with myxedemic coma is almost uncommon now. Unless and until you do occasionally pick up, altered mental status, which may have seizures, hypothermia, bradycardia, hyponatremia, heart failure, and hypopnea. And we all know that myxedemic coma is virtually disappeared now. And I hardly feel that anyone must have seen case in the last 10 to 15 years, particularly in private setups. But we do see cases in public health hospitals. So clearly, when we are looking at a pre-op consideration in hypothyroid patient, we need to ensure that all these changes are completely reversible with replacement of the hormone. We need to understand that if there's a risk of acute decompensation, we need to postpone elective surgery till adequate thyroid hormone is on board. Clearly calculate dose of full replacement of thyroxine with 1.6 microgram per kg per day. That's the standard formula. You will never go wrong if you use that dose. However, if there are elderly individuals above 65 or people with documented coronary artery disease, start with 25 micrograms per day and increase it every 2 weeks till euthyroid status is attained. And remember, half-life of thyroxine is 7 days. And then, of course, once normalization is done, surgery can be performed. Now, clearly, we know that as the half-life of thyroxine is 7 days, and often on the day of surgery, patient is fasting, even if you miss the thyroxine dose, it doesn't matter. However, if oral medications are going to be missed for several days, particularly for more than 5 days, then only IV levothyroxine has been recommended by all societies. And that too, the dose has to be 60 to 80% of oral dose. IV thyroxine is very rarely available. Many cardiac surgeons use it, particularly T3 is more freely available than the T4. And nowadays in routine care, we don't use T4 at all. Although the whole idea of hypothyroid patients undergoing surgery, the definitions are all based on mild, moderate, and severe hypothyroidism. The interpretation vary from studies to studies, and the conclusions are also reasonable. So obviously, when there is elective surgery, it is best postponed till euthyroid status is achieved. If, however, patient needs urgent or emergent surgery, one can proceed with surgery in mild to moderate hypothyroidism. So remember the data on mild to moderate hypothyroidism. If the surgery is emergency, one can proceed with it in the modern day technology. And of course, starting levothyroxine preoperatively is a standard of care. Severe hypothyroid is the only challenge where you might have a risk of myxedemic coma or severe complications. And if you have altered mentation, pericardial effusion, heart failure, or very low levels of thyroxine, then obviously we need to postpone this surgery. And this is something which is very clear. And even in severely hypothyroid, if surgery is mandatory, then we need urgent normalization of thyroid hormone levels, which can be done by IV levothyroxine with a loading dose of 200 to 500 micrograms, followed by 50 to 100 micrograms IV daily. And simultaneous administration of IV T3 can also be considered with myxedemic coma. Often, whenever we are looking at severe hypothyroidism, many a times you know that it's an autoimmune disease, and there might be pre-existing Schmidt syndrome, which is coexistence of adrenal insufficiency with hypothyroidism. And occasionally, glucocorticoids may have to be administered in stress doses, like 50 or 100 mcg of hydrocortisone 6-hourly with the thyroid hormone. So often this is all you need to do, unless or until you are in a severe hypothyroid situation. In most cases where there is an emergent surgery which is required, you can proceed with surgery. The only challenge which comes in is due to cardiovascular health, because people who need cardiovascular revascularization and they are compromised, that's a small subset. And remember that it's only in cardiac patients with angina where there is a real possibility of worsening cardiac ischemia by replacing the thyroid hormone. Because you know that when we start thyroxine and the myocardial oxygen demand goes up, as the myocardial oxygen demand goes up, cardiac patients with angina get precipitated. So all the data available from all the retrospective and prospective studies of cardiac patients undergoing revascularization, either through catheterization or angiography or cardiac surgery, they have not found that there is any increased rate of adverse event in those whose hypothyroidism has not been treated. So remember that if you have adequately pre-treated thyroxine, it is reasonable to proceed with revascularization procedure before depleting thyroid hormone. So that's something now very clear cut, that from the cardiologist standpoint, cardiac surgeon standpoint, one doesn't have to worry from a thyroxine standpoint. The bigger challenge and nightmare for a surgeon and endocrine surgeons and surgeons like you all is the complications of hyperthyroidism. And we know that elevated thyroxine is seen with thyrotoxicosis, and the most salient feature again is cardiovascular. It's predominantly the positive inotropic and chronotropic effects, and that thyroid hormone will have an impact on the heart. It will lead to vasodilation, it will decrease the systemic vascular resistance, and there will be sodium and water retention. And there will be clearly that activation of renin-angiotensin-aldosterone system, which can culminate in increase in cardiac output between 50 and 300%. The most common arrhythmia which we see in hyperthyroidism is the lone atrial fibrillation, and that can be the sole manifestation in masked hyperthyroidism. So often you might just get a person who has no symptoms, and you might just get a person with just urinary frequency and ECG showing atrial fibrillation. And clearly when you do thyroxine levels in them, you will see that TSH drop down, the T3, T4 may still be normal, and prevalence of atrial fibrillation increases with age. And that's the big challenge one has. Currently, there is no data, because the primary thing when you are doing surgery in hyperthyroid patients is optimization of cardiovascular status. And currently, you will not believe it, but there is no published data evaluating pre-op outcomes of hyperthyroid patients head-to-head when they are compared with euthyroid patients. So we have data on hyperthyroid patients on their pre-op outcomes, but we don't have data where hyperthyroid patients are compared with euthyroid patients. And obviously, precipitation of thyroid storm is a rare scenario. It is always a risk when there is tachycardia, confusion, fever, GI complaints, and you can get a cardiovascular collapse. So obviously, we always postpone elective surgeries in overt hyperthyroidism. But however, if there is mild or subclinical disease, simple pre-op beta blocker is all what you need. And this has been supported by a proper prospective randomized control trial, which shows that hyperthyroid patients undergoing thyroidectomy who are treated with just 5 weeks of metoprolol preoperatively had no serious intra or post-op complications compared in patients who were pre-treated for 12 weeks in a combination of methimazole and thyroxine to render them euthyroid. So clearly a small addition of beta blockers in RCT, because today we are in an evidence-based world, makes a difference. So for people with overt hyperthyroidism, for urgent and emergent surgery, cardiac status has to be monitored. One has to have an arterial or a CVP line is appropriate for evidence of cardiopulmonary disease if the patient is not hemodynamically stable. Beta blockers are the key. There is no beta blocker which has a superiority over others. Some cardiologists prefer atenolol, but metoprolol is the one which has data because it has better beta-1 selectivity, better tolerated in people who have reactive airway disease and asthma. It has a longer half-life which facilitates once-a-day dosing. However, because of thyrotoxicosis, its metabolism is accelerated, and total daily dose may be needed to be divided into 2 doses. 25 milligram daily may be used, and higher doses like 50 milligram, and one may have to go up to 200 milligram, which may be required. The commonest beta blocker which was used traditionally is a non-selective beta-1, beta-2 blocker, which is propranolol, which has a very short half-life. Therefore, you have to give it 3 to 4 times a day. But it has an additional benefit because the monoiodine type 1 enzyme for T4 to T3 conversion has been blocked. And it can be used IV, but we can also use IV ismolol to control pulse and blood pressure. And it also remember that because of its non-specific effects of the T4 to T3 conversion being blocked, it also decreases fever intraoperatively. Sometimes people who can't tolerate beta blockers, we can use calcium channel blockers, and calcium channel blockers have been reasonably used. And very rarely when calcium channel blockers and beta blockers are contraindicated, occasionally we use erazarpine or gonadotropin. So obviously the challenge is that we have 2 types of hyperthyroid diseases or thyrotoxic diseases which we treat. One is Graves' disease and second is toxic nodular disease. Very rarely we get, as surgeons, you will never get cases with exogenous thyroid hormone intoxication or thyroiditis. And therefore, first thing which one needs to do is institute anti-thyroid drugs. In thionamides, particularly we have propylthiouracil, methimazole and carbimazole. And all 3 are available in India. And all of them inhibit the production of thyroid hormone. Now we know that methimazole may achieve euthyroid state faster than PTU, but still it takes 3 to 8 weeks. And remember that we don't like to use PTU except first trimester of pregnancy because PTU is hepatotoxic. It has a longer half-life, and obviously something is not we like. So methimazole is now freely available, 20 to 30 milligrams, or carbimazole also is available. And usually both the drugs are given orally. Remember, all these 3 drugs can be also administered rectally in people who can't take it orally. Of course, PTU has more advantages because it blocks T4 to T3 just like propranolol does. And obviously both these drugs can have toxicities like urticaria, rash, arthralgia, fever, and very rarely you can get agranulocytosis. So this is something which we know. And these are all idiosyncratic agents. So these are very strong agents. Often, most people with surgery need beta blockers with thionamides at least for 2 to 4 weeks. And most people can be able to undergo a thyroidectomy because we know that this has to be done. Often thionamides have to be stopped post-operatively because the half-life of thyroxine is so long that it may necessary to continue beta blockers for a week. Or
sorry to interrupt you. Your last minute is getting over.
Sorry?
Your last 1 minute is getting over, sir.
Yeah, I will be almost done in a minute. Occasionally we can use lithium, and we also know to stabilize thyrotoxicosis rapidly, we can use inorganic iodide. We all know the Wolff-Chaikoff effect as well as the Jod-Bestow effect. And therefore, clearly we know that escape from Wolff-Chaikoff effect is anticipated for 10 days and treatment with iodine should not be started for more than 10 days preoperatively. So if at all you use iodine, whether it is potassium iodide, 1 drop 3 times a day, or Lugol's iodine 3 to 5 drops thrice a day, or if you use either hyponic acid, 500 milligram twice a day, that will use you to get faster treatment. Of course, we can always use steroids. We can use cholestyramine. And obviously, fundamentally, the current recommendation for American Thyroid Association is to use beta blockers, potassium iodide, glucocorticoids, and potentially cholesterol for immediate post-op period. As far as excessive use of thyroxine is concerned or thyroiditis is concerned, steroids and hyponic acids are the ones which are recommended. And remember, never forget to replace oral calcium and vitamin D, particularly in hyperthyroid states. That is a standard of care. So obviously, these are rare complications, but we need to be mindful of them, that they can be potentially deleterious and catastrophic. So what I have tried to do is try to cover them in a limited time, which is there. I know my time is up, so I think I'll stop here. If there are any quick impending questions, I'll be happy to answer them. Thank you very much for the opportunity.
Thank you. I would like to have...
Thank you, Dr. Shashank, for the elaborate talk. And we have one or two questions in the chat box. One was regarding IV levothyroxine being available in India.
It is not very easily available, but we do get it from Royal Chemist, both T3 and T4. T3 is more easily available than T4.
Okay. Thank you. If any questions, Prashant, feel free to answer in the chat box.
Sure.
We'll move on to the next speaker. Dr. MJ Paul, would you introduce the next speaker?
Yes, thank you. It is my pleasure to introduce Dr. Sabaratnam. Can I have his slide, please? He is a dear friend of mine who's the Secretary of the Indian Association of Endocrine Surgeons. And I must say that he has contributed greatly to the functioning of associations and many conferences. He's also a very keen academic and publishes strongly. He has improved services in his institute by leaps and bounds, and he has more than 200 articles to his credit. Dear Sabha, thank you for taking on this topic about the management of hyperparathyroidism. Please proceed.
Thank you, sir. Thank you for the kind introduction. Thank you, Niranjan sir and Dr. Ritesh ji for this opportunity as well. Today, I am an examiner for post-MCH exit exam. I have asked permission from the examiners for 20 minutes because this is a very important meeting. And this is my agenda for today: introduction, etiology of hyperparathyroidism, clinical manifestations, diagnosis of hyperparathyroidism, surgical and medical management. And coming, before we go into the subject per se, the function of parathyroid hormone is to maintain serum calcium levels. Parathyroid production is closely regulated by the concentration of serum calcium. And you all know that there are serum calcium receptor sensing genes which produce calcium sensing receptors. I will come to that in a minute. And what is primary hyperparathyroidism? Definition is hypercalcemic state due to disorder of secretion of parathyroid hormone. Because nowadays you have normocalcemic hyperpara and normo PTH hyperpara as well. And it is parathyroid, primary hyperparathyroidism is the most frequent cause of hypercalcemia in ambulatory patients. Prevalence is 1 per 1,000 men and 2 to 3 per 1,000 women. Nowadays, most of them are because of screening, routine screening for serum calcium levels. This is one of the most important slides. You can see 4 small parathyroid glands, 3 to 5 millimeters in size, which has calcium sensing receptors, and they sense the calcium levels. And these parathyroid glands secrete PTH, which causes increased bone resorption, increased renal calcium resorption, and increased GI calcium absorption, and thereby increases the calcium levels, and there is a negative feedback. And as I said, these calcium sensing receptors are present in renal tubules, the bones, the intestine, as well as the parathyroid glands. And they orchestrate the serum calcium levels. This diagram is important because we have one new drug called cinacalcet, which is allosteric modifier. And coming to hyperparathyroidism per se, primary hyperparathyroidism is due to autonomous secretion, whereas secondary is response to normal regulatory stimuli. You have one another entity called refractory secondary, which is non-suppressible secretion after correction of metabolic abnormalities. And tertiary is refractory secondary hyperpara with hypercalcemia. These are the definitions. And most of the times, primary hyperparathyroidism is due to a single solitary adenoma in 85% of the times. hyperplasia and multiple adenomas in 15% of the times, and carcinoma in 0.5%, and familial causes of primary hyperparathyroidism is very rare. You have in MEN1 type 1 and type 2A, and hyperparathyroidism jaw tumor syndrome, and one another entity called familial isolated hyperparathyroidism. And secondary hyperparathyroidism, it's mostly due to chronic kidney disease, where we have GFR less than 60 ml per minute, medications in the form of bisphosphonates, anticonvulsants, hydrochlorothiazide, denosumab, furosemide, and phosphorus, renal hypercalciuria, malabsorption syndrome, 25-hydroxy vitamin D deficiency, pseudo hypoparathyroidism type 1. These are the causes. And tertiary, it is mostly refractory secondary with the hypercalcemia, whereas a single gland becomes autonomous and secretes. This is the most important slide of hyperparathyroidism. Here you can see the calcium levels, phosphorus levels, serum calcium levels and phosphorus levels. In primary, serum calcium is high and phosphorus is low. Tertiary, both are high. In secondary hyperparathyroidism, secondary hyperparathyroidism, it can be normal or low, and phosphorus can be high.
So there is some disturbance.
Can you please mute, because some people are talking. So in secondary, it can be normal or low, and phosphorus is high. And urinary calcium will be high in primary hyperparathyroidism. This is very important because we have to differentiate with one another entity called familial hypocalciuric hypercalcemia. So this is a busy slide. Do not worry about this. Just concentrate on sporadic adenomas. These are non-inherited, mostly in the age group of 50 to 60 years. And one gland will be enlarged 20 times the normal size. It's monoclonal or oligoclonal, and very high cure rates of 95 to 98%. This is what we should understand. Majority of the patients will have sporadic adenoma. And what are the clinical manifestations of primary hyperparathyroidism?
Sorry, some background. Can you move it, please? Disturbing the speaker. Thank you.
Like the clinical manifestations include like abdominal manifestations in the form of constipation, indigestion, nausea, vomiting, peptic ulcer, pancreatitis, stones in the form of renal stones, nephrocalcinosis, polyuria, polydipsia, uremia, bone manifestations in the form of osteitis, fibrosa cystica, which will be exhibited in the form of subperiosteal resorption, osteoclastomas or the brown tumors, bone cysts, and radiologically you will have osteoporosis in the bone mineral density. Arthritis can be there. Psychic moans in the form of lethargy, fatigue, depression, memory loss, psychosis, personality changes, confusion, stupor and coma, and other manifestations in the form of proximal muscle weakness, keratitis, conjunctivitis, hypertension, and itching. So this was termed, this disease was termed the disease of the stones, moans, bones, and groans. And what is the trend now? Previously, asymptomatic disease was very uncommon. Nowadays, asymptomatic routine screen detected hypercalcemia is the commonest form of presentation. And if you compare the West and the East, in the East, you still see, in our developing world, we still see bone disease, osteitis, fibrosa cystica, palpable brown tumors, nephrolithiasis, and nephrocalcinosis. And these kind of PHPT patients have concomitant vitamin D deficiency also. This is very, very important because once you do not correct vitamin D deficiency in the post-op, pre-op there is a controversy whether you will correct or not. Post-op, at least if you do not correct, patients will have refractory hypocalcemia. And in the bones, you will have cortical bone is the most affected rather than cancellous and trabecular bone. And ultradistal radius is the bone which represents the cortical bone. So ultradistal radius will be the affected bone. And diagnosis of PHPT, this coming slide is also very, very important. You will have albumin adjusted calcium of more than 11 milligram per deciliter with normal renal function. And then you see whether it is a PTH dependent or a PTH independent hypercalcemia. So if it is PTH levels are normal or low, then most of the time it is non-parathyroid cause, malignancy, myeloma, vitamin deficiency, sarcoid, or immobilization. So you can do a PTH related peptide, and if it is high, it suggests malignancy likely. If PTH is increased, then you have 3-4 scenarios. It can be primary hyperpara or tertiary hyperpara. And then you have urinary calcium with creatinine ratio, which if less than 0.01, then it is familial hypocalciuric hypercalcemia. Still, we cannot exclude malignancy if PTH is high because dual pathology can coexist. Parathyroid, primary hyperparathyroid, as I said, incidence is 3 to 5 per 1,000 population. So it's not a very uncommon disease that we should understand. And what is the difference between familial hypocalciuric hypercalcemia as well as primary hyperparathyroidism is this one. See, as I said, most of the times PTH will be within the normal range, but calcium creatinine ratio, urinary calcium creatinine ratio less than 0.01, that is most sensitive. And coming to all these endocrine disorders, first you biochemically prove them. Then once you have biochemically confirmed, then you go for localization. Localization in primary hyperparathyroidism, it's using high resolution ultrasound, which is an anatomical imaging, which is 7 to 10 megahertz. You can localize up to 80% of adenomas, cheap, easily available, non-invasive, but operator dependent. If you have an endocrine radiologist who is doing only these kind of imaging, dedicated radiologist, then the sensitivity is up to 80 to 90%. And then you have a functional imaging in the form of MIBI scan, which will give anatomical some details, but functional, this one also, sensitivity is 86 to 90%. However, false positives can occur with thyroid nodules, sarcoidosis, lymphomas, thyroid carcinomas, and false negatives in the form of multi-gland disease and small gland. But if you combine both together and if it's concordant, then the accuracy of your localization will be around 95%. And most of the times you will get away with what is known as focused parathyroidectomy or a minimally invasive parathyroidectomy. This is a classical MIBI scan. You have early images and late images. Parathyroid, because of the increased mitochondria, concentrates MIBI, and in late images it will be there. I will show a case before I finish, so we will deal. And these are the sensitivity of ultrasound, CT, MIBI, thallium perticnate for adenoma, hyperplasia, and multiple adenomas. You can see that adenomas, most of the imaging. Now we have a new kid in the block known as 4D CT scan, which is both a functional and anatomical imaging with very high sensitivity and specificity. And that can be used if you have. And what approach of surgery is conventional bilateral neck exploration is there, where you open and see all 4 parathyroid glands, unilateral where you see one side of the neck, and minimal access approach where you see, where you just do the surgery with 2 centimeter incision. Nowadays in our institute, we are doing what is endoscopic parathyroidectomy in the form of BABA approach, transoral approach, and we are also doing robotic parathyroidectomy. But still in most of the part of the world, minimally invasive approach done by a surgeon who's trained in parathyroid surgery with the parathyroid, what we call a parathyroid eye, the eye to find an adenoma. Dopeman, way back in 1950s, told, he was a radiologist in Mayo Clinic, if you want to localize a parathyroid adenoma, first localize a good endocrine surgeon. So advantages of minimally invasive parathyroidectomy include less post-operative pain, less requirement of analgesia, lower consumption of analgesic, less scarring, great cosmetic satisfaction. And we always have an adjunct in the form of intraoperative PTH. That is, we do PTH levels before incision, before we excise the adenoma 5, 10, 15 minutes. And if there is more than 50% drop, then that means all functional parathyroid tissue we have removed. There are many criteria like Miami, Halle, Rome by cities. What we usually follow, what most of the centers follow, is modified Miami criteria. You can see the PTH falling like this. Then you can tell the patient we have cured you of the disease. And previously, the guidelines said if the patient is less than 50 years, T-score of more than less than minus 2.5, GFR reduced to less than 60 ml per minute. And then if you have a serum calcium more than 1 milligram per deciliter, we have to operate. As of 2021, the recent American Association of Endocrine Surgeon guidelines say if you have a parathyroid patient doesn't have contraindication for surgery, and if you have a good endocrine surgeon, even under local anesthesia, parathyroidectomy can be done safely, and it improves the quality of life and reverses all parameters. And how do you follow a asymptomatic patient with the PHPT? Serum calcium annually, serum creatinine annually, BMD, DEXA scan every 1 to 2 years, and preferably at the same center so that we can see the percentage of bone increase. And coming to the medical management of PHPT, drugs are there like cinacalcet hydrochloride, which I said is allosteric modifier of calcium sensing receptor. And then we have conjugated estrogen, medroxyprogesterone, raloxifene, alendronate. And here you can see this is the mechanism of action, calcium sensing receptor allosteric modification by cinacalcet. Cinacalcet is now widely available. And the thing is, yes, sir, I am just winding up. And if you see the response to cinacalcet, like with placebo, cinacalcet has a good calcium lowering effect. And just before 1 minute before, this is a classical 22-year-old female, was going on and off for 4-5 years. Then endocrinologist diagnosed her to have a hypercalcemia. She had a small 2 into 2 centimeter neck swelling also. You can see the classical appearance of hypoechoic shadow in the ultrasound, and a MIB scan showing retained uptake. And we did a focused parathyroidectomy under general anesthesia for this patient because she was apprehensive. And this was a parathyroid adenoma cured of disease, 3rd day discharged. And last slide, classical symptomatic parathyroidism is still common in India. Asymptomatic is also being increasingly recognized. And we have coexistent vitamin D deficiency also. And surgery is the only definitive therapy. Thank you, Niranjan sir. Thank you, Ritesh, for this wonderful opportunity. Thank you.
Thank you. Thank you, Dr. Sabha. It's very kind of you to bring us back to time with that excellent presentation, the overview of hyperparathyroidism. And as you said, the training of the surgeon in terms of technique, understanding of embryology and anatomy is very important, and the most important factor in success. In fact, the parathyroid excision has been described as the technically most successful procedure in terms of cure. So with that, we'll move to the next presenter.
Thank you, Dr. Paul. We will move on to our next speaker, Dr. Santosh John Abraham. Dr. Santosh John is Senior Consultant Head of Department of Surgery at Lord's Hospital, Panchalam, Cochin. Is surgeon at Pushpagiri Hospital and surgeon at various hospitals and Hospital of St. X-Cross at UK, surgeon Leeds General Infirmary, UK. He's a life member of Indian Society. And Dr. Santosh John Abraham will be talking on prevention and management of complications of thyroid surgery. Over to Dr. Santosh.
Sir, before you begin, my request to all delegates is if they have any questions, rather than raising hand, at least put it in the chat box, because it won't be possible for us to unmute all of you and allow you to ask questions directly. So please put it in the chat box.
Good morning to all of you.
Good morning.
I hope my slides are visible.
Yes, sir.
Yes, sir.
Right. So let me thank first of all Mumbai Surgical Society for having invited me to deliver this lecture on prevention and management of complications in thyroid surgery. As we all know, it is better to prevent the complications as it arise. I would like to deal with the complications in thyroid surgery as intraoperative complications. Where do we have bleeding from the superior thyroid vessels, middle thyroid vein, the small mediastinal veins which stretch over, the injury to the nerves, parathyroid, trachea, esophagus, carotid, thoracic duct, etc., etc. So to prevent the complications arising from superior thyroid pedicle, one need to know the anatomy well. As you understand, it comes from the top and then divides into two branches, the anterior and the posterior branch. Securing the vessels can be using ligatures. It can be by transfixion. It can be by harmonics. It can be by bipolar cautery. Very often, not very often, but ligatures are known to slip. The vessels retract and it bleeds. What you need to do at that point of time is to keep pressure, get good retraction, good lighting, good assistance, identify and secure the problem. So I just show you a clip where how the classical ligatures are being done. You dissect the superior pole. The artery and the vein are separately tied, and you divide after you put the two ligatures. Instead of this, you can have a transfixation as well in some of the cases. The same thing can be achieved by looking. I'm sorry. Okay, I'll move to the next slide. Same thing can be achieved by putting a bipolar cautery. Now let us see what if it gets slipped. Is it possible to do something in such kind of a situation? I think my video is. My video working?
No, sir, it's not visible.
I'll just go to the other mode. I'll just go to this mode so that I can work the video. So the second method for doing this, as previously being described, you look at the superior laryngeal nerve very closely, and then you can do a bipolar cautery. Bipolar cautery is as effective as a harmonics, but it is at a lesser cost. So one need to know how you do the bipolar cautery. You can actually safeguard the superior laryngeal nerve, do a bipolar cautery, and safely divide the superior pole. The first, you see the artery, and secondly, you see the vein. That's how you do it. Now look at how the slipped vessel can be tackled. For demonstrating that, we are actually deliberately doing a cutting of the superior thyroid vessel. See how this can be best managed. Whenever there is a bleeding, the first thing that needs to be done is don't panic. And you know how to control it. Best is do a pressure. Get your instruments ready. Keep pressure under pressure there. Get your assistants a good assistant. Now you expose after seeing the vessel, and this can be actually caught by the cautery or by an artery forceps and ligate. Don't panic at that point of time. So the most important thing is to have a good control of the situation. As you all know, middle thyroid vein is notoriously known for its bleed. This is because it's a straight short vein draining into the internal jugular vein, and it needs to be secured. And the way to secure it can again be by ligatures. You can identify the middle thyroid vein, pass a suture under that, take it, ligate, and between the ligatures, you cut as usual. That is the next way of doing things. The same thing can also be given a bipolar cautery. You can see it being dissected well. You can do a bipolar cautery there. It's just like any other vessel. Only thing is that you need to know what exactly you need to do. So there will be small mediastinal veins, particularly if the tumor is very large and if it is having a retrosternal extension. Lot of small veins would be stretched over the inferior aspect, and it is better that the fascia is very clearly divided after enough of coagulation so that we don't have any problem with the venous problem. Carotid artery is the next vessel that can bleed. It may not come directly under a thyroid surgery in routine cases, but there are thyroids which are malignant, which may have problems, and it may be very closely associated with dissection of the thyroid, the dissection of the carotid artery. This is one typical example where the tumor has gone actually behind the engulfing the entire carotid. It has gone beyond the carotid also. So one need to have a combination of very sharp dissection. This is not a malignant tumor. You can see that the adventitia actually comes off very easily, but one has to have a clear understanding and use good energy sources and sharp dissection. You get a clear plane between the adventitia and the tumor unless and until it is infiltrated. So one need to move forwards and clearly dissect it, and that's the way you dissect it completely. Here the vein had to be sacrificed, but the artery from the, you can see the artery aorta and the carotid artery coming up, and you dissect the entire thing without a problem. Now, what do we do if there is a problem? It is you can have a ligature of the bland, or you can have a coagulation, you can repair, or you can do a reconstruction, any of these things. Now, internal jugular vein on a similar note is well known to have an injury, particularly when you are going to do a neck dissection. Some of the veins can get avulsed if you are stretching too much. Some occasions we may have a tumor emboli to be dealt with. And this is one of the typical examples where how an internal jugular vein gets dissected well. You can see that we are doing a lot of bipolar cautery, and this is the small adventitial plane that we create between the carotid artery. And this is what the one on top is the internal jugular vein. And we are dissecting the vagus nerve away from the tumor. And you can see the internal jugular vein is full of tumor emboli. And this is a place where you need to remove. This is because the middle thyroid vein is bringing the emboli straight into the tumor embolus, straight into the internal jugular vein. And if you're not careful, you're going to create a problem. I just wanted to show you that it is nothing but the tumor thrombus. And the tumor thrombus, you can see it coming out of the internal jugular vein. I just fast forward the whole thing a little bit more. And that's the way you have removed the tumor thrombus. And you can see the column of blood here. And you really do not want the tumor thrombus to go down. So we dissect it completely, and we take the tumor thrombus out, and the internal jugular vein is, tumor thrombus, as you know, is not attached to the vessel. Very often, since it's a unilateral one, we can actually ligate the internal jugular vein. But it is important that you recognize this entity and do a good thing, so much so that the tumor emboli is not going downwards. So you can see the internal jugular being opened. We allow the blood to flow, and we are in complete command of the situation. We ligate and move away to the next level. Recurrent laryngeal nerve is another area where injury is very well known to occur. Till 80s, the teaching was don't look at the recurrent laryngeal nerve. When I was a postgraduate student, this was the dictum. If you look at recurrent laryngeal nerve, you will injure it. And we have all been trained in that era. Early 90s belong to the time the concept has changed to look at the recurrent laryngeal nerve. Late 90s onwards, we are doing tracing the recurrent laryngeal nerve. And I can vouch for certain that we can really swing on the recurrent laryngeal nerve without producing an injury. We can detect its branches, we can trace its branches, And the relationship to the inferior pedicule is the one which is going to be well known to all of you. It can either be over the inferior pedicule or behind the inferior pedicule, or it can be intermingled with the branches of the inferior pedicule. So one need to look at it in a very careful manner. And this was the era of, partial thyroidectomy. We were never detecting the recurrent nerve and putting the clamps alone. And that is not good at all today. Today, the entire recurrent nerve needs to be traced. While in the progress, you come across, if you are in the habit of tracing a recurrent nerve, I'm 100% sure that the seniors would have seen enough and more of non-recurrent laryngeal nerves, particularly on the right side of the patient when these things are well known to occur. The parathyroids is again an area where it can be found to have injury and devascularization. One need to have a deliberate look at the parathyroid, which is goldenish yellow in color. The upper parathyroids are more constant. The ischemia is more constant than its removal. Inadvertent removal is possible. If seen, well and good, you take it out. If it is not seen, always make it a point to look at the specimen on the posterior aspect and find that the parathyroids are removed or not. If there is a removal, the gland is to be minced. It's not just being sliced, it's actually to be minced into small particles and taken into a syringe and injected into the sternomastoid muscle or the medial part of the arm. So this is something which is has to be done. This is I think I'll, yeah. This is again showing the bipolar cautery, and you are going to trace the recurrent nerve. That's the way to trace it. And we maintain a plane medial to the recurrent nerve because the vasa vasorum is to be preserved. And you can locate the parathyroid, lower parathyroid there, and we dissect the area. And we use extensively bipolar cautery, and you always make a movement in line with the recurrent nerve. You can see the recurrent nerve coming into the view, and we use bipolar cautery instead of any other energy source. It comes handy. It doesn't have any added cost like harmonic scalpel. It is fine compared to harmonic scalpel, which is going to be very bulky in many of the situations. It is a good idea that we trace it up till it enters the larynx so that we don't produce any injury. As we, the same principle we adopt for looking at the external branch of the superior laryngeal nerve as well. You can here see the recurrent laryngeal nerve being dissected. You can also see the parathyroids coming into the position. Whenever you have an organ of Zucker candle, you will find the recurrent laryngeal nerve just underneath that. If the patient has got a recurrent thyroid, the way to go about is instead of from below upwards, it will be a good idea to find the entry point of the recurrent laryngeal nerve to the larynx, because those are areas which are generally not dissected unless and until they are being done by regular thyroid surgeons who are extensively experienced. So otherwise, these areas are generally not done. So one need to be very careful in dealing with the parathyroid as well as the recurrent laryngeal nerve. You can dissect the entire course and see it entering into the larynx, and you maintain in the most avascular plane. And bipolar cautery we use extensively for both dissection and coagulation. You need to learn the technique. Trachea, I don't get into major tracheal reconstructions, but a thin trachea is prone to get injured as cartilage is also thinned out. A cut injury can be directly sutured with absorbable sutures. It's a good idea to extubate the patient on the table because the integrity is good. Segmental loss or a planned removal can be a direct closure after mobilization of the trachea from both above and below. And tracheal reconstruction becomes a specialized job. by itself. So one need to be patient about this tracheal injury. Generally, it happens when you have a long-standing thyroid, and this long-standing thyroid has actually given rise to thinning of the trachea completely, and it is almost in line with the tracheomalacia. I think my computer is showing up some issue. I'm sorry about that. The next injury that is possible, let it get corrected. It's getting hung. The next possible injury would be to esophagus. Esophagus is one where in malignant lesions you have infiltration to the esophagus. Whenever you find the esophagus to be difficult to be located, put a Ryle's tube and try to protect the esophagus. Thoracic duct injury is also possible in large goiters with particularly retrosternal extension. And if you see a serous discharge, a watery discharge or a lymphomatous discharge, dissect and identify the thoracic duct, suture it before you leave, but still it can produce problems. Now, what problems do you have in extubation? The patient may be having a respiratory distress as a result often of laryngeal edema. It's possibly a long-standing goiter, and the anesthetist will have to take care of that with the non-invasive ventilation. Negative pressure pulmonary edema is again a possibility. Tracheomalacia, as we all know, it's as a result of a long-standing goiter, and this can be predicted by various methods. And if you suspect, you make an on-table assessment whether it is going. If the patient is found to have a tracheomalacia, please continue ventilating the patient. Bilateral when vocal cord palsy is another problem. Post-op, the patient can respiratory distress due to hematoma, tracheomalacia, or bilateral vocal palsy. If it's hematoma, make sure that you open it on the ward and bring the patient for control of this one. Sometimes the other issues that you see late post-op are the voice change. If you have detected that recurrent nerve, it will be a neuropraxia. It will come up. Hypocalcemia is not infrequent. It's already been covered. You give calcium, but resistant hypocalcemia, always look at magnesium and albumin and do that. And long-term hypothyroidism is a problem with the total thyroidectomy, and scar in the neck is yet another problem which can be solved by gentle dissection, etc., etc. But very often the scar and thyroid disappears in course of time. So these are the complications and how we prevent these complications while we do a thyroidectomy. I hope that I have stuck to my time allotted. Thank you very much, ladies and gentlemen, for a patient listening. Thank you, Dr. Paul. Thank you, Dr. Ritesh, for letting me share my few experiences with thyroidectomy. Thank you.
Chairperson, we have 1 minute, so we can take some questions.
I think we're out of time. So very nice presentation. The videos was very instructive. Thank you as usual. And I suggest we move on. We are 11:25.
Yeah, thank you, the chairpersons and the speakers.
Thank you, sir. Thank you, Chairperson, Dr. Rajesh Yadav, Dr. M.J. Paul, and the speaker as well, Dr. Pradeep, Dr. Sushant Joshi, Dr. Malivam, and Dr. Santosh Abraham, for your wonderful presentation. And let's move on to the third session of this talk. So we are moving to the again the invited lecture, and I would like to invite the chairperson for this session, Dr. Rajesh Prashant Kelkar, and let me introduce him. He is more than 13 years of experience in the field of oncosurgery. He has been part of a department of surgical oncology at Bombay Hospital, which runs a teaching program for DNB students, and he has been taking the lectures and demonstration for DNB students there. During his stint at Tata, during the Tata Memorial Hospital, which was a teaching post, he, along with his team, used to regularly conduct the classes for the undergraduate and postgraduate students. He has done more than 5,000 major surgeries and supervisory surgeries with low morbidity. He has 6 national publications to his credit, and his special interest in the hepatopancreatic biliary and gastrointestinal laparoscopic oncosurgery. He is a member of Royal College of Surgeons of Edinburgh. He is also a member of International Hepatopancreatic Biliary Association, He's also a member of the Asian Pacific Hepatobiliary Association, and he's also a member of Indian chapter of IHPBA. He's also a member of Indian Association of Surgical Oncologists, and he's a member of the Association of the Surgeons of India. So I welcome Dr. Prashant Kelkar. Another chairperson for this session is Dr. Naresh Rao. He is a founder and president of the Indian Association of Daycare Surgery. He is a president of 2020 for Mumbai Surgical Society, and he's the editor of Daycare Journal of India. He has a newsletter, One Day Surgery Times and MMS Time. He's the author Protocol of Daycare Surgery Center, and he's author Handbook of the Day Surgery. He's working at the Babulnath Hospital, One Day Surgery Center in Girgaon, Mumbai. And he's a member of the Association of the Surgeons of India. So I welcome you both, chairperson, to proceed for the session and introduce the speaker. Thank you.
Thank you, Sandeep, for that brief and nice welcome. I welcome you all on behalf of Mumbai Surgical Society once more to this bright and sunny day. And moving on to this third session, on behalf of my co-chairperson, Dr. Kerkar, I invite the first speaker, Dr. Ritesh Agarwal. Ritesh is a dear friend. I have known him for many years. And it suffices to say that he is a qualified endocrine surgeon in this part of the country. Ritesh, over to you.
Thank you so much, Naresh sir. Actually, it is an honor for me that a teacher introduces his student. Thanks a lot, sir. Am I audible?
Yes, yes.
Yes, Ritesh, you're audible.
My slides are visualized?
Yes, it's visible.
Okay, thank you so much. So today's my topic for presentation is open surgical approaches for goiter. First of all, I would like to acknowledge and give a lot of thanks to my God, my teachers, my residents, my supporting staff, my family, and last but not the least, my patients. Disclaimer, permissions have been taken from the patients for showing these photographs. Almost all photographs belong to my patients, few from other sources only. There is no conflict of interest and nothing to declare. Always at the beginning of any presentation, I would like to thank this gentleman, this great surgeon, the Nobel laureate, Dr. Emil Theodor Cocker. Whatever technique he has propagated, it is still being used, and I use his techniques till now. There are a lot of modifications being done by other surgeons, but the basic has been done by Cocker. He has proposed the technique of thyroid surgery which reduced the mortality from 21% to less than 0.5% in his career of 25 years. He discussed the technique of capsular dissection. He decreased the incidence of recurrent iliac nerve injury. And the principles, whatever he had laid, are still valid. Coming to the goiter. Goiter, a general definition is any abnormal enlargement of thyroid gland is known as goiter. Types of goiter can be classified by many aspects. Anatomical type, like diffuse or nodular. The nodular goiters can be multiple nodules or solitary nodular. Anatomical location by location in neck or location in neck plus chest, that is thoracic or mediastinal goiter, or mediastinal goiter alone. Functionally, the goiter can be euthyroid, that is thyroid function tests are normal. Hyperthyroid when there is elevation of T3 or T4 or suppression of TSH, or hypothyroid. Pathologically, after surgery, they can be found to be either benign or malignant. So there are a few pics of goiter. You can see the various kinds of enlargement in this patient's neck. Whenever there is a lateral neck swelling also in the presence of goiter, do not neglect it because it can be a harbor of malignancy. Surgery for goiter, the basic principles as for any other surgery. Make the patient functionally euthyroid. It is very important. Please do not take the patient when on table when he is hyperthyroid or hypothyroid, because there are a lot of chances of cardiac problems during surgery as well as problems while reversal. The preoperative evaluation must be thorough, and I am very much thankful to previous speaker Dr. Joshi that he has elaborated a lot that how to evaluate the thyroid functions before surgery and make the patient euthyroid. We must prepare the patient for sternotomy or other approaches to widen the thoracic outlet whenever we are dealing with large retrosternal goiters or mediastinal or thoracic goiters. we should be prepared with the lymph node dissection when we are dealing with malignant goiters. And a good anesthetist is a key person to our successful outcome. We can see this patient, a classical patient of Graves' ophthalmopathy with orbitopathy. The orbits are enlarged, the eyes have multiple signs, and there's a diffuse neck swelling, a very classical thing which we see usually in our in decades back. Our teachers have been seeing these things for many years. This patient was operated, a total thyroidectomy was done. The feeling was nodular, but it was a diffuse thyromegaly, and it was a diffuse goiter only. However, we should not always think that a diffuse goiter is benign always. It can be malignant. This is a patient of hypothyroidism, and there was no single nodule. The whole thyroid was converted into a nodular goiter, which is a diffuse sclerosing variety. So we did the complete malignancy surgery, total thyroidectomy with bilateral modified radical neck dissections and central compartment dissection. Multiple lymph nodes were positive for metastasis in this patient. This is a classical case of euthyroid multinodular goiter. Multiple nodules are seen in the neck as various bumps. And when we operated, we did a total thyroidectomy. It's just like looking like an embryo of the embryo inside the mother and like a fetus in situ. But it is a total thyroidectomy for multinodular goiter. As I already told, the nodules can be solitary. So solitary nodule surgery, see this the nodule plus isthmus and a part of pyramidal lobe. So this is a hemithyroidectomy, a classical hemithyroidectomy for a solitary nodule. One important catch here is this is a isthmic nodule. The nodule is in the isthmus only, not in right lobe, not in left lobe. And we did total thyroidectomy in this patient. Always remember, when the nodule is solitary and is present in isthmus only, there are high chances of malignancy in such patients. So we should be mentally prepared for dealing these patients as per malignancy only. Retrosternal goiters. This is a large vessel in the mediastinum, and the goiter is like a saddle over this vessel. So these kind of goiters can be taken out from the neck only. See, one part of the goiter, other part of the goiter, and in between the vessel was going. So if we do a proper mobilization, a good incision and flap raising, these kind of goiters can be taken out from the neck only, and there's no need for opening the chest or widening the chest. A very important catch here is the midline splitting of the strap muscles, especially in the inferior aspect till the suprasternal notch. Surgeons must remember that by doing this maneuver, they gain a lot of extra space, and it is easier to take out the goiter from the sternum, from behind the sternum in the retrosternal part. This is the same specimen. Again, if the goiter is present in the chest like this, surrounded by major vessels, still it can be taken out by neck, especially when it is not crossing the arch of aorta. We should be meticulous in dissection, a proper pulling from the neck upwards in the mediastinum, and slowly we can take out the goiter from the mediastinum. However, such kind of large goiters where the base is very broad. See, this is a thoracic outlet and the base is very broad, even much more than the thoracic outlet. So even after a lot of trying and manipulation, these kind of goiters are very difficult to take out from the neck. In such cases, we have to resort for either median sternotomy or some other maneuvers. In this patient, we planned for median sternotomy. Sternotomy was done. And here, see the size of the goiter, it was a huge one and delivered after sternotomy only. It was a multiple nodules, a euthyroid case. So coming to the types of thyroid surgery, hemithyroidectomy or lobectomy. This is a specimen of lobectomy. Lobectomy means removal of a lobe only. When lobectomy is combined with stomectomy and the removal of pyramidal lobe, it is known as hemithyroidectomy. This is the specimen of hemithyroidectomy where lobe plus isthmus is removed. Then comes the total thyroidectomy where we remove the both lobes of thyroid along with any other visible appendages like pyramidal lobe, tubercle, or any detached thyroid nodules. So total thyroidectomy is not the removal of thyroid lobes alone. It is the removal of all the appendages also like pyramidal lobe, tubercle of Zucker-Kendall, and detached nodules. This is a very important slide, and I would like all the audience to please focus on this slide. It was an excellent publication from my teacher, Dr. Gaurav. It was an evidence-based review, and I would like to request everyone to please read this review. This is how a paper should be written, published 15 years back, but still valid. Subtotal thyroidectomy versus total thyroidectomy were compared for multilodular goiters, and they found that subtotal thyroidectomy is associated with significant recurrence. There is an undetected thyroid malignancy which may require reoperation, and total thyroidectomy is safe in expert hands and is the procedure of choice for multinodular goiter. This is the most important slide for my presentations. Please see this. I can finish off my presentation here alone if you are able to grasp this thing. American Thyroid Association in 2015, the latest guidelines for thyroid nodules and thyroid cancers, they clearly mentioned removal of nodule alone, partial lobectomy, and subtotal thyroidectomy, where more than 1 gram of tissue is left behind, are inappropriate operations for possible thyroid cancer. Please remember this thing. They have abandoned the surgery of nodule alone, that is nodulectomy, partial lobectomy, and subtotal thyroidectomy. These are inappropriate operations for the possible thyroid cancer. We must always remember, whenever we are operating any patient for thyroid, there are always a hidden chance of cancer, even after extensive preoperative evaluation is done. So the important steps are, and here I am thankful to all my previous speakers and presenters who have shown such an excellent video for thyroid surgery. So my job is much easier and I can run a bit faster. So we do proper positioning and mark the incision. My patients' thyroid are always smiling. We deal with large goiters maximally, so we do not hesitate to cut the strap muscles, thyroid as well as, sternohyoid as well as sternothyroid. An important approach is lateral versus midline. Some of the presenters showed previously the midline approach, where they open the midline, divide the strap muscles, separate them, and then reach thyroid. This is one of the commonest techniques for reaching the thyroid still nowadays. However, lateral approach is where we approach the thyroid from between the sternocleidomastoid and strap muscles. We create a space between sternocleidomastoid and strap muscles and either divide the strap muscles or lift them up to reach the thyroid from the lateral side. This is the approach I commonly use. However, it depends upon surgeon to surgeon's preference and their ease of doing surgery. The lateral approach is especially important in the reoperative settings because if we go by midline approach in the reoperative settings, there's a lot of adhesions and the recurrent laryngeal nerve may get damaged, especially in the midline approach. We must remember this thing. We must give special attention to the superior pedicle. The medial space is known as the space of Reeves. We should give a special attention. Lateralization, this is holding the thyroid lobe. So lateralization of the thyroid relaxes our surgery and we are able to save the external branch of superior laryngeal nerve and we are avoiding injury to the superior parasite as well. This is a classical photo of tubercle of Zuckerkandl. Just behind this and engulfing it is the recurrent laryngeal nerve. It is the superior parathyroid. We are saving the superior parathyroid and removing the thyroid completely. Another important thing we must remember while operating, we have to identify the recurrent laryngeal nerve and not only identify all its branches and save all of them. We must not sacrifice any single branch of the recurrent laryngeal nerve because unfortunately the anterior branches are the motor nerves and they can cause, if damage is there, they can cause injury to the vocal cords. You can see the internal jugular vein by this broad arrow. Inferior parathyroid glands must also be identified and saved. Thank you. Just a quick case. In a classical multinodular goiter, we should not forget that there can be hidden malignancy also. Large nodules, but the malignancy was present in one of the smallest nodule, roughly 2 centimeters only, but with widespread metastasis. This is another classical case where a goiter is associated with chest swelling and skull swelling, a classical follicular thyroid carcinoma. Total thyroidectomy was done. Another important aspect, when Thyroid swellings are associated with primary hyperparathyroidism, especially seen in the toxic goiters. Toxic goiter was euthyroid, but developed renal stones. So calcium was done. It was found primary hyperparathyroidism with toxic multinodular goiter. A huge parathyroid adenoma was there, which was lying partially in the chest. So total thyroidectomy, and this is a total thyroidectomy and parathyroidectomy was done. Thank you so much. So last slide is coming on. Guidelines versus patient risk, we should discuss with the patient, give all the consequences of doing a procedure, whatever we are going to do, explain them complications and chances of recurrence, etc. We must educate patient and relatives to make a collective decision. And by doing this, we can avoid the complications also, because if we have done a good preoperative evaluation, we have an extremely capable team in the form of endocrinologists, physicians, anesthetists, etc. And we have a sound knowledge of normal thyroid anatomy and its variations. Thank you so much.
Thank you, Ritesh.
A wonderful presentation, Ritesh. Now, is Dr. Kerkar there? My co-chair.
Naresh, I think you continue with it.
Well, all right. So the next speaker is Dr. Malhotra. Let me have his slide. He's a radiologist, and he's going to, with a specialty on the breast and thyroid diseases, the endocrine basically. I will just quickly, it's a 15-minute talk, and then we'll take the question answers at the end of the session. There is a question answer chat box next to the chat box. Please put your questions there so that we can ask. Otherwise, we will. So there is one question by Suraj Pawar. I think I'll take it at the end of the session. Dr. Malhotra, please.
Naresh, I will interfere. It is a 10-minute talk with 2 minutes talk time, not 15 minutes.
Excellent, excellent. So the things are much more clearer. Dr. Malhotra.
Yeah, thank you so much. Can you hear me?
Yes, yes. Your slides are visible.
Great, great. Yeah, that's great. Okay, thank you so much. At the outset, I would like to thank Mumbai Surgical Society for inviting me to talk on this topic in this August with audience. And I am basically a nuclear medicine physician by profession. And see, nuclear medicine has so much to offer, even when we talk of thyroid, but I thought I would concentrate only on the issues that which are the basic needs of our referring clinicians here, and have curtailed my slides to a lot of extent. And basically, I'll be talking about nuclear medicine as a functional imaging concept. Then second, we'll go on to radioisotopes in thyroid imaging, technetium-99m, iodine-131, and others. And then radioiodine therapy in thyrotoxicosis and thyroid cancers. And finally, does radioiodine treatment lead to increase in risk of solid tumors if the time permits? Nuclear medicine is a functional imaging, and how does nuclear medicine work? It's by knowing the distribution of radioactive compound, which is imaged with some form of detector, whether it is a SPECT camera, gamma camera, or by a PET CT. But basic concept is same. It's the open source of radioactivity that is injected within the patients, injected into the patients or taken by oral route, and then these images are acquired. And now,
sorry to interrupt, sir. Pramesh, can you mute the background noise, please?
Yeah.
Carry on, sir. Thank you.
Yeah. Okay. So as we see, there is this is the functional imaging part, which is not showing much structure. And here we have it is somewhere in the retroorbital region. And if we combine both, what we get as fusion imaging, what we see nowadays as SPECT CT or PET CT or PET MR imaging. Now, what are the radioisotopes that we use in thyroidology? Most commonly that you people all know about is technetium-99 and pertechnetate, which is the workhorse of nuclear medicine, iodine-131, iodine-123. Iodine-123 isotope is not available in India. It's expensive, cyclotron produced. And then there are non-specific tracers such as cysteamine, pentavalent DMSA, and now even DOTA scans are there. This table compares the three isotopes, two commonly used isotopes, pertechnetate and I-131. And And I want to draw your attention to this part of the table that technetium-99m is a short and sweet scan. It's a quick scan. The imaging characteristic of technetium is much better than iodine-131 and much more favorable. So, and it is widely available. Even iodine-131 is widely available, but iodine-131 has beta component, which is used for therapy. Iodine-123 is the preferred one, but it's not widely available. And if you see these two scans on the left side, this is the technetium scan, and you can see the body contour, the contours anatomy can be seen. Other areas are much more visible, while if you look at the iodine-131 scan, it looks more grainy, and there'll be more increased background kind of a thing. So we need to have a lot of markers in iodine image at suprasternal area and other areas to better define the scan. And as had been told by earlier speakers, we use indication for a nuclear scan is suppressed TSH. And I will show you the in coming slides. These are the other indications: solitary thyroid nodule, where you want to know the functional information, ectopic thyroid, agenesis, and others. Now, this is not a routine kind of a thing that we would go for. If we are seeing a nodule, we would not go for a technetium thyroid scan unless TSH was suppressed. But this is a normal scan, and this is how a cold nodule looks on a technetium scan. A cold area is seen in the right lobe, and this is a commonplace scenario where a technetium scan is done, where there is suppressed TSH, and you can see in this, there are four kinds of patterns that we may see. We may see a Graves' disease, diffuse toxic goiter. We may see a multinodular goiter with areas of hot nodule interspersed with cold areas. We may see an autonomic functioning nodule, and or we may see a thyroiditis-like picture where by doing technetium scan, and these things have to be distinguished for further management. Is there a role for a functional scan in multinodular goiter? Yes, there is, especially when we look at this. These are three hypoechoic nodule in a sagittal image, and you can see the third nodule is the one which is having very low uptake, or it is functionally very low scan, and the hypocold area. This is where an FNA should be done to get a better yield if there is malignancy in this. Then in congenital hypothyroidism, especially for dysembryogenesis, this is a technetium scan is useful. We are not seeing the normal thyroids, but we are seeing only thyroid at the ectopic location. Then this is the iodine scan showing a huge retrosternal extension. I would like to contact the surgeon for it. Whether even if patient is toxic, we will go ahead, make them euthyroid. This is the surgeon's job. Then coming to radioiodine therapy in thyrotoxicosis and thyroid cancer, when radioiodine was used in 131 mixture, which was used at Massachusetts General Hospital to treat Graves' disease, and basic mechanism of action is the beta particles. Iodine-131 relies on this. It causes local inflammation and fibrosis. But more than that, it is not only the accumulation, but it's also the retention of iodine long enough in thyroid, which has to be there to deliver enough radiation dose. And obviously, pregnancy and lactation are absolutely contraindicated. And in patients in whom there is thyroiditis, these are self-limiting conditions. They don't need radioiodine. And there have been dosimetric and empirical approaches, but there's not much difference between the two in the outcome. And coming to capsule versus liquid formulation, again, from the patient's perspective, it's not much different. But from the physicians or consultants' perspective, from the radiation giver perspective, with liquid formulations, we get much more radiation dose than solid formulation. This is just to show we follow the basic principles of time, distance, and shielding to protect ourselves so that we achieve lesser dose. And these are specialized areas where radioiodine is administered, and these are negative chambers, negative air chambers, and iodine is a volatile compound, and this is known as fumode, and this is how it is administered in these patients. Thyrotoxicosis patients do not need indoor admission. However, CA thyroid patients need indoor admission and monitoring, and in specially designed radionuclide wards. and they need hospitalization, monitoring, and when the permissible level is achieved, only then we discharge these patients as per the Atomic Energy Regulatory Board limits. And coming to radioiodine in thyroid cancers, we can see that it's a combined job. Once we get patients who have undergone total thyroidectomy, we have our own protocol. Like that, every institution should develop their own protocol. We need a TSH of more than 30, so the patients are off L-troxane. They are not taking any thyroid containing compounds. These are the slides given courtesy Dr. Ritesh. This is he's already shown in his previous presentation. We need to know what kind of surgery has been done. We to determine the residual thyroid tissue, we need to do the post-operative scan. We need to know if there is any metastatic disease and suitability of radioiodine. And we have to ensure that patient is not taking any iodine-containing compounds, and these restrictions have to be followed. Obviously we are using the TNM AJCC. I'm not going to details of this, and we are between the AJCC 7 and 8, but definitely we need to know if there was an unresectable tumor, like as shown in this slide, versus a resectable tumor. And we know if it is not a R0 resection, we are going to treat with radioiodine, how much radioiodine is to be given, and likewise.
Sorry to interrupt, sir. So we have to cut short the discussion.
Sorry?
Your time is getting over, sir.
Oh, yeah, yes. I'll just take I'll show a few more slides. I'll not go into the last part, which I had planned. Okay, so there is initial surgery. There is a focus, some multifocal uptake we are seeing in the thyroid bed. When we have treated this patient, when we do a follow-up scan, we see there is complete residual remnant ablation. Then we have to be bothered about this recurrence part. And this slide shows, a diagnostic scan. After diagnostic scan, when we have done a post-therapy scan, we do not, there is a lot of lung uptake. So post-therapy scan is very necessary. This patient has shifted from low risk to intermediate risk. Then we have to be, in many times in PET scans, we see focal uptake in thyroid. We have to be very careful, almost like 30% nearly nodules. These can be malignant. These have to be worked up. This is the slide I had kept for this purpose. Then this is an iodine scan showing uptake in the nodes. However, I may be tempted to give radioiodine. I would first go and ask for a surgical opinion. If they remove it, nothing like that. If this was done in this case, it's a surgical disease. Then there are patients who present with metastatic disease, excessive metastatic areas. Radioiodine is used for palliative care. Nevertheless, it is very helpful. And even without achieving a TSH of 30, we are able to do these scans. We simultaneously follow them up with PET scans. This is the same patient to see the extent of disease. This is another patient with extensive metastatic disease on iodine 131 scan, and we have cumulative dose is achieved. We cannot go beyond 1 curie. So we had done gallium dotatate PET scan and found that gallium dotatate was concentrating. So we can use these. And then recently gallium PSMA we have shown in metastatic disease, it is very helpful. And especially in tennis cases. And this is the area that we are further exploring. This we can see that this is the, I'll just go on to conclusion straight off after trying this.
Thank you.
Okay, so this is where even FDG was not concentrating, and you can see that it was PSMA uptake. So this is the area we want to explore. Again, a dotatate scan with in a medullary thyroid cancer, you can see serial lutetium dotatate therapy in a stable disease or a progressive disease when we are in MTC. And finally, coming to my slides of take-home points. Functional scan provide valuable pathophysiological information guiding patient management in addition to biochemical and structural abnormalities. And radioisotopes in thyroid imaging have theranostic implication. Radioiodine therapy is here to stay and benefit much more. It does not lead to, I have not shown the details of that, but you can take this point home that radioiodine treatment does not lead to increased risk of solid tumor, secondary hematologic malignancy, and contemporary management demands an individualized approach based on initial and follow-up evaluation. Thank you, and sorry for exceeding the time slide.
Well, Dr. Malhotra, I would request you and Ritesh both to have a look at the chats that are there, the questions there, and please take time out to answer those. Just a comment, I don't think we have time to take questions now. We'll move on to the next session. And just a comment. See, this is a forum where we are looking at the practical aspects. We are already practicing surgeons and some PGs who are completing their training, including the cosmopolitan, metropolitan cities and the second-tier cities. Whenever we do a presentation, we should keep in mind that, what are the investigation modalities available, what is necessary and why. The take-home message should be crisp and absolutely brief. That is my comment. Otherwise, the questions are there. Dr. Khanna, Suraj Pawar, they're all there on the chat groups asking questions. Please answer them. That's my request to you. And now I hand over to Sandeep.
Thank you, sir.
Take over to
Sandeep, I would just like to congratulate Ritesh and Dr. Malhotra both for an extremely lucid and detailed presentations. Wonderfully done.
Thank you.
Thank you so much, sir.
Yeah, let me thank the chairperson, Dr. Prashant Kelkar, Dr. Naresh Rao, and the speaker, Dr. Ritesh Agarwal and Dr. Malhotra. So thank you for this lovely session. Let's move on for the next session. So our next session is it's a panel discussion, and I would like to invite the moderator for panel discussion. So Dr. Deepak Abraham and Dr. Mahadev Garale. So let me introduce Dr. Deepak Abraham. Dr. Deepak Abraham is a professor, Department of Endocrine Surgery, Christian Medical College, Vellore. He's a PhD from University of Sydney, 2011. He's an Endocrine Oncology Fellowship at Sydney. He's a Best Teacher Award, CMC Vellore. And he's an invited guest lecturer in AAC 2019 annual meeting. And he's a special interest has in thyroid, parathyroid, and neuroendocrine. Or another, the chairperson, I welcome Dr. Abraham for session chair. Another chairperson, Dr. Mahadev Garale. He is a laparoscopic and endoscopy surgeon at GS Medical College and KM Hospital. And he has got the publication on parathyroid adrenal insulin. I welcome both of you to the session and proceed for panel discussion. Thank you.
Yeah, can you hear me?
Yes, sir.
Yes, we can.
Okay, thank you. Thank you to the Mumbai Surgical Society and to the friends in Mumbai as we take part in this panel discussion. Ritesh, especially for giving me this invite. Mahadev and I would be using this to present two cases for each about 20 minutes. And we have directed questions to each of the panelists. And that would be the pattern so that we try to finish on time. Before we start, I'd like to introduce the panelists. First is Dr. Vikram Sanghvi. He's a senior surgeon from Mumbai, works at Bombay Hospital, Raheja Hospital, Breach Candy. We've met him at various other fora, and we look forward to his wisdom as we take part in this panel. The next panelist in the group is Dr. Sudeep Sarkar. I don't know whether he's on this meeting. We heard that there was a family emergency which he needs to be attending, but if he's here, we would use his wisdom too. And he is a practicing surgeon from Balawai Nanavati Hospital. And the next person on the group is Ameya Joshi. He is an endocrinologist and a person who would be adding a lot of value to this discussion because not only do we operate, but we need also inputs from our endocrinology friends as we manage patients with complex thyroid diseases. And Ameya is an endocrinologist working in various hospitals, but I think his main hospital is Bhaktivedanta Hospital. Next is Murad. Murad is a close friend of mine, and Murad is an oncologist from PD Hinduja National Hospital. And Murad, what I can tell you about Murad is one person who has climbed the Mount Everest twice. So that is something which keeps him set aside. And finally, we've got the next on the panel is Anand. Anand also is a close friend of mine who heads the Department of Endocrine Surgery at KGMU, Lucknow. And he will definitely bring in a different twist to the whole discussion as we go ahead. With that, I'll go to the first case, and may I be able to share my slides, please?
Yes, sir.
Okay, can you see my slide? Yeah.
Yes, sir.
Yeah, okay. So the first case is a benign thyroid disease, and then we would do one with malignancy. So without much ado, I'll start off, and that this is a patient who presented to us in 2016. It was a 32-year-old male who presented with the classic symptoms of hyperthyroidism, which started in the March of that year. Following that, he developed he noted a swelling in front of his neck, which typically puts this as primary thyrotoxicosis. And then on examination, he was obviously toxic, pulse rate of 126 per minute, and tremors were fine.
You are not audible.
Is it? The rest of you?
I can clearly hear.
I can hear.
All good.
Audible, sir.
Yeah, okay. So maybe Anand, it's at your end, you need to just look at. So he had a particular feature of thyroid acropathy, and maybe I'll ask Ameya to speak on that a bit, and I'll talk about the clinical activity score, and I've got questions for Ameya for that too. Now, to you, Ameya, the first question is, could you elaborate on what this clinical activity score is, as opposed to what surgeons mostly know about various eye signs which have been described with names? But I think what is more clinically relevant is actually the clinical activity score, and I'd like Ameya to speak.
Yeah. Thank you, Dr. Deepak. First of all, really wonderfully crafted case. I mean, secondly, I mean, a very, very well planned. So I'll try to cover the learning points. And at the outset, I would like to thank Dr. Niranjan Agarwal, sir, and my close friend, Dr. Ritesh, for giving me this opportunity. When you talk about hyperthyroidism, and then you focus on something called as Graves' disease, which is an autoimmune hyperthyroidism, the antibody and the Graves' disease come associated with two more complications. One of them is an eye disease, and another are the dermatological, or what I would say, connective tissue manifestations, which includes dermopathy and acropathy. Coming to eye disease, because acropathy and the dermopathy are not relatively common in Indian population, but what is more common than Westerners or Caucasians in Indian population is thyroid eye disease. When you see hyperthyroidism with thyroid eye disease, you think of Graves' disease as a causative factor, even on the background of a multinodular goiter. When you think of thyroid eye disease, you assess for inflammation, and that is a clinical activity score that Dr. Deepak has displayed. And if you find any three out of them present, we call this an active eye disease. By active meaning that we need additional therapeutics for the eye in specific. And then whenever we follow up, we always ask the patient or try to measure whether the eyes have become more prominent or there is a visual problem. Because if anything has came up as a new, irrespective of this score, you need more aggressive assessment, maybe an MRI, and maybe and sort of anti-inflammatory therapeutics. The second thing that I would like to highlight is in the presence of a large goiter and presence of a significant eye disease, or I would say relatively large goiter and a significant eye disease, we are scared to give radioiodine therapy. And that is one place, I mean, in Graves' disease, there are three treatment options, and we need to refine them for the patient also. And this is one place where we prefer, if the patient has not responded well medically, then to consider surgery. So these are possible implications of thyroid ophthalmopathy.
Yeah, okay. I think that brings us to the point that, yeah, the score cutoff is 3. And if you've got a score cutoff of 3 or more, then you've got clinically active disease, and you need to pay attention to the eye, and that needs to be addressed primarily too. Then the next is about the eyes. These are just the pictures to show you what these signs are. And I'm sure that this will be available as a presentation to you, to the participants who are attending. Now, I'd like to ask Anand. Anand, you know, very often there are a lot of questions about names and name signs. Would you like to name a few? And I've got them listed out here. Anand, you're muted. I don't think we can hear you.
Yeah. Sorry. So, in Graves' disease, there is more sympathetic drive. So, the muscles which are supplied by this sympathetic, they are more active. So, where obviously you have shown some sign, von Graffi's
So
sign. There is
I think you can
lack.
stick to 3 of them. Stick to 3 of them, which you think.
So,
what you use.
von Graffi's sign is one of the signs. Geoffroy's and I think Dalrymple sign, widened
Yeah.
palpable fissure during fixation.
Sure.
When
Okay.
you're looking at the patient.
The reason I put this up is that because very often in the surgical exam, this is a question asked to candidates in the general surgery exam. But honestly speaking, the clinical activity score has more relevance and prognosis, whereas these are more signs which can be demonstrated and needs to be looked at, especially from a perspective of management or diagnosis of a patient. Now, this patient actually had a fairly large goiter, and Ameya briefly mentioned that you've got a large goiter and you've got prominent eye signs, or you've got clinically active disease. You then want to call the surgeon into the role of managing this patient. And this patient had a classical thrill and a bruit, felt at the superior pole, which is primarily where the superior thyroid vessels come in. And Ameya, what would you do now if this patient, say, active eye disease, big gland, and fairly large, fairly active in terms of pulse rate being high? How would you proceed?
Yeah, I think just for the sake that I understood, there are a lot of students who have joined. And one of the important questions is, what is hyperthyroidism and thyrotoxicosis? Hyperthyroidism means the source of thyroid hormone excess is the internal thyroid gland, whereas thyrotoxicosis may have internal thyroid gland production or external source also. To confirm hyperthyroidism, essentially biochemical confirmation is done by T3, T4 and TSH level, and you expect the T3, T4 to be high and the TSH to be low. The hallmark of Graves' disease is a selective T3 toxicosis. And since the patient is clinically toxic, you also need certain more investigations. What add value are an ultrasound and a TC uptake scan or a thyroid scan. Ultrasound because it does tell you whether there are additional nodules, and it has been more and more recognized that malignancies are not unknown in even Graves' disease gland. Recent studies from Dr. Susan Mendel's group has confirmed that. And TC uptakes can obviously will tell us how highly active is the gland, are there any focal areas, and is there any asymmetry in the uptake.
Okay, so I think I'll just go through what we have. And this is the patient's profile. And you can see his antibodies were elevated and frankly talks with a free thyroxine concentration of 4.16. When in 2016 he first presented to us, we did not have TRAB available, and that is thyroid receptor antibody, which is now available with us for our management. And so we didn't have a baseline value, and we also did a thyroid uptake study. The other issues were the thyroid uptake scan, as mentioned by Meya, was also done, and we had an uptake which scored 66% at 24 hours. So actually amenable to nuclear medicine treatment or radioactive iodine therapy, but because of the prominent goiter and also the eye signs or the active eye disease, he was taken up for surgical treatment. And so I'll move on to that. I'll bring in Dr. Vikram Sangvi. Would you do an ultrasound for all patients with thyroid, with Graves' disease? Would you do that before you operate? That I just like to hear differing opinions. Dr. Vikram? Okay, if Dr. Vikram's, okay.
It definitely I will go ahead for sonography, ultrasonography, to know so many things. Important messages I can get it from the ultrasonography. It's a diffuse, bulky thyroid, heterogeneous, hyperechoic nodules can be seen with increased vascularity. And sometimes, as Dr. Joshi has already said, that malignancy also can be associated, and we can get the definite definite information about the neck nodes also along with, which
Sure.
may be lesser important, but it is important.
Yeah, I think that the point taken is the fact that if you suspect that the nodule or there is an area which, apart from the diffuse goiter, there's an area of hardness and it's a discrete nodule, then you are suspecting that there is a possible associated malignancy. And not only are you looking for the nodule, you're also looking for nodes. And so what did we do with this patient? We actually went on to manage him medically upfront. And Ameya, would you like briefly, very briefly, tell us what would you do when you are seeing this patient in terms of medical therapy?
When we decide to put the patient on medical management, and all hyperthyroid patients essentially should be stabilized first before you take a call on what to do next. Ideally, the patient should be given antithyroid drugs and beta blockers, which are a must. Of the antithyroid drugs, there is definite merit for considering methimazole or carbimazole, and don't give it in homeopathic doses. I mean, a lot of times I see given 5 milligrams neomercazole for a large goiter with uptake like this. And I mean, if you have a thyroid hormone that is more than twice elevated, there have been 2 landmark articles, one from JCM, one from Clinical Endocrinology, published in 93 and 96, which said that if you have more than twice elevation, be bold enough to give 30 to 40 milligrams of carbimazole or methimazole. You want the patient's hyperthyroidism to be controlled as soon as possible. Similarly, it's good to add or must to add beta blockers. PTU and lithium have the select roles, and we don't prefer them as first-line medications. And obviously, you need to monitor CBC and, if possible, an SGOT, SGPT in this.
Just quickly to say, why did you do a CBC? Just for the
So here we start on a really good dose of neomercazole.
And how would you give it? How would you give it? On a spread out daily dose, or you do a once daily dose?
Yeah, it's a relevant question. So I'll answer both of them. First is we give it on once a day basis, because even if the serum concentrations of neomercazole may not be uniform throughout the day, the intrathyroidal levels needed to suppress the thyroid hormone synthesis, even if given once a day, are enough, are significant. Secondly, the compliance has been found to be much better when carbimazole is given once a day. The second part of the question was
in terms of what side effects. Why do you do a CBC?
So the common 2 side effects that are rare, fortunately, but seen are agranulocytosis or cytopenias and derangement in the liver function. Now, the hallmark of this is, if you are going to get them, you usually will get them in first few weeks of administering. And so it is always better, though not universally recommended. Let's still say that screen verbally whether the patient is having an infection, whether there are any signs of jaundice, and then only do. But safer, at least for practicing surgeons, to get a CBC and SGOT, SGPT all taken together won't cost more than 250 rupees.
Sure. Okay. So I'll bring in another aspect of this patient. This is actually a patient who we managed, and this is one aspect which many may not understand can happen. And I'd like Ameya to still be on this and to say, this person, while on treatment, presented to the emergency with sudden onset weakness of both lower limbs, and he was unable to get up and walk. So what do you make of this?
I would like to give 3 important differentials of this particular condition, because he has came, and we have not yet totally examined, but he has came with sudden onset weakness and both lower limbs. One possibility is that hyperthyroids are much more likely to have fractures, and this can also be there because of osteoporosis. The second possibility is obviously of hypothalamic periodic paralysis that is common in hyperthyroids, and the third possibility that we must keep in mind is myasthenia, which is common.
Sure.
So maybe we can go to the further evaluation. Yeah.
So what happened was, actually his electrolytes were, potassium was on the lower side, his bicarb was low, and we skipped the time for time constraints. Just like to highlight that this person actually had a periodic paralysis. those known to be associated with Con syndrome, this is something which we should be aware of patients who come to us with thyrotoxicosis. So we actually went ahead and corrected his electrolytes, and he got better. But for some reason, he defaulted and he left till he returned back to us in 2020. There he had a weight gain of 10 kgs, constipated, grossly hypothyroid, and still the goiter was there. And at that point of time, I just bring in the fact that his TSH was high, his FTC was low. And what would you then do in terms of treatment of this patient preparing for surgery, Amir?
Yeah, I think this is a common scenario that patients of Graves' disease, they just become better and default from treatment. And this fellow actually is a deserving candidate for surgery. Now here, toying block and replace is not a common therapy that we use, but in this patient, toying too much and spending too much of time in stabilization and titration was not a good idea. A block and replace should be given, and in such a situation, I would just defer about giving maybe beta blocker on a frank hypothyroid patient, because these people may have bradycardia. It's wise to start thyroxine first, get the free T4 from low to mid normal range on the back of carbimazole, which again probably can be continued to be a block, and then thyroxine. Titrate it, maintain, you can easily get it in another 7 days, because even if TSH takes time, free T4 stabilizes in 7 days, and then consider beta blocker as the need be basis. Also important to parameter, just one take home message for all surgical fraternities: do check for coagulation parameters, because our department at Nair has presented this, that derangement in coagulation parameters is quite common when you look at autoimmune thyroid disease like this.
Sure. Okay. That's good. And this is what he had. And then he was stabilized and his FTC went up to 1.68. And we went on to decide for surgery, which was what was planned earlier too. So Anand, would you like to come in now and tell us what are the indications for patients with Graves to undergo surgery?
A patient who has a very large goiter, has compressive symptoms, is an indication for surgery. Then if associated nodule is there, which is suspicious or has a proven malignancy, in those patients where antithyroid drugs is contraindicated, like there is intolerance or recurrence after antithyroid drugs. In some patients, antithyroid drugs are even contraindicated, like certain situations like pregnant women or nursing women, or whereas there is very relatively low uptake on radioactive iodine, those are contraindication. If there is an associated disease, conditions like Graves or orbitopathy, which we were discussing, or periodic paralysis, it becomes an indication for surgery. There are certain age groups, pediatric age group, or patients who is pregnant, where we want an early control euthyroid status, that becomes also an indication. And last one is we have to consider the situation of cigarette smokers, because they have a risk of eye disease.
Sure. Okay. So I think if there's a take-home slide in this segment of this case, it would be this about who you choose to operate on. And the next would be to bring in, okay, Murad, would you, how would you plan definitive surgical treatment?
So this gentleman definitely from the beginning was the ideal case for a candidate for surgery. Now in surgery, first the endocrinologist would have to prepare this patient. So try to make them euthyroid or as euthyroid as possible. And provided there are no immediate concerns for surgery where we have to rush into surgery, ideally I would like to have a euthyroid patient taken up for surgery. The definitive treatment for this would be a total thyroidectomy, but there is controversy about whether we should use Lugol's iodine in preparation for the surgery preoperatively. There are some people who advocate it, but quite frankly, if our patient has been optimized for surgery, we are not routinely using Lugol's iodine or SSKIs. We usually keep this Lugol's iodine or SSKI for people who are very likely to get into a thyroid storm situation. but otherwise not as a routine that I would subject my patients to Lugol's iotine preoperatively. In
Sure.
case you have to give it, it would be about 5 to 7 drops twice a day for 10 days, 7 to 10 days preoperatively.
Sure. Okay. And
sorry, can I just add one more pre-op preparation for these patients is most of our patients are vitamin D deficient. So I would use the time that they are optimizing the patient to start calcium supplements and vitamin D supplements, so that would mitigate much of the complications post-operatively.
Sure. Okay. Thanks so much. And Dr. Sudeep, are you on? I mean, if not, somebody else could take this on. What extent of operation?
So as I mentioned, the surgery would be a total thyroidectomy. I think it was made amply clear earlier in one of the talks that we don't do a subtotal thyroidectomy nowadays. So if we are operating on these patients, if it's a diffuse goiter, a total thyroidectomy would be the surgery indicated.
And for surgery for Graves, anything specific, which as opposed to doing a multinodular goiter or a cancer?
Yes, we do anticipate a hypervascular gland, but I think we go in with our eyes open, so we just take extra precaution to keep it as bloodless as possible.
Sure.
The use of energy devices, whether you want to use a harmonic or any other device, is personal surgical preference. I think most importantly is good hemostasis and critical care for either ligating or coagulating or clipping these vessels.
Yeah, so this is what we had actually seen for this patient. And you can see that we actually cut his muscle and we did use a ligature for that. And his gland was we had an uneventful surgery. So with this, we'll stop with this case and come to the discussion of this later, after we have Dr. Mahathir presenting right now on a particular thyroid cancer, which I call the 2 to 5% cancer, which is medullary thyroid cancer. And though it would have been more ideal to have a differentiated thyroid cancer as a more, the common case, but we would present this to bring about the nuances of management of thyroid cancer. Over to you, Mahathir.
Thank you. Yeah, you're seeing my slide?
Yes, go ahead.
So my case first is a 23-year-old lady, primigravida, but detected to have hypertension at 12 weeks of gestation during routine antenatal care. During routine antenatal care. So on inquiry, she complained of paroxysm of palpitation, diaphoresis, headache, and dizziness. Looking at this scenario, Dr. Amesh Joshi, I want to ask you, what is in your mind? Dr. Amesh Joshi.
Yes, thank you, Dr. Mahathir sir, for the beginning. And see, there are two things that cross the mind. One of them is definitely you think of in pregnancy and first trimester as hyperthyroidism as a first possibility. But the second possibility definitely remains, and then what becomes underlined is hypertension and paroxysmal features. And any paroxysmal hypertension clicks the light to look for pheochromocytoma or screen for pheochromocytoma.
Very good.
So it's a rare entity, but yes.
Yes, I agree with you. The patient underwent the obstetric scan, and obstetric scan shows the single live intrauterine gestation with gestation age of 14 weeks and a left adrenal mass 6.3 centimeter to 6 into 4.4 centimeter. And that patient referred to our center at KM Hospital. I want to ask Dr. Murad Lala, now, what about your opinion in this scenario? Please elaborate.
Yes, so if we go back to the history, this lady in her first trimester developed hypertension. It's too early for a pregnancy-induced hypertension. And now the ultrasound is showing a 6 by 4 centimeters. So first I would like to ask this lady whether in the beginning of her pregnancy, had she had a prior ultrasound where I can compare the size. And
Yes.
but that is one thing. Secondly, that generally when they do an obstetric scan, they really don't look for the adrenals and the kidneys, etc. So probably it was there, it was missed. But more importantly, why I'm worried about that is it a bleed into the adrenal or whether it is actually an adrenal mass? That is one thing I would like to know. So now with this adrenal mass and with the paroxysmal hypertension, of course, again, it goes more in favor of a pheochromocytoma, but we need to investigate and see whether it's actually a pheo or sometimes very rarely an aldosterone secreting tumor.
Yes, I agree. Next, on examination, she has a tachycardia, hypertension, that is supine blood pressure is 160 by 100, orthostatic hypotension, standing blood pressure 136 by 86, and has multinodal goiter. But there is no significant family history. Looking at this, what about, would you like to do for adrenal mass further, Dr. Amay Joshi? For adrenal mass, you want to do anything? Now looking at this scenario.
I think here the first rule of thumb is going to be a biochemical confirmation of catecholamine excess because adrenal masses are common. Pheochromocytoma, I would not say uncommon, but we need to zero down, and there we must do plasma-free metanephrine and normetanephrine levels as a because of the paroxysmal hypertension. And then, I mean, these are costly investigations, I must say. And as Dr. Naresh was pointed out, we need to be a bit streamlined. Though we can order all, but I think plasma-free metanephrine, normetanephrine should be the most important test here.
Any radiological investigations?
Yeah, here I think we are in a condition where the patient is pregnant, and what becomes contraindicated is a CT scan, and what is available for us is an MRI.
We have done the MRI of this patient, and it's suggesting whether 6.5 centimeter and 6.3 centimeter and 5.0 centimeter hyperintense left adrenal mass. And already you have mentioned the biochemical investigation. This is a 2010 case where I am just presenting in front of you. That time we have the urinary vanillin mandelic acid and metanephrine levels only. And we have confirmed that it is a pheochromocyta. But I just want to ask Dr. Vikram Sanghvi, for thyroid, what you would like to do? She has a multinodular goiter.
It's clearly shows as the picture that it's a bilateral nodule, as it is mentioned, and right and left nodule, particularly the sonography. Because of pregnancy also, I would prefer the sonography. And in the sonography, I can get the hyperechoic bilateral thyroid nodule. Its size is also important. It is a site. Site usually when we are thinking of something which is MEN syndrome, maybe thinking I'm talking that size is very important, and when it is upper third and middle third junctions, both as shown in the picture, it is there, as well as the neck, as well as you can do the USG guided FNSE. Also the other biomarker like serum calcitonin and its level, high, low, and medium. This also guides further treatment indication of aggressiveness. That's one thing. And one more thing which I want to suggest here, which is less known but frequently used, is a carcinoembryonic antigen, which is also raised with the medullary cancer thyroid, and it also gives the information about how aggressively it should be treated. That's how I feel.
Okay. So according to you, we have done the USG and FNSE that suggested a medullary thyroid carcinoma, and the serum calcitonin level 713 picogram per ml, but there is no evidence of primary hypothyroidism or glucose tolerance test performed, which was normal. I just want to ask Amay Joshi that when you, no, sorry, I want to ask that Dr. Anand Kumar Mishra, what is the role of genetic study in this? Sorry, I forgot.
No, so this patient has a pheochromocytoma biochemically proven, and then medullary thyroid cancer, and this combination goes to usually MEN2 category. MEN2 category has the two components. So medullary thyroid cancer, 85%, around 70% to 80% cancers are sporadic, and 20 to 30% patients are genetic. Now we have to find out whether it is a hereditary form of medullary thyroid cancer or it is a sporadic form. And for this, we need to have a RET mutation analysis. There is usually a single nucleotide polymorphism in these patients. And identifying, doing this RET mutation test, we can categorize this patient whether it belongs to a family medullary 2A or MEN 2B. In these patients, medullary thyroid cancer, there is a very clear-cut genotype-phenotype relationship. And
Yes.
this genetic mutation that guides us about the patient's management as well as the family screening and family management.
Yes,
So
sir.
because of these reasons, genetic study is needed in this patient.
Was tested positive for the RAT mutation C634W and in exon 11 was diagnosed to have MEN2A. And this is, you have explained that properly, sir. I'm happy that you have explained properly. Next, I just want to ask Dr. Amay Joshi, when you will refer this patient to the surgeon, and which surgery you would like to do the first or but together on the same sitting?
Yeah, I think first priority will be to stabilize the patient, and here we know that we have to follow a sequential algorithm. Alpha blockade followed by beta blockade. Ensure that the patient's blood pressure and pulse rate is well under control. Patient must have adequate hydration. It should be ensured that they should have adequate salt intake. These are common points which we must remember, that adequate salt intake is important here, adequate hydration is important here. Cardiac assessment has to be done because catecholamine cardiomyopathy is common. And then more often than not, after the patient is optimized on alpha and beta blockade, after all the proper evaluation is done, and we must never forget assessing the calcium level, because we might at times get hypercalcemia of a severe magnitude that needs to be controlled. Rare, but can happen. And then after all these things are taken care of, then comes the role of surgery, which usually should be planned in a second trimester. And this is one of those situations where you will be operating a benign tumor first, that is a pheochromocytoma, before a malignancy, that's medullary thyroid carcinoma. Here, the size that was mentioned was around 6 centimeters. So there, you should be careful that you should not miss on multiple pheochromocytomas also, because there could be other adrenal gland which should also be looked at. And I mean, maybe a nuclear person should also comment about extent of the disease over here. I would like to take their help at this.
So we first, according to your blockage was 20 milligram prazosin and 50 milligram atenolol. Patient underwent the laparoscopic left adrenectomy at 16 weeks of antenatal care. Then for medullary thyroid carcinoma, after 12 days, we have done total thyroidectomy with no evidence of neck node, central clearance of neck disease. Also, we have done, but finding is that there is no evidence of neck lymph node metastasis. I would like to ask Dr. Murad Lala how you proceed for the neck dissection in case of the medullary thyroid carcinoma.
Yeah,
on
so
imaging or
the
there
neck,
is
yeah, so
calcitonin
regarding neck dissection, one is a good imaging of the neck, one is ultrasound would have been done. Ideally, because the calcitonin level was 700, which is quite high, I would have to look for disease beyond the neck as well. So this lady would actually have had a proper staging workup, but because of its limitations, because she's pregnant, we can't do the CT scan. So we would rather do an MRI of the neck, an MRI of the chest as well for mediastinal nodes, and an MRI of the abdomen for liver, because that's the most likely site of metastatic disease. And then to decide about the neck, extent of neck dissection, one is based upon your imaging, the other is based upon the calcitonin level. So as this slide shows, that if your calcitonin is beyond, is less than 20, then only a central compartment is adequate. If it is beyond 50, you need to do the contralateral side. And if it's beyond 200, you have to do the contralateral lateral neck as well. And if it goes beyond 500, then you need to do the upper mediastinal nodes as well, clearance, even though they're not picked up. One more thing about the medullary thyroid cancer is that the spread to the lateral nodes or the lymph nodes does not depend upon the size of the primary. So whether you have a 1 centimeter primary or a 4 or 5 centimeter primary, the nodal metastasis irrespective is high. So these are the two, we do a compartment-oriented neck dissection. So depending upon your imaging and depending upon the calcitonin levels, we decide about the extent of neck dissection.
Thank you. He decided to follow the repeat serum calcitonin after 6 weeks of delivery. At terms, he delivered a healthy female neonate by vaginal route. So, poor baby, I want to ask Dr. Vikram Sanghi, would you like to do the mutation study, and when?
Yes, it's very important to do the mutation study because 17% of the all pediatric thyroid cancers are MTC, medullary thyroid cancer. Hereditary medullary thyroid cancers are very aggressive. No effective standard systemic treatment is available. Can be prevented with a genetic test. Probably, it can treatment will be the thyroidectomy, and for this it's very important, as you said, the time. But before the time, it's a parents counseling is very important, and it should be done immediately or one day, within 2 days. It should be done. Like we are doing it for the metabolic disorders in intrauterine also tests are done. And I'm sure it's most of the, because I was trying to get the literature, Indian allowed or not for the mutation of RE genes is, I'm not sure, but it's allowed everywhere in the world. And because Down syndrome, they are doing intrauterine also, so it should be done because it can be operated also. Mutation gene is positive, then, possibility and prevented the MTC in a newborn. And timing should be then, they say that 5 to 10 years is a good timing, but I feel that, it should be done.
Now, prophylactic thyroidectomy is
prophylactic thyroidectomy.
Yeah, this is a slide. You just read out in the paper for the residents and all those are watching this. Just elaborate on this. You
MEN2A, that's very nicely said that before 5 years, as I said, that children with the genetic RAT mutations is there, and I agree with MEN2B, ATA, HST. That's the first year or first month of the life that to be done.
Yes,
I also. Yeah, and MEN2A, it's they say the childhood where then in between 5 to 10 years with the serum calcitonin is elevated. That's what the standard is. I agree with you.
Yes, thank you. I just want Amay Joshi to comment on any role of tyrosine kinase inhibitors. These all are tyrosine kinase inhibitors.
Yeah, I think I would say that tyrosine kinase inhibitors have been mentioned in the guidelines for a progressive residual inoperable disease. What have been approved has been cabozantinib and vandatinib. Vandatinib got approval after the Zeta trial, and these can be given, and the responsive rates are, quite encouraging, though not 100%. The reasonable effect can be seen. What has been a recent thing has been approval of two important tyrosine kinase inhibitors. One is specific for the RET, that is selpercatinib. It got a expedited approval after a trial called as ARROW, and pralsetinib. So these give 70% responsiveness even when the current lot of commonly used tyrosine kinase inhibitors are ineffective. They remain as a good therapy for progressive inoperable disease. And then we have tried other modalities like radionuclide guided therapies and external beam radiotherapy, which enhance responsiveness.
If there a Dr. Sudeep Sarkar is there, just I want to ask him how to schedule follow-up, sir. Sudeep Sarkar. Hello. If he is not there, Dr. Anand Kumar, please elaborate on this. Hello.
Hello, I'm here.
Dr. Sudeep Sarkar or Anand Kumar? Dr.
Dr. Sarkar is here.
Yeah, Sudeep has joined in.
Sudeep joined. Sir, please elaborate on the follow-up of the MTC with pheochromocyte are meant to is.
Yeah, as you put on the slide, the entire family has to be screened because the subsequent siblings which are there or the immediate relatives they have to be screened for the with the ret oncogene, and the patient herself has to be. We are talking about the patient who has already had surgery for medullary thyroid cancer. Same?
I think yes, yes.
Yeah.
For patient, we are asking, sir.
Yes. So serum calcitonin as a follow-up 6 monthly, and as in all thyroid cases, the ultrasound imaging for structural disease recurrence or persistence is important. And about the PET scan, I'm not sure whether the PET scan every year is going to help, or we can have directed scans, especially for the medullary thyroid cancer.
Sir, I will ask one. Is there any role in calcitonin doubling time? I have focus on this slide, sir.
So in
calcitonin doubling time has any prognosis on the patient survival?
That
I'm put on there.
Less than 6 months of the calcitonin doubling time in less than 6 months, say, the very poor prognostic variable, and almost all patients die between
6 months to
the survival is only 25 and 10% at 10 years and about 25% at 5 years. But what is significant is that all these patients who had the calcitonin doubling time is in less than 6 months are dead within 13 years after the surgery. But if the doubling time is more, that is about 5 to 10 years, doubling time, the doubling time is 6 months to 2 years, then of course the survival is improved. And only about 60% will die following up from 3 to 15 months after surgery.
Thank you.
Can I have the question, please?
Yes.
Can I have the question? Regarding carcinoembryonic antigen, since the literature 2018 onwards, they are mentioning the lot of relevance comes with the medullary carcinoma. Is any panelist or sir, you have any idea of it, whether to follow or not to follow? I understand the calcitonin is a more specific tumor marker, but it does, along with the MTC, it is reported in so many literature, especially from Canada.
Okay, I mean, maybe I could contribute.
The calcitonin and CEA, both the doubling times postoperatively have sensitive markers, just as calcitonin. CEA is also a very sensitive prognostic marker, as has been found in the recent studies.
No, I think I'll bring in Anand here because he would be somebody who could comment on the use of CEA. And then I'll ask him to speak, and then I would sort of close up because we're reaching.
Yeah. Okay, so thank you, Deepak. CEA is a marker of undifferentiation. So if there is an undifferentiated component in medullary thyroid cancer, CEA is obviously raised, and it is definitely used as a marker in the follow-up. We all use it. And if CEA is rising, then there is more undifferentiated component, and that's the bad prognostic marker.
Sure. Yeah.
That's all I will say.
I just conclude this case. If you see the looking for pictures of MEN 2A, we have to see for the goiter, calcitonin, family screening, and adrenal sparing for the pheochromocytoma to post-op steroid dependence with low rate of recurrence. So management of MEN 2A is a pregnancy is very challenging. So I conclude this, and thank you every panel. Thank you, and thank you Ritesh, Niranjan Agrawal sir, Sandeep Bipte for giving me opportunity to present. Thank you, Deepak Abram, sir.
Yeah, no problem. I just like to comment on the red testing, which was said that you don't offer operation for the child who is positive till at least 10 years old because you want to prevent complications. Hence, there's no tearing urgency to go and do the red test on the baby. You could wait. It's an autosomal dominant 50% chance of developing positivity, but you could wait and titrate it along with calcitonin to decide when you would go in. So yes, you could do the genetic test in the 1 to 2 years of life, but the intervention is going to happen only much later. And that intervening period prior to intervention could be followed up by yearly or a 6-monthly calcitonin. And if there's a rising calcitonin, then intervene earlier with a prophylactic thyroidectomy. And only in 918s, 883 and 634 mutations would you offer prophylactic thyroid surgery. All the other patients, you would just follow them up on just with serum calcitonin. I think we'll close with that and over to the organizers. Thank you so much.
Thank you, sir. So at this wonderful panel discussion, and I would like to thank you, Dr. Deepak Abran, for wonderful managing the case, Dr. Mahadev Garale for his case capsule, and I would like to thank you all panelists, Dr. Vikram Sanghvi, Dr. Sudeep Sarkar, Dr. Amay Joshi, Dr. Murad Dana, and Dr. Anand Mishra. With this end of this panel discussion, I think we are end of this thyroids and lovely, wonderful discussion that happened. And thank you all the speaker and the faculties for their time. And let's move on to the next session, part 2, as a breast session. I would like to invite convener Dr. Ritesh Agrawal to take over and proceed for the further session. Thank you.
Thank you so much, Dr. Sandeep Ipte. So this session is of the invited lectures. I would like to introduce Dr. Prachi Mahajan. Dr. Prachi Mahajan is a cancer and laparoscopy surgeon practicing at Mahajan Ortho and Surgical Hospital at Nagpur. She is also known for her extensive surgical experience in breast cancer and GI cancers. We are lucky that she was Mumbai born and bred and an alumni of Sion and Nair hospitals. She is the recipient of prestigious Margaret Odester International Fellowship Award in 2019 and is a senior faculty at national and international conferences. We are lucky to know that she is the first and only woman oncologist and laparoscopy pediatric surgeon in central India. So our next chairperson is, change the slide please, Dr. Rajendra Ganeriwal sir. He is the president of Maharashtra State Chapter of ASI and is FIGS with a special interest in GI endoscopy and breast surgery. So over to you all, Dr. Prachi and Dr. Rajendra sir, please.
Thank you, Dr. Ritesh. Welcome to this session of invited lectures. And without much ado, I'd like to introduce the speaker for this invited talk on triple assessment of breast cancer, which we all know is a very important topic, because even after examining so many breast lumps, there are certain protocols which are to be followed to arrive at a diagnosis. To introduce Dr. Gaurav Agarwal, he's a senior endocrine and breast surgeon from SGPGIMS Lucknow. He is the professor of the Department of Endocrine and Breast Surgery there, and he is president of Breast Surgery International 2019 to 2021, and a counselor of the International Society of Surgery Switzerland 2019 to 21. And he's a board member of the Indian Breast Cancer Repository. He's an active member of the American Association of Clinical Oncology, Asia Oceania Thyroid Association, the Association of Breast Surgeons of India, and the ASI. Over to you, Dr. Gaurav Agarwal, to begin with your talk.
Thank you very much. Am I audible?
Yes, you are.
Thank you. And can I share my screen now?
Yes.
Yes, sir. Okay. All right. I hope my screen is visible to you all. Firstly, I thank the organizers of this from the Mumbai Surgical Association for this invitation for me to speak at this meeting today. And I've been asked to discuss the approach to a breast lump and how we do a triple assessment. Well, this is like the bread and butter job. We all breast surgeons and general surgeons with any interest in breast surgery do day in, day out, sitting in our out clinics and in our patient for our patients admitted with us. So triple assessment, it cannot be overemphasized. I'm trying to shift to the next slide. Yeah, okay. So when you are faced with a patient presenting with a breast lump, I should also acknowledge the fact that I've been part of the team from Association of Breast Surgeons of India in the capacity of Director Education North Zone, where when we develop a slide set and then a set of presentations for carrying out some teaching activities for the ABSI, and some of what I'm going to talk are kind of borrowed from those slide sets. So when we are faced with a patient with a breast lump, the first and foremost step is to arrive at a diagnosis. And the aim
at evaluation for arriving at a diagnosis is to achieve a robust, irrefutable diagnosis. How do we do that? The way we do it is to arrive at a diagnosis or rule out the diagnosis of a cancer. And this whole lecture is all about how do we go about doing it. Besides diagnosing cancer or ruling it out, if in case we are dealing with a patient with a cancer, we need to not just diagnose, but also stage the cancer in the breast, in the axilla, and systemically. We also would need to know how to treat this patient, and in order to advocate appropriate treatment strategies for an individual patient, we would need to know the predictive markers, prognosticate the patient, and then plan the treatment while ensuring safety, and appropriate treatment for surgery, radiation therapy, and systemic treatment. Breast lumps are common problems in all age groups. Of course, different age groups have different kinds of breast problems. Majority of breast lumps are innocuous. They do not require specific treatment or surgery and radiation and whatnot. However, 1 in 10 approximately of those who present to various breast clinics actually are neoplastic or tumors. And the real challenge is in identifying the not so innocuous ones. And it's like trying to search for the needle in a haystack. But with a bit of systematic approach to evaluation, and which involves the triple assessment, we can diagnose majority as benign or malignant or potentially malignant, and so we can then advocate appropriate treatment. So let me now talk about triple assessment. So it's quite apparent triple assessment has to have 3 components, and these 3 components are a complete history and oops, what happened? I can't see my screen anymore. Has the screen share been disabled? Let me try and share. Okay. No. Is it back again?
Yes.
Can you see my screen?
Yes,
All right.
sir.
Thank you. Okay. So I was talking about triple assessment, and the 3 components of triple assessment are, first and foremost, the history and clinical examination. Second, in form of breast imaging, and usually it is limited to mammography and ultrasonography. In fact, in majority, both of these. And in exceptional cases, we would like to use MRI of the breast. And the third component, which is the confirmatory component, is the needle biopsy. Usually, we resort to a core needle biopsy, but I'll also like to discuss the role of FNAC or fine needle aspiration cytology. Core biopsy, as I said, is preferable because FNAC has somewhat lower reliability, but because of ease of doing it and various other reasons, it's much more commoner or popular compared to core needle biopsy. What happened? Yeah. So dealing with a patient who has a potential breast lump or has a breast lump, the detailed history must have a particular attention to the symptoms, which may suggest neoplastic pathology. These symptoms may be age dependent. However, a set of common symptoms or common features that may suggest neoplastic pathology are relatively a shorter duration of disease, a painless lump, new nipple inversion, changes on the skin which may suggest a malignancy, discharge from the nipple which is either frank blood or blood mixed, non-tender or painless lymph nodes in the axilla or the supraclavicular fossa, and any symptoms which may suggest metastatic disease, such as symptoms which may suggest bony pains, fractures, cough and expectoration with maybe streaks of blood, weight loss, appetite loss, and then the features of ascites and those kind of features. Another set of important history must be directed at looking at the specific risk factors. Now, risk factors for breast cancer can either be personal or internal, and they may be external or environmental. And the most crucial ones that we must always pay attention to are the genetic risk factors, and therefore the role for a good family history cannot be overemphasized. There are certain factors which are protective, and then there are certain factors linked both internal or genetic and external or environmental, which may indicate higher risk. And some of these are listed here. I'll not go into each one of them, but the important ones are BRCA mutations, age, nulliparity, and age of first childbirth of more than 30 years, having never breastfed. These are certain features which increase the risk of breast cancer. And if we can talk of one protective factor, or one most important protective factor, it is the breastfeeding and parity. So these things must be brought out in the history. Having taken a good history, including all components of family, personal, past, menstrual, obstetric history, we then focus our attention to examining the patient. The examination of the breast must always be done with a female chaperone. The patient has to be in the privacy of a good examination room, which is well lighted. Patient needs to be exposed from jaw to umbilicus. Both the breasts should be examined together. Attention should be paid that the two shoulders are at the same level. And then you examine, first inspect and then palpate, and then do the rest of the examination, firstly in the sitting up or standing posture, and then again while lying down. While the patient is upright, the first step of examination is while the patient's arms are by the side, and then you ask the patient to raise the arms as shown in this picture. And then thirdly, ask the patient to shrug her shoulders while pressing the two hands on her hips. And these are maneuvers which make certain parts or certain types of lesions in the breast more apparent while inspecting. And these maneuvers are also required while palpating for them. And then, for example, for ascertainment of fixity of a lump to the chest wall or to the skin, all these maneuvers are useful. And as I said, after inspecting and palpating while sitting or standing in the sitting or standing posture, this must also be repeated while the patient is lying down. The examination of axilla is done while the examiner is standing or sitting in front of the patient, using the left hand for the right axilla and vice versa, while the arm is supported with the opposite hand of the examiner. And then the supraclavicular foci and the neck are best examined while the examiner or the physician surgeon is standing or standing behind the patient. These are certain features we can find relating the common complaints of breast mass or nipple discharge and skin changes, which can be associated with benign characteristics or malignant characteristics. For want of time, I'll not go into each one of those, but these are features which help us raise our suspicion or arrive at some initial diagnosis and accordingly go along that path in the evaluation or the subsequent evaluation. So having examined the patient, and then by the way, the examination is not just limited to the breast. The patient must be examined in toto, head to toe, but here I'm limiting to just the triple assessment of the breast. So having examined the patient, we then focus on the breast imaging, which is the second and very important component of triple assessment. And as I said earlier, it is usually limited to well-performed bilateral mammography and ultrasonography of the breast. In today's day and age, ultrasound has kind of emerged as the new age stethoscope, as an extension of clinical examination. So for specialist breast surgeons and people or various specialties, it makes sense to learn the craft of ultrasonography and then do it yourself. But of course, you can always collaborate with radiologists. The role of breast MRI is rather limited to my mind, and it's limited to patients who are BRCA mutation carriers or those who have received neoadjuvant systemic treatment or undergone oncoplastic or breast conservation surgery, and those who have an implant in place. So this is how mammography is carried out. The breast is compressed between two plates, and then high energy X-ray is used, or rather low energy X-ray is used to image the soft tissue of whole of the breast. Digital full field mammography is the preferred way, and it is best if we can couple it with tomosynthesis, which can give you a 3D imaging. It has to be bilateral and complete, which means the whole of the breast is included in the mammography study field. It should also include the axillary fold and the pectoral muscles. It is best reported by an expert breast radiologist, and the reporting is done using the BIRAD system. It's important that all these things are taken care of in a specific fashion so that we do not miss out any of the details. The aims of breast imaging are to detect a breast cancer, to know the extent of disease, multifocality, multicentricity, if any. It also helps us do a guided biopsy of a suspicious lesion. At times, we use these imaging to place a guide wire or other things like iodine seed in an impalpable lesion, using which we can then excise it or biopsy it. And obviously, it helps in the treatment planning of the patient. Here is a set of mammograms. You can see on the left breast, there's a deep-seated spiculated soft tissue lesion, and with streaks of fibrous tissue extending up to the nipple. And the mediolateral oblique view, the same patient, you can see very well that deep-seated spiculated lesion, and also you can appreciate the enlarged axillary node. And another patient, yet again patient with a big spiculated mass in the right breast. The left breast on mediolateral oblique, I feel this is a complete study, which because you can see the axillary fold. However, on the right side, this is not a complete mammogram because the axillary fold is not completely visualized. So it is important that we do a complete study. At times, patients may have microcalcification like this patient, and then the patient may require a compressed or a focused view, which the radiologist would be able to do. Ultrasonography for diagnosing breast cancer and various other breast pathologies is quite useful, and more so in younger women less than 35 years age, because they have dense breast, in which case mammography is not as great of importance. Usual high-risk lesions and cancers are seen as hypoechoic, ill-defined, taller than wide lesions, and they have a post-acoustic shadows. Ultrasonography can also help you do ultrasound-guided core biopsies or even needle FNACs. Breast MRI, I said, has a limited role, and mostly we would find a breast cancer which is lighting up on contrast enhancement, and then at times we are able to see multifocality and multicentricity.
Excuse me, sir. Your time is up, sir. How many more slides?
So I'll just stop after this. Okay, and then any other things that you want to, we can discuss later. So the final step in triple assessment is to establish the tissue diagnosis, and this is usually done by a core biopsy, which may be image guided, but a surgical biopsy must not be resorted to as and when possible. Core biopsy is preferred because cytology alone has lesser specificity, and it does not provide tissue for immunohistochemistry, which is again an essential part. So two-cut biopsy or a core biopsy has higher sensitivity and almost 100% specificity. And you can also get the immunohistochemistry predictors like estrogen and progesterone receptors and HER2. So beyond a triple assessment, we may have to at times resort to image-guided vacuum-assisted biopsy, and we've been using mammotome, but there are other options. And then you can at times have to resort to wire localization and excision of an impalpable lump or a lesion, and that has to be subjected to specimen radiography. Operative biopsy should be resorted to only in exceptional
So I think you need to stop,
circumstances.
sir.
Okay, thank you very much.
Thank you, Dr. Agarwal. That was a very elaborative talk, and it is we've seen that it is very, very important that to do a proper clinical assessment, clinical examination, and basic radiological and pathological investigations to go a long way in diagnosis of a breast lump. Moving on, Dr. Ganeri Bal.
Yes, thank you. Good afternoon all. The name is Dr. P. OBE. My proud privilege, Dr. P. Sir, is FRC at Glasgow, FSC Thailand, here Surgeons of Sri Lanka, Honorary Fellowship of College of Surgeons of China. Is immediate of Surgeons of former Secretary Association of Breast Surgeons of India.
So I think your signal is bad. We are not able to hear you. Dr. Raghu can, Prachi, either you introduce him and we can move forward. Because Dr. Ganeriwal's signal is poor.
Yes, I got it. Dr. Raghuram, as we all know, is a very he's a very well-known figure in the field of breast surgery, breast cancer surgery, and he is. I mean, Dr. Ganeriwal has introduced most of it, and I'll just highlight his major achievements. That he's an international gold medalist of the Royal College of Surgeons of Edinburgh in 2013. He's a Padma Shri awardee and a Dr. B.C. Roy National Awardee, and a founder, honorary secretary, and president of the Association of Breast Surgeons of India. So with that introduction, I hand over the mic to Dr. Raghuram.
Okay. Good afternoon, everyone. And I bring greetings from Hyderabad. At the very outset, my heartfelt gratitude to Dr. Niranjan Agarwal, the Mumbai Surgical Society. We have our distinguished president of ASI, Dr. Abhay Dalvi. And I'd like to especially commend Dr. Sandeep and the entire team for putting together an excellent program. So the assessment and evaluation of a breast lesion aims to ensure accurate diagnosis. As 9 out of 10 breast health issues are benign, the main aim is to reassure the worried well. The aims of breast assessment, there should be only 3 outcomes. Either there is no problem, either there is a problem of a benign lesion, or a diagnosis of a cancer, and assessment should end at diagnosis and not before. My good friend Gaurav has already clearly explained about the importance of triple assessment, but I'd just like to highlight, just as a physician requires a stethoscope for a surgeon dealing with breast diseases is a good radiologist and a good pathologist. It's not just good enough to be a great surgeon. It's very important to have a multidisciplinary team where you can speak to each other by first name. There is no one superior. Everyone is equal. And I'd like to also emphasize that it's very, very important to listen. Particularly applies to benign breast disease, where the patient comes with a lot of problems. She thinks she has a lot of problems, but actually she doesn't have a problem that really requires surgery. So it's very important to listen, just like, not like this doctor, where you see the patient at the edge of the chair, but you should be like this doctor, where you are listening to the patient. And that's extremely important. Throughout the course of my presentation, you will see the monuments and buildings in Hyderabad illuminated in pink. This is the majestic Charminar. Mastalgia, very common. Cyclical mastalgia, which occurs whilst women are menstruating. Non-cyclical after menopause. And the third kind of pain, which is actually not mastalgia, is a chest wall pain, which very often people mistake it to mastalgia. Very important to roll the patient to the side. This allows the breast to fall away from the chest, and lifting the breast with one hand and palpating the chest with the other will distinguish between true breast pain and chest wall pain. What is required is reassurance, advising the lady to wear a correct fitting bra, and in rare circumstances, giving half a dose of tamoxifen for a short period or NSAID gels. But what is not to be done is to prescribe evening primrose oil, which is very often prescribed, and danazole, which is totally not required at all. This is the Buddha statue in the center of the lake that separates Hyderabad from Secunderabad. A 35-year-old lady, left breast lump, 6 months duration, a typical popcorn calcification, a fibroadenoma on a mammogram. On ultrasound scan, it's oval, smooth, internal echoes with partial transmission and edge shadowing. What is to be done? An FNA and an excision? No. What is to be done is an ultrasound guided core needle biopsy. We always at our breast center take a picture of the needle within the lesion to show the lady, to reassure the lady, and to explain to her that she does not need surgery unless it is large or the patient is paranoid about the feeling of the lump in the breast. What is required is reassurance and only excision if it is large or a giant fibroadenoma. This is the only Raj Bhavan in the country, ladies and gentlemen, which is illuminated in pink in October. Phyllodes, a lady, usually someone over 40, presents with a large lump, mammographic appearance, large, rounded, oval, lobulated, well-defined lesion. On ultrasound, it's well circumscribed. What is not to be done is FNA. What is to be done is an ultrasound-guided core needle biopsy. Even then, you can't distinguish between a benign and a malignant phyllodes. She will require a wide excision or sometimes a mastectomy if it is very large and cannot be removed with just wide local excision, ensuring good aesthetic outcome. This is the only legislative building in the country, in Hyderabad, which has been illuminated in pink in the month of October. A cyst, typically a middle-aged lady, presents with sudden onset of lumps in both breasts, and you see here typical lesions in both breasts, well-defined, and on ultrasound scan, it's smooth, anechoic, well-defined walls with enhanced through transmission. What is to be done in cysts? Aspirate? No. And when you aspirate, do you send it for routine cytology? No. The only time you want to aspirate is when the cyst is infected. And when you aspirate that cyst fluid, it should just be discarded. There is absolutely no role for sending it for cytology, culture, sensitivity at all, because it is of no value. It may show false positivity with atypical features, and then you're in a dilemma what to do. And it's not at all cost effective. Not even in a corporate hospital. It should be resisted, because a lot of times we find people sending aspirates for cytology. The only time you want to send it is when it is blood stained and it's done under ultrasound guidance. Most cysts are benign, but sometimes, very rarely, a cyst can be malignant. This is a typical intracystic lesion, intracystic cancer, and that is when you want to do an aspiration and also an ultrasound guided core needle biopsy. This is the United States consulate in Hyderabad, turning pink. Many a times, women who undergo screening mammography, majority of the microcalcifications are benign, very benign, nothing to be done. This is a fingerprint artifact, vascular calcifications, secretory calcifications, and oil cysts. What is to be done? Nothing. Should they be followed up? No. They are all benign. Majority of the microcalcifications are benign. Ravindra Bharati in the center of the city, which is the cultural hub in pink. Nipple discharge, physiological or pathological. Physiological, we know there are several causes, and usually it is yellow, gray, brown, or dark green. And pathological, it's caused by an abnormality in the duct epithelium. It is spontaneous. I emphasize the word, it's spontaneous. It is unilateral. It is bloody or serous in color, and usually caused by papilloma or papillomatosis or papillary cancer. Duct ectasia, when women age, the ducts behind the nipple get shorter and wider, and that's called duct ectasia. Usually seen, multi-duct discharge, greenish, yellowish. It's not blood, triple assessment to be done. And when there's no intraductal pathology, all that is required is reassurance. Periductal mastitis, ducts under the nipple become inflamed and infected. Younger women, lactating women, and there is usually discharge and signs of acute inflammation and nipple inversion. A young lady, we recently celebrated the World Breastfeeding Week. Lactational abscess, very common. Incision and drainage should never be the first option. The first option should be an ultrasound guided aspiration. And you need to bring the lady back multiple times and aspirate on a regular basis. And only when it is multiloculated and it's not responding to antibiotics, not responding to ultrasound guided aspirations, that is the only time when you want to do an incision and drainage. Galactoria, again a common symptom, discharge from the nipple that resembles milk, many times bilateral, and it's sometimes caused by a non-malignant prolactin secreting tumor. One must suspect galactoria when there is a combination of amenorrhea, infertility, and associated visual disturbances. Prolactin levels are high. A short course of dopamine agonists are given to shrink the tumor, and surgery is reserved for non-responders. And it's very important that in blood-stained discharge, patients think that they are worried because, I think I'd like to emphasize here that stress, hypothyroidism, it's important to take a good history because all these drugs can cause galactoria. Blood-stained discharge during pregnancy and lactation, people are worried because this happens sometimes because of sudden increase in size of the breast, which can cause a galactoria, and all that is required is reassurance. Many times discharge from the areolar region, from the Montgomery glands, it's not truly a nipple discharge. They're serious in nature. Reassurance and treating with antibiotics is all that is required. Pathological nipple discharge is a blood-stained discharge, and on triple assessment, what do? You do a mammogram, you see a small lesion. Under ultrasound guidance, we do a core needle biopsy, and a papilloma has to be excised. This is the Raj Bhavan in pink again. This is a typical galactosile fat fluid level, nothing to be done unless it is really infected. And this is my own hospital, Kim's Hospitals, which is illuminated in pink. This is a mammogram. This is a typical multifocal breast cancer is what you would think, because you would see multiple masses, pleomorphic microcalcifications. But when you do an ultrasound scan, if you see this picture, there are multiple ill-defined cavities reaching the skin. The diagnosis is TB, very, very often missed. They present with ulcers like this, or they present with ugly scars where people have multiple times done incision and drainage. What is required is high index of suspicion, ultrasound guided core biopsy. If there is suspicion of granulomatous mastitis combined with caseous necrosis and epithelioid giant cells, we can start empirical anti-TB medication. In our center, we always involve a pulmonologist and we counsel them that this may not work. And after an empirical course, we decide whether we continue or not. And majority of the times, chronic granulomatous mastitis is TB until proven otherwise. And it's magical in most people, but it does take time and perseverance.
May I interrupt? We are in the last minute of the session, please.
Thank you very much. I shall not go into the not so benign conditions, and I shall conclude by stating that triple assessment is mandatory, as mentioned by my previous speaker as well. Communication skills have to be at your best. It's important to be aware about benign conditions, but not so benign, like radial scar, atypical ductal hyperplasia. They're not benign, but they need to be excised. But most benign breast health issues require just conservative management with good reassurance to the patient and to her spouse, and always never to forget not to do any harm. Thanks very much for the opportunity.
That was a very comprehensive talk on benign breast disease assessment, interspersed with the pink, which was really very interesting. And I must say that breast tuberculosis is very much on the rise. So I'm glad that you pointed that out as well. Since the past 5 to 6 years, breast tuberculosis has become a very, very common thing. Just one question. Why is it that you emphatically said no to the use of danazol? I mean, what are the problems with danazol that you have encountered?
Side effects. Tremendous side effects. There's absolutely, I mean, we have found that there are a lot of side effects with danazol, and we find that majority of the times we find, that patients do respond to other measures, mainly reassurance, mainly counseling.
Thank you. So I think I'd hand over to the organizers again
Thank you so much, Dr. Prachi and Dr. Rajan Ganegewal for moderating such a nice session. And we would like to thank speakers also, Dr. Gaurav Agarwal, who had been my teacher, also my professor, and Dr. P. Raghuram. We thank you all on behalf of Mumbai Surgical Society. So coming to our next session, it is a panel discussion on benign breast diseases. It is an honor for me to introduce my teacher, my mentor, my elder brother, my father figure, Dr. Niranjan Agarwal. He had always been a supporting person to me in Mumbai. He is a very well-known consultant colorectal surgeon in Bombay Hospital and Wockhardt Hospital and many other hospitals. He is current president of Mumbai Surgical Society. He is the president of Association of Colon and Rectal Surgeons of India and an executive board member of many societies. Next, please. Whenever I say that excellence is personified, then comes the name of Dr. Aditi Agarwal. She is an excellent breast surgeon at Wockhardt and SCG Cancer and many other hospitals. And she has 23 publications in national and international journals. So over to you all, Dr. Agarwal and Dr. Agarwal, for conducting the session, please.
Thank you, Ritesh, for those kind words. May I request Aditi to introduce the panelist? Aditi?
Yes, sir. It is my pleasure to introduce Dr. Rajshri Kelkar. Madam has done her FRCS from UK. Besides that, she has done her PG certification in breast oncoplasty from University of East Anglia, UK in 2021. She is also the honorary assistant professor of surgery at Grant Medical College and Sir JJ Group of Hospitals. Besides that, Madam is consultant with Saifi, Raheja Hospital and Apollo Spectra. She has multiple publications on her name. Dr. Anjali Davle is a renowned surgeon from Nanded. She is at present the EC for Association of Breast Surgeons of India. She is also the treasurer of Maharashtra chapter of surgery. She is one of the pioneers in microendoscopic ductoscopy for nipple discharge. Welcome, Dr. Anjali. Thank you. Thank you. It is indeed my pleasure to introduce Professor Anurag Srivastava, sir, who is retired professor and head from AIMS. At present, sir is the medical director of Balco Medical Center at Raipur, Chhattisgarh. Sir has many achievements. Sir has done his FRCS from Edinburgh, UK. He has done his PhD from University of Wales, UK. Besides that, sir has also done his MPH. Sir has also done his distance learning course in medical education with Center for Medical Education from Dundee, Scotland. And his major achievements are, sir has multiple prizes, book prize for standing second in first professional MBBS, then for standing second, again in second professional MBBS. He has certificates of honor in anatomy, pathology, and surgery. Besides, he's also got first prize in symposium at Stroke Medical College, Allahabad. Sir has won multiple best papers also. A very warm welcome to Anurag Srivastava, sir.
Thank you, Aditi. The next panelist is a very senior surgeon from Rajasthan, Dr. Kumkum Singh. She has been an ex-professor and head of department at the Ajmer Medical College and past president of the Association of Colon and Rectal Surgeons of India, as well as the ASI Rajasthan chapter. She has been the director education for the West Zone of the APSI 2019-21. Welcome, ma'am. The another panelist is Dr. Jayashree Pandya, again a senior surgeon from Mumbai. She is a professor and head of unit and in charge of the breast disease division at the Topiwala Nair Medical College and the Nair Hospital. Welcome, ma'am, to the panel discussions. With this, we start the panel discussion. Can you display the first slide, Aditi? At the very beginning, I must thank Dr. Raghu because in his talk, he has covered so many benign conditions very aptly, and probably will help us to finish our panel discussion well in time, though it's a very long list of diseases to be covered for benign diseases. It was already mentioned that 9 out of 10 are benign. You know, the time we are waiting is very small, and it is thanks to me only. I don't have anybody to blame for that. In the first slide, so first is we'll talk about acute infections in the brain. The first slide which he has projected is a breast abscess. Rajeshri, I want to ask you, when you get such kind of late abscesses, how do you pick them up early, and what do you do to prevent their progressing to such an extent where they would form such a large abscess with so much of cellulitis around? Rajeshri, are you around? Anjali, you can take if she is not.
Yes. Now, I think she's. Hello, can you hear me?
Yeah,
Hello?
I request all panelists to unmute themselves so that we don't lose time in discussion. Yeah, Rajeshri.
Hello, can you hear me now?
Yeah, very much.
Yeah.
I can see you also.
Thank you.
Looking very pretty.
Okay. Niranjan, as we were discussing, this cellulitis development is a late sign of breast abscess. So our aim should be, particularly in lactating women, to pick up the mastitis at a very early stage, when there is the stage of mastitis, when there is no pus, or where there is minimal pus. So what I call this as a clinical triad, where the lactating woman is complaining of breast pain. That should be significant, because breastfeeding is a physiological process, and that should not be painful at all. So if the patient is complaining of continuous 2-3 days specific side breast pain, we should look into it. Most of the times our mothers and our mother-in-laws keep on saying to apply heat, which actually worsens the scenario. So it should be always ice packs which should be applied. Then second thing is, if they are cracked nipples, then there is a very good chance that they are developing mastitis. And third most important thing is, if the patient is having fever, then it is almost 100% sure sign that the patient has developed mastitis and some amount of pus at least. The fourth very uncommon symptom is that the baby which is well feeding and passing stools suddenly starts to have a diarrhea. Then you can assume that the baby is having infected milk, and we should look into it. My take on this would be, we should have a very low threshold of doing ultrasound in all these patients, so that we pick up the infections when they are at the level of mastitis, and they can be treated with conservative line of treatment, such as antibiotics only, or if there is a small amount of pus, aspiration and cytology and things like that. And we should not need to do any incisions and drainage. That should be our aim in managing the lactational breast abscesses.
Fine. Points well taken. The next question will be to Anjali. Anjali, traditionally, we have all been taught to drain these abscesses with a large radial incision, so that the lactating ducts do not get damaged, and then give an adequate counter drainage, which actually cause a lot of cosmetic bad effects on the patient, because most of these are young women, in their 20s or their early 30s. As Dr. Raghuram was saying, it should not be done anymore. What is your take? When would you do an incision and drainage? When would you not do an incision and drainage for this patient? And what would be your incisions?
Right. So incision and drainage, which has been described traditionally and taught us in the medical schools. Now, in recent past, there is a trend. In recent past, last 5 years, there is aspiration with a white bore needle is one of the accepted treatment. Now, what are the guidelines, and for which abscess we will go for? One, whether the abscess is a uniloculated abscess, that is one. Second, whether abscess has involved the skin and subcutaneous plane. The picture which was shown previously when Rajeshri was describing, it has involved the skin in a big way. So there is a patch of necrosis, or the skin is going to give away after certain period. So this is not the proper case where aspiration should be the choice of the treatment. Still, if you take a chance, you should well in advance tell to the patient that this skin is going to give us a trouble, and this is a patient in which we should go for incision and drainage. So in short, wide bore aspiration is one. Second thing is wide bore aspiration with a three-way cannula, where we can give a wash.
Third thing is, if the tell in advance to the patient that she may require multiple aspirations to avoid the incision. Fourth thing is, aspiration is a minimal invasive treatment which is again not going to affect the breastfeeding of the patient. So in short, aspiration has to be followed where the abscess is a uniloculated. It is quite a well-defined abscess. It has not involved the subcutaneous tissue. It has not formed a ductal fistula. So such is the case where we will go for an incision
Do you need
or
to
aspiration.
do you need to do it under ultrasound, or you can do a blind aspiration for this patient?
It is always, if the ultrasound is available with the surgeon, it is always accepted and good. But even though if you do not have an ultrasound at your clinic, still you can try, no harm in that.
Jayashree madam, would you tell if you have to do a surgery on these patients, what incisions would you now recommend? Would you have the traditional radial ones, or Jayashree
When the
Pandya ma'am?
abscess is big enough, can you hear me?
Yeah, we can.
Yeah, when the abscess is big enough and aspiration cannot be done, then the only option with us is to do incision and drainage. As you rightly said, Dr. Niranjan, initially huge radial incisions were taken, and it was cosmetically also bad, and it was functionally also bad. So now what we do is that we take a small incision, we remove the abscess completely, and probably we pack it so that it heals from below upwards. Or the second option is, if the breast is very large, then you can probably put a drainage for a few days so that the cavity collapses early, and this can be removed in 24 to 48 hours.
So where is the incision, ma'am? Is it at the periareolar area?
The incision can be taken in the periareal area, but you do not go and tackle the duct.
Fine. You can take the next slide, Aditi.
So I would like to discuss this.
Any faculty want to add something different? You are most welcome. Dr. Anurag Siva.
Yeah, thank you. So as Dr. Raghuram very rightly, pertinently pointed out, avoid incision and drainage if skin is intact. So if skin is intact, we will do ultrasound. If cavity is very large or has multiple loculi, then we should aspirate initially, send the pus for culture and sensitivity. If the cavity seems more than 3 centimeters in diameter, or if on ultrasound evaluation, the volume is more than 30 ml volume, then suction drainage, vacuum suction drainage with number 14 gauge Romson suction drain connected to a vacuum suction receptacle is the ideal. We have done randomized trials and we have found that for large abscesses, vacuum suction drainage is a better option than multiple daily aspirations for many reasons. So just to cut short, that vacuum suction drainage is a viable option. Using 14 gauge, why I say 14? We tried with narrow gauge 10 or 12 to minimize pain and size of the catheter, but with the 14 gauge, you can connect a syringe. The hub of the syringe can be connected to a 14 gauge cannula, and then you can suck it directly. With a narrower gauge, the catheter ruptures, tears. So
excellent points. Thank you, sir, for elaborating so well. Aditi, go to the next case.
So next case is a 23-year-old lactating primary female, 2 months postpartum with no comorbidities, who came to our clinic with blackening of entire left breast since 2 days. She underwent IND 4 days back at another hospital, but when she presented to us, there was absolute blackening. This is a clinical presentation. Dr. Rachni Kelkar, ma'am, could you emphasize what would be the take-home message in such a scenario where a patient has undergone IND, what the first surgeon should have taken care, and what would be the further plan of management?
Thank you, Aditi. As you can see the pictures, the whole breast is gangrenous, and you can see the post-operative picture also. This patient came with, as Aditi said, with a history of incision and drainage done 4 days back, but it did not improve her. In spite of the incision and drainage, she kept on worsening. She had very high fever, and when I saw her about 104 degrees, and this was her clinical picture. And you can very well see this small incision which was made in the inner central quadrant. but obviously I think it failed to drain the complete pus, which was probably in all the quadrants of the breast, and this was the outcome within next 4 days. So some infections would be very aggressive, and incision and drainage, although we recommend that we should take minimum incisions, and the incisions should be more cosmetically oriented also. I think the incision should be good enough, adequate enough to drain all the pus, and we need to check what are the areas involved. If necessary, we really need to do, if the clinically, if it is not sure, we really need to do ultrasound before we go ahead with any incision and drainage. And wherever we are planning to operate, we have to make sure that the other quadrants of the breasts are not involved, because this is a total disastrous situation. This was a primary patient, and she almost had a partial mastectomy at that time.
Thank you, Dr.
Aditi, one question we forgot to ask in the last this thing was whether breast feeding can be continued with an abscess sitting or it should be stopped. And if you're, yeah, any of the panelists can take. Kumkum Singh, madam, you can take.
Continued.
Yeah, we should always
Must
continue and encourage the patient to continue breastfeeding from the affected side also. Although the patients are very apprehensive that the breast milk would be infected, but I think it is always advised that they should be encouraged to continue breastfeeding from that side. It should not be stopped.
Unless until the nipple is pouring pus. So only
And
in
another
that
thing is
situation we will.
if the baby develops sudden diarrhea, then that is a sign of patient, the baby getting infected milk. Then we can stop for a while.
Okay. Yeah, Aditi.
Because patients, you know, Rajshri, continue to feed from the opposite side, and the milk
Yes, I
continues to
agree.
collect. So that is why it has to be. Yeah.
Yes, the
Either
other
you have to
side, yes.
evacuate. If they do not want to feed, they should evacuate at least with a pump.
Agreed. But on the affected side, we can stop, and the other side they can continue. Totally agree.
Aditi, please move.
Yeah, thank you very much. With this, we complete breast abscesses. Next case is a 34-year-old female who presents with pain and heaviness in both breasts, which persists throughout the cycle. In fact, 60 to 70% of our OPD, breast OPD, would involve mastalgia patients. Anurag Srivastava, sir, could you please explain us what is your protocol for all these mastalgia patients?
Thank you, ma'am. So mastalgia is defined as a pain persisting for more than 1 week in the menstrual cycle or in 1 month, occurring at a pain score of more than 3 on a scale of 0 to 10. So pain score of more than 3 on a pain scale of 0 to 10, persisting for more than a week, should be called mastalgia. And we should first assess by triple assessment. If there is no discrete lesion, no abnormality to be found, then it is pure mastalgia. We need to distinguish true breast pain from other causes as bilateral chest wall pain and true breast tenderness. Having done that, then you can have either mastalgia with nodularity or without nodularity. So initially, we reassure the lady after the reports of the imaging comes, and if there is no suspicious lesion, pain chart, we teach the lady how to fill the pain chart. We have developed our own pain chart in AIIMS. It is readily available. It's free of charge. We can send it to you. It's published in Indian Journal of Surgery. So pain chart for 1 month. Sports bra, properly fitting sports bra, one size tighter. If the lady's size is 30, she should be encouraged to wear 26 or 28 size, cup size in daytime. In the night, they can remove it. There are randomized trials to prove the efficacy of sports bra, well-fitting sports bra. Then third thing is flax seeds. Flax seeds are a rich source of omega-3 fatty acids, and Canadian breast guidelines recommend flaxseed as the first line of therapy. We also use it for many years. 30 grams a day is the dosage. 30 gram. Alsi ke beej, Hindi mein alsi ke beej bolte hain. Flaxseed, a very rich source of omega-3 fatty acids, 30 gram daily. And diclofenac gel or pyroxicam, NSAID gel, locally to be rubbed very well in large amount, 10 to 15 minutes rubbing over the painful areas. And this, she goes with this prescription, comes back after 1 month. If pain is still more than 3 on a scale of 0 to 10, she probably needs some systemic therapy. Systemic therapy, we usually give anti-estrogen. If ovaries are normal on pelvic ultrasound, we give Centroman, Saheli, or Meloxifene. in the dosage of 30 milligram alternate days. If ovaries show features of the PCOD, then we recommend tamoxifen, because PCOD is a contraindication to Centroman. And this we'll give for 3, sometimes go to 6 months. If pain still remains more than 5 or 6, in spite of this anti-estrogen therapy, then it is called recalcitrant or resistant mastalgia. And then we have other things like total estrogen blockade with LHRH analog along with Centroman or tamoxifen. This is in short.
Excellent.
Thank you, sir. At times, when we are planning to give the patient tamoxifen, as well as if we are planning for total LHRH blockade, would the pregnancy be affected if the patient is planning for future pregnancy?
Yeah, so first thing, when the lady comes on first visit, ask or talk to the husband also. Are you planning a family? If they are planning a family, then do not give any hormones. Estrogen, the anti-estrogen, tamoxifen, Centroman, danazol, they will all not support the pregnancy. So first thing is to talk to the family. Are they planning family? If they are planning family, going for children, no hormonal agent, including danazol, is harmful. So they will not support pregnancy. That's first thing. If they are not planning family, then total estrogen blockade should be done in consultation with the endocrinologist and gynecology department, because it is more than just treatment of the breast pain. So we always let a referral from endocrinologist to rule out any other endocrine conditions, and they measure LH and FSH as the baseline hormone level, and they also get a referral from gynecology.
Sir, many occasions you see even unmarried girls with a lumpy breast, especially premenopausal, and those decreases after the menses are over, and do whatsoever, their pain does not go away. In such kind of conditions, what would you advise? The same protocol or something changed?
Right. So we have done randomized trial also, that the Centroman, tamoxifen, or even danazol, as it controls the pain, also controls the nodularity and the lumpiness, as you say. In some patients, it may persist. Then, if you have done triple assessment, there is no sinister disease underlying, you can just reassure and let her continue with the, if it is not painful, if it is only nodularity and no pain, then after 3 to 6 months of Centroman or tamoxifen, you can just reassure that this is your structure, your body, and she can learn to live with it if it is not painful.
Any reason why Dr. Raghuram said no to evening primrose oil or some GLA tablets which are available?
Right. So in our meta-analysis, we found that evening primrose oil has about 30% benefit, which is same as placebo. Please remember, like peptic ulcer disease, mastalgia also has a running periodicity. It comes and goes. So whatever you give, it will have remission and recurrences, just like peptic ulcer disease we used to read. So we have to do a controlled trial with the placebo or with some other thing. So those trials and our meta-analysis showed that evening primrose effect is similar to the placebo. So why give expensive drug which has similar effect to placebo? As long as danazol is concerned, danazol is very effective. In meta-analysis, it was very potent therapy for mastalgia, but it has many side effects. The girls don't like it. Unke daadi much nikal aati, hirsutism. Weight gain, because it's a anti-gonadotropin. So weight gain, menstrual irregularity, and hair growth, masculine voice. So these are, the girls don't like it, and it is cost at least 12 to 14 rupees a tablet. Whereas tamoxifen is 2 to 3 rupees a tablet, Saheli is again 3 rupees a tablet. So cost is very much, side effects are too much. And in our randomized trial, actually 69% was the benefit with danazol and 89% with Centroman. So danazol is less effective than Saheli, Centroman. So many reasons to avoid danazol. And another drug to avoid is the vitamin E, Evion. All practitioners for mastalgia give 2 things: Evion, vitamin E, and evening primrose. Both should be avoided.
Very good take-home messages on mastalgia. Aditi, you can move forward to the next.
Thank you, sir. Next is we come across a lot of
Dr.
patients with
Agarwal,
nipple
I just wanted
discharge.
to say,
Raghuram sir has given us a very good guideline for nipple discharge, what needs to be managed. But still we happen to see a lot of ectatic patients coming with reports of ectatic ducts. So how do we manage this? Dr. Anjali, could you highlight on how can we manage these patients?
Yes, Aditi. Now, duct ectasia is basically a phenomena which comes under the aberration and normal involution in development called as ANDI, which the concept which has taken in a big way in last 10 years. The accepted diameter at the terminal end where the nipple areola complex is 1 to 2 millimeter is the normal ductal diameter. But when this diameter is of size 3 and above, 3 millimeter and above, it is called as the dilated duct or a pathological dilatation. Now, in ANDI, there are 4 different components to evolve. One is cyst, one is fibrosis, third is epitheliosis, and fourth is papillomatosis. Now, whenever there is a dilatation of the duct, it can be a focal uniform dilatation throughout the length of the duct. That is one. Second, if there is segmental fibrosis of the duct, it can give rise to multiple cysts within a single duct. Third is if this cyst formation and ductal fibrosis undergoes into various pathological changes, there will be hypersecretory epithelium. The epithelium proliferates and it becomes more secretory, and that gives rise to atypical changes of the epithelium. That is a fourth part. And after a certain period of time, there is papillomatosis, which is known. Once the papilloma within the duct develops, it can be very well seen in ultrasound, and nowadays ultrasound of the breast, which is a high resolution ultrasound, it can be very well seen. So ductal dilatation is it can be most of the time physiological, seen mostly in the 30s and 40s perimenopausal age group. It is actually a misnomer where it is a physiological alteration called as the involutory and aberration changes. Now, what to do in such cases? One is we can go for triple assessment. Once the triple assessment has been done and it has been said that the ductal dilatation is nothing but there is a formation of cyst. In such cases, we can go for aspiration with a white bore needle. This aspiration, once we have done, the residual disease which is there, if it persists and if the patient develops nipple discharge in subsequent time, if there is a fibrosis of the duct, there can be chances that the nipple may get retracted. There can be blood-stained nipple discharge, and in such cases, we have to, since from 2017, we have started the microendoscopic ductoscopy at our center, and in our experience, we have done up till now the 50 cases, and almost 30% incidence is a papillomatosis. It can be a single papilloma, and various cases are florid papillomatosis. So always think that whether it is a part of ND, whether it is a simple cyst. Third thing, even if the lumpiness or the nipple discharge, if it resolves and if it responds to the treatment, well and good. But fourthly, if the nipple discharge persists, maybe serosanguinous or bloodstained, you have to think whether the duct has papillomatosis. Fourth thing is, there can be a last line, do not, to label it as a duct ectasia, do not miss the in situ ductal carcinoma. So these are the take home points.
Thank you very much,
Yeah.
Dr. Anjali. It was a very elaborate discussion. Moving on to our next case, where we have a 32-year-old female who's presented with asymmetrical enlargement of the left breast as compared to the right one, and she was having this issue since last 10 years. Dr. Rajshri Kelkar ma'am, if such a patient walks into your clinic, what would be your differential diagnosis for such a patient?
First, I think is most important is to do a clinical breast examination and a proper triple assessment. Clinical breast examination, as this patient is very young, only the ultrasound would be sufficient, and followed by a true cut biopsy. Nowadays, I prefer to do true cut biopsies over FNACs, and that is what I have made my own protocol. And that is how we should be going for this. But this is a very large asymmetrical breast, which you are seeing on the left side. And since I know this patient, this was a very rare condition called hamartoma, which was myoid hamartoma, which was about 15 centimeters. So you do get occasionally very rare tumors which are not seen on a very regular basis. But I think the triple assessment should be followed in all such cases.
Madam, would you keep giant fibroadenoma, phylloids as your differential diagnosis?
Yes, that would be. But for me, this true cut biopsy did show hamartoma, but they were not sure because they could not do any IHC over that. It was a very well defined on mammography, if you have the mammography picture. A very well defined and well encapsulated tumor. So there was no fear, and this patient actually was following with me for 10 years, but somehow she did not come for surgery. So we could easily take out the lump. Yes, Dr. Niranjan.
Kumkum ma'am, can you add something about phylloids in this, such kind of patients? Kumkum ma'am?
Yeah, phylloids does not present in a unilateral enlargement like this. It would present with a oscillated
Your
tumor.
voice is not clear, ma'am.
Your voice
is not clear, ma'am.
Hello, can you hear me now?
Now it's clear. Yes.
My video is gone. I don't know. Yeah, the presentation of phylloids is slightly different from, this is a uniform enlargement of the entire breast, whereas phylloids tends to be present as a large tumor. It is mainly a unilateral tumor, and it is normally suspected when the patient is around the 30s. And this tumor tends to grow very rapidly. And this tumor, which you are showing on the film, was around 10 years, persisting since 10 years. So I would not put phylloids as my diagnosis here. Phylloids has a different presentation. It has a bosselated surface, large tumor, maintenance of nipple areolar complex, no fixity. The tumor remains mobile even in spite of having a large size. And as Dr. Rajshri said, she has done a sonography, and if it would have been a phylloids, it would have been picked up on a sonography. But I would not keep phylloids as a diagnosis for a tumor, for a enlargement of the breast, which is present for the last 10 years, and a uniform enlargement of the breast.
Ma'am, if the biopsy is suggestive of phylloids, then how would it present different from fibroadenoma that you have already explained? But how do then we further operate these patients? What care do we have to take?
Now, basically, fibroadenoma is in the younger age group versus phylloids, which occurs in the later age group. Fibroadenoma can be single, multiple in both the breasts, whereas this phylloids tends to be unilateral. When the diagnosis is confirmed by a core biopsy, we do not take a FNAC for confirmation of phylloids. It is always a core biopsy, which will tell you whether it is a benign tumor, or it is a borderline tumor, or it is a malignant tumor. According to the Anderson Cancer Center staging, benign tumors constitute about 58% of the tumors, borderline is about 12%, and 30% of the phylloids tends to be malignant. So important is a core biopsy. A mammography would show a halo sign, which is due to compression of the tumor. And if a pathology examination will also show, ultrasound examination would show solids, lesions, based along with cystic spaces in between. So if we are confirmed that we are dealing with the phylloids, then the approach would be, in phylloids is notorious for having a recurrence. It is very notorious for getting a recurrence in spite of the best efforts. So in a tumor, when we are dealing with phylloids, we have to take a wide local excision. That means you have to take according to NCCN guidelines, 1 centimeter clearance zone all around the tumor as well as in the depth. You have to have a margin of 1 centimeter clearance is very, very essential. A fibroadenoma simple can be enucleated, but a phylloids has to be a wide local excision has to be done. And this also again depends, the treatment would also depend upon the breast and the tumor ratio. If suppose the breast is small and the tumor is of a large size, where we cannot get a wide local excision is not possible because the architecture would be distorted. In those cases, then the patient has to be counseled and we have to go in for a mastectomy. But if the breast is large, voluminous, with a tumor where we can get a wide local excision, where a good margin of clearance is available, then the treatment is wide local excision.
Yes,
Aditi,
ma'am.
we have only 6 minutes left. Better take the granulomatous mastitis first, followed by gynecomastia. Take the granulomatous mastitis first.
Yes, sir. Divyam. Sir, I will take it. So can we first take gynecomastia?
Okay, fine. So again, Anjali or Jayashree madam, whosoever, traditionally gynecomastia we see occurring in a young boy or just a teenager, which is of more or less equal size. But sometimes you see it unilateral gynecomastia, and maybe in a slightly more adult. How would you evaluate this patient and what treatment would you offer to them? Jayashree ma'am? Pandya madam?
Yeah, this is a 24-year-old boy who has got gynecomastia on one side. That is what the picture shows. And basically, after we have ruled out that there is no other cause for the gynecomastia, this is a cosmetic surgery which we have to do. Now, in the present era, initially we used to take a perioral incision, and then we used to dissect out the disc, and we used to reduce the gynecomastia. But nowadays, the trend is more for a liposuction. And later on, after the gynecomastia size decreases, then we can, then after a couple of months, the breast takes the size of the other breast and cosmesis is achieved. Only if it is a case of bilateral gynecomastia and there is asymmetry of the breast, then we have to decide which side is the left side of gynecomastia, which will look normal, because removing excessive of gynecomastia will give rise to absolutely flat chest, which also may not be cosmetically acceptable.
Many times you feel that the gynecomastia disc is quite hard. In such kind of cases, would liposuction only work for them? Because that would not be, one would not be able to remove the hard disc.
If the gynecomastia has a hard component, then liposuction would not help at all. Then we'll have to tailor our treatment with excision and liposuction to achieve the best cosmetic result.
Any other faculty wants to say something more different, not the same thing?
I
If you
would
have
like
any
to
other
say,
point, please add.
Yeah,
Yes,
just
sir,
one point. Books describe
Sir,
use of
sir, Anjali,
tamoxifen. Books describe use of tamoxifen. So we did a study on 50 patients with gynecomastia, and none had any effect, significant reduction of gynecomastia with tamoxifen. So we have stopped using tamoxifen, although books describe as the first line treatment. So that is one point. And
Anjali,
subcutaneous mastectomy has to be done for
yes, sir.
large.
I would add, on ultrasound, we have to differentiate the type of gynecomastia, whether it is totally fatty breast, whether it is a mixed type of breast, whether it is a dense breast. That will decide your crux of treatment. If it is a totally fatty gynecomastia, liposuction is the best. If it is a fibroadenotic and fibrotic element is more, you have to think of the excision. That is take.
And excision is nowadays done based on oncoplastic procedures, like the inverted T approach or the Benelli's type approach can be done for this, preserving the breast architecture.
So we are reaching our closure. Aditi, take the granulomatous mastitis.
So this is a 52-year-old female who has presented with nipple discharge and multiple discharging points from various aspects of the breast, which we clinically consider as chronic granulomatous mastitis.
14
I would
hours.
request Anurag Srivastava sir to give us some management guidelines for such a case.
Right. Thank you.
In just a minute, moderator, sir, request. Time is very short, and we are.
This is the last slide. Don't worry. I'll wind up. I will wind up. I am here. Don't worry.
I'll go very fast. So,
yeah,
non-lactation mastitis. Examine the breast. If it is central, that is around the nipple areola complex, subductal, periductal, near the nipple, then palpate the milk ducts. If milk ducts are thickened or there is fish mouth-like retraction of the nipple, we are dealing with periductal mastitis. Periductal mastitis, also called plasma cell mastitis. Treatment is initially assessed for presence of any subaerular abscess or sepsis or milk duct fistula. If these are present, then we need to remove the milk ducts. Limited Hatfield operation. About 1 to 1.5 centimeter milk duct has to be removed after initial 2 to 3 weeks of antibiotics. Antibiotics must have anti-staph and anti-anaerobes. Bacteroides spread. So we give a combination of ciprofloxacillin and tendazole or cefuroxime and tendazole, or Taxim-O, cefexime plus tendazole for 2 weeks. If there is no inflammation, we go for limited milk duct excision, 1 to 1.5 centimeter Hatfield operation. If lady has completed her family. If she has not completed, she wants to continue breastfeeding, then try to avoid surgery. If it is a peripheral type, you have to consider either tuberculosis or granulomatous mastitis. If the histology shows granulomas, epithelioid cell granuloma, we treat it like a multidisciplinary team discussion with pulmonary physicians, pathologists, and radiologists. It's like MDT for cancer. So here we choose pulmonary physicians because they are experts in tuberculosis. So they do HRCT, they do Mantoux test, PPD, and assess for other stigmata of tuberculosis. If they are present and the chances of tuberculosis are higher, they start with anti-tubercular therapy. If it is low, then we consider as granulomatous mastitis. Option is start with non-steroidal anti-inflammatory drugs. If they do not respond, then prednisolone is the last resort that I want to emphasize. So we did a study on 60 patients by this approach, disease analysis approach, discussing with pulmonary physician, and found that only about 2 or 3 patients required steroids. So have this approach, multidisciplinary approach, and then number of patients requiring steroid will be very low. Thank you.
Thank you so much, all the panelists, for a very crisp and a very clear-cut take-home messages for the delegates. Since time is up, I know there are many issues which can be covered, but over a period of time, we will see some videos or some panel discussion which will cover all the other remaining things also. So thank you, Aditi, for co-moderating, and Rajeshri, Anjali,
Thank you very
Anurag
much,
sir,
Dr.
Kumkum ma'am, and
Niranjan,
Jayashree
Aditi,
ma'am
and all the
for
other
being with us
panelists.
today and deliberating. Thanks, everyone. Over to
Thank you, everyone.
Ritesh for the next session.
Thank you.
Thank you so much, sir, for such a nice panel. I thank moderators as well as all the panelists on behalf of Mumbai Surgical Society. Coming to our next session. This session is invited lectures on changing paradigm in breast diseases. The chairpersons are Dr. Neeta Nair. She is a professor and consultant surgeon at Tata Memorial Center, Mumbai, India. She has multiple publications and she has a research interest in breast cancer. She has a special interest in oncoplasty, young women cancers, TNBC, and quality of life improvement. There is a change in name of chairpersons. So this session will be chaired by Dr. Shishir Shetty along with Dr. Neeta. Dr. Shishir is a head oncology at Apollo Cancer Center. He is a head surgical oncology at Dr. D.Y. Patel Medical College and Hospital. He is a thoracic and GI hepatobiliary surgeon, robotic rats, vets, and a minimal invasive cancer surgery, and a special interest in tracheal tumors and reconstruction. He is also treasurer of our society, Mumbai Surgical Society. So we welcome you all, Dr. Neeta and Dr. Shishir Shetty. Please take over and introduce to next speakers, please.
Thank you so much. So after a very interesting discussion on benign breast diseases, we're going to move forward towards oncology and the surgical practices and how we're changing paradigm. Our next speaker honestly doesn't need any introduction in a forum like this, but it gives me immense pleasure and an absolute honor to introduce my mentor and guide, Dr. Rajendra Badve. He is the current director at Tata Memorial Center, an absolutely eminent breast surgeon and oncologist, and a doctor par excellence. I think this slide does not do justice to his actual affiliations and achievements, so I'm going to leave that there for you to read and hand over to Dr. Badve. Sir, the floor is all yours.
Thank you, Neeta. Neeta, would you mind putting up these slides, please? By the time the slides come up, let me give a short introduction. Over a period of time, it has been ingrained that we don't operate on somebody who presents with metastatic breast cancer. Such patients' need for surgery is based on either fungation or bleeding or intractable pain. And I must say all those three indications are standard indications. In my whole experience, I have yet to see a single patient whose breast surgery has not been done complained of intractable pain on the chest wall. That's a rarity, extreme rarity. Unless the tumor is completely infiltrated onto the chest wall and the whole chest is covered, that's again a uncommon feature, and in which case surgery is not even possible, even if you want to do it. So the role of surgery has, for years, conventional wisdom has said that we shouldn't be doing it. Next slide, please. Let me quickly run you through indications for mastectomy being fungation and bleeding tumor. Next one. The evidence, I'll put up some evidence against mastectomy and then some evidence, experimental evidence, of course, and then some evidence in favor of mastectomy in the form of retrospective analysis. And then I will quickly present our study and give you a review of what's being done globally and how many more trials have followed our trial in India. Next slide, please. So this was the Fisher experiment, and that experiment had a mouse experiment wherein a primary tumor was created in the subcutaneous pocket. Once the tumor grew to a certain level, then another small tumor was implanted somewhere else, assuming that this is a micrometastasis which has evolved over a period of time. Post that, as the second panel or the second mouse there, the primary tumor was excised and the secondary tumor there was observed to understand what happened. And it clearly showed that, next slide please, that there was a rapid increase in growth after removal of the primary tumor. And here is in the first panel, figure 1, you will find that the top graph that shows a Parvatasan, if I may use that word, is something that rapidly shows an increase in the thymidine labeling index after removal of the primary. The vertical line to the left is the event of surgery, and then we have the thymidine labeling index going up rapidly. They also did the study with chemotherapy, which is the inverted U on the same graph, inverted U, that there was a rapid reduction, but then rapid increase also after surgery. So the rapid increase slope is similar to what post-surgery you would see in the first graph. But the same rapid increase and decrease was not visualized when tamoxifen or LHRH agonists, that the middle graphs, LHRH agonists were utilized. And there was a figure 2 shows that the thymidine labeling index clearly showed a rapid rise in proliferation after removal of the primary. But this is animal experiment. Do we have any evidence in literature, in our own human experiments or in human beings ever it happening? And you might say that, yes, sometimes you do see when you operate on somebody, there is a rapid onset of metastasis in a short duration of time. And you wonder what has happened. Is there something like a switch that once put on produced a rapid and massive growth of metastasis in multiple organs? We blame that on the virulence of the tumor, as it is usually that when we don't know what it is and we don't want to accept that we ourselves might be responsible, blame it on the tumor. Next one, please. So that's the survival benefit. All these studies, which are individual, institutional, retrospective, all are retrospective studies, show a remarkable improvement anywhere from 30 to 50% improvement in survival in those who have had surgery versus those who have not had surgery. Albeit, those who were selected for surgery had a major selection bias. Next slide. The same thing is also visible when we do a population-based analysis, and you find exactly similar difference in population-based survival benefit in those who have had surgery. But this is even further fraught with biases. Next slide, please. here are some studies where there was no survival benefit, and there was some kind of matching done for those who have had surgery versus those who have not had surgery. And this matching reduced the possibility of that survival. So there was a debate as to, is it really helpful, and should we be challenging our dogma that surgery is not required in individuals who present with metastatic disease? Next slide, please. So we ran a study to assess the effect of removal of primary tumor and axillary lymph nodes, and the primary endpoint was overall survival. The secondary endpoint was progression-free survival, more so for distant progression-free survival, since the animal experiment suggested that if you remove primary, the distant metastasis grows rapidly. Next slide, please. What we did was that we had 350 patients as part of the study, and that's the statistical jargon. I don't have to go through that. Next slide, please. We selected these MBC patients. Almost all out of these 350, almost all of them except some 5 patients who received preoperative hormones. All others received anthracyclines or taxanes. Those who had CR or PR were the ones, after being stratified for site of metastases, number of metastases, whether oligometastasis or not, or ER/PR positivity. After this stratification, were randomized to receive locoregional surgery followed by radiotherapy, and in the other arm, no locoregional treatment at all. So locoregional treatment in totality versus no locoregional treatment is what the randomization was. Next slide, please. There were 350 patients, 173 in locoregional treatment, 177 in no locoregional treatment, and I described to you that they received standard treatment, the rest of the chemotherapy and hormone therapy as one would consider standard for hormone receptor positive tumors. Next slide, please. That's the demographic characteristic of distribution of bony metastases. There were some 26% who were oligometastases, 74% were multiple metastases, and fairly large number, 60% were ER/PR positive. These were the days when Herceptin was not easily available to be utilized, and hence we have not considered HER2 positivity, although we did the HER2 assessment in them and both the groups had similar HER2 positivity, but none of them received HER2 directed treatment. Menopausal status was also similar on both sides. Next slide, please. Very small percentage had protocol violation, 1.7% in no locoregional treatment and 5.2% in locoregional treatment. I would like you to understand the second line here. We keep on telling our patients that this might fungate, and that's the reason why I might want to consider surgery. Not actually fungated, but might fungate. Now that fear happened only in 10.2% in these 28 months, 32 months of follow-up post-operatively, that only 10% had fungation or indication of performing per protocol surgery in no locoregional treatment arm. So the thought in our mind that local progression might lead to we resorting to surgery is not very common. It's in fact uncommon. 90% of them did not need this kind of intervention. Next slide, please. That's the survival graph. That was the primary endpoint. Overall survival is no different in no surgery versus a surgery arm. Conventionally, if I were talking about a treatment and if the hazard ratio is 1.04, I would relate this or express this as there is 4% detriment which does not reach statistical significance. Although in this situation, if you look at the overall survival, 20.5% and 19.2%, so 4% detriment that does not reach statistical significance. The graphs are lying one on top of the other, and so there is absolutely no indication of doing surgical intervention. in those who present with metastatic disease. Next slide, please. I wanted to know that we do this usually I mean, we can keep on arguing that this may be in subset, that it may be important. This is a forest plot for various subsets: menopausal status, metastasis to bone versus not, metastasis oligo versus larger metastases, hormone positivity, HER2 positivity or negativity. And you will find the right-sided forest plot has nothing to offer. All of them are exactly similar. There are individuals who have argued with me many times that oligometastases might be benefited, but I want you to look at the oligometastases. In fact, 1 to 3 node metastases have the plot, which is to the right, indicating that there is in fact a greater detriment in oligometastases than in frank metastases. So in general, nothing much to say. No subset stands to benefit, whether it is hormone positivity, HER2 positivity, or anything else. Although you might argue that HER2 directed treatment was not given, so you can't really see the difference between the two. But suffice to say that responsive treatment in the form of hormone was also given, but there is no difference. Extending that, I wouldn't anticipate, even if HER2 directed treatment was given, there would be a difference whether surgery done or not. Next slide. But that's a matter of conjecture. We usually do this for local control and look at the local progression-free survival. Hugely different. In fact, such a huge difference in local control yet has not translated even 1/5 or 1/6 of what this difference, big difference is. Now, is there something else that we are missing? That such a huge difference in local control does not translate. If I were to look at EBCT-CG local control meta-analysis, for every 4 local recurrences avoided, there is 1 life saved. So a 25% reduction in lives saved, and yet such a large difference in local progression free, and yet we don't see any difference in overall survival. Take me to the next slide and you will see why is it so. This is the distant progression free survival. And I want you to understand that the blue graph, which was underneath in the previous slide, is now on top. That no loco-regional treatment, which is lower down, is in fact having a better survival compared to loco-regional treatment. And that reaches a statistical significance. So there is rapid progression of distant sites by removal of primary. Something that was seen in animal experiments for the first time is now visible in human trials. So this was the first time that we reported this. Someone else also has a mic open. Anyway,
request everyone else to mute their audio, please.
Right. So suffice to say that removal of primary tumor did bestow a growth advantage on distant metastases. That was the biological take-home message. Next slide, please. To conclude, the loco-regional treatment of primary tumor in women presenting with MBC did not result in overall survival benefit and hence should not be offered as a routine practice. This was the first randomized and the largest randomized trial to date, 350 patients. Surgical removal of the primary tumor in these women appears to confer a growth advantage on distant metastases. Now, since this trial, there have been 3 other trials that have been published. That was the first one that I showed just now. 1.04 is the hazard for overall survival and distant disease-free 42% detriment. The next is the Turkish study that showed a 14% benefit that did not reach statistical significance. Soran study did not report on the DFS distant disease-free survival. Seema Khan's ECOG trial has 256 patients, 9% detriment in overall survival that does not reach statistical significance. She also did not report on distant disease-free, although in her text, she does say that the median progression time for distant site was 24 months in surgical intervention and 46 months in non-surgical intervention. So there is obviously a difference more in favor of non-surgical treatment as far as distant disease-free survival. Fitzgerald is trial also had a 12% detriment in overall survival that does not reach statistical significance, and a distant disease-free survival having a 90% detriment in disease-free survival related to distant site. So almost all trials showing a distant progression after removal of primary. Now the fifth point, Seema Khan's paper, the ECOG study, did look at quality of life. One might argue that quality of life might improve remarkably by people who have had surgery. In fact, it was significantly worse midway between the trial in surgery arm in Khan trial. So TMS study was the first in human to show the worst impact of removal of primary tumor on distal mets, and all studies show an 80% better local control, and need for surgery in non-surgical arm was between 10 to 16% only. The thought that I described earlier, that we do tell our patients that I might want to do surgery because this might fungate, this might produce pain, but that happens in a very small percentage over a period of 2.5 years time, wherein 10 to 16% undergo surgery. Suffice to say that 4 studies put together, we have close to 900 patients on these trials, and in 900 plus, close to 1,000 patients, there is no difference in overall survival when surgery was performed in distal metastases, those who presented with distal metastases, and also that distal metastasis did grow faster in individuals who have had surgery. Next slide, please. I would like to thank my colleagues and all these brilliant and very brave women who participated in this study, and of course, support from the Department of Atomic Energy Clinical Trials Center. Thank you very much. I hope I have stuck to the time.
Thank you, Dr. Vadve. Excellent talk, as usual. I think you're one of the best that we can ever hear in breast. Thank you so much. I think, Neeta, we can move ahead to the next speaker.
So we'll move ahead to the next speaker, sir, and we will come back to you with any questions that will appear in the chats.
Okay.
Our next speaker is Professor Dr. Chintamani, who is a very famous person who probably was one of the first TNB teachers in Delhi. And he is the president and governor of the American College of Surgeons, international surgical advisor for the Royal College of Surgeons of Edinburgh, member of the Academy of the Master Surgeons Education of the American College of Surgeons, and I can go on and go forth about this. This has more than 175 scientific papers in international and national journals. I would request Professor Dr. Chintamani to please start his talk.
Well, thank you very much. And at the very outset, I would like to thank the organizers, especially Sandeep, for having me into this and asking me to speak on something that he thinks is very important. And he was very keen that it goes to the general surgeons as a message of those who are operating the backwaters, taking care of breast cancer. So every patient doesn't reach the specialized unit. So the talk is basically my ignorance that I'll be sharing with you on this theme or topic, which it can go on. Can I share my screen, please? Thank you very much. Dr. Neeta, very good afternoon to you too. Wonderful to see you. And Professor Budway, as always, truly delighted to have heard. Can I share my screen, please?
Yes, sir.
Is my slide visible?
Yes, sir, they are.
All right. Thank you so much. Well, after a wonderful, wonderful talk on the metastatic breast cancer as to the do's and don'ts, lots of take homes. And I'll be talking about some controversies, some myths and facts, if we can call them facts, relating to breast conservation surgery and mastectomies. I think it has been spoken for ages, and we haven't yet reached where we want to. Well, there are no disclosures. Well, I put them down as 10 issues that probably I would like to address. And this is based on a debate and also a survey that we ran in 2012 when I was the editor-in-chief of Indian Journal of Surgery, asking surgeons as to how do they perceive the concept of breast conservation. And these are some questions that came through, some ideas that came out. And I've added a few to make it a little relevant and relevant to the present day context. Mastectomy is the gold standard for all stages of breast cancer. Well, we will address that. We know that it is not true. Although gold standard is not always the best treatment that you offer to any patient. It's a standard against which you weigh the others. Maybe it's true in that sense, but otherwise we have moved on. Bigger the surgery, better the outcome. It's been long been sorted out. B4 trials and other trials, they've all sorted it out. It's not just equivalent. In fact, it's better to offer breast conservation surgery. Breast conservation surgery is an under-treatment and inferior to mastectomy. Well, again, as I mentioned with the NSABP before, it was proven that the extent of surgery doesn't really make a huge difference in the outcome. As long as it has been done oncologically correctly, you're getting a clear margin. And perhaps if you're adding radiation, they now find that it's not just the equivalent of the mastectomy, it's even superior. Well, that can be argued as to how can it be superior to something that on overkill cannot be less than a kill. But the trouble there is a lot of people feel that with more surgery, there are lots of tissue factors and cytokines that come into circulation which bring down the patient's immunity and response to the cancer and also allow progression. We'll discuss that. BCS is a surgery for the Western patient, and actually mastectomy is an operation for countries like India and other developing countries. Well, we'll address that. It's not true. It's changed. Even in the West, the mastectomy rates have gone up for different reasons in some places, but even otherwise, the rates are not very, very low. So the concept of, even in spite of the screening being a factor which people swear by, the rates have not dropped down drastically. BCT is associated with local recurrence, high local recurrence and distant failures, and we all remember not too far in the past, we used to address when counseling the patient that although your local recurrence rates may be a little shade higher, but your overall survival would be the same. Even this has been now in most studies proven that the local recurrence rates are also lower and it's safe. Highly specialized training mandatory for BCS. Training is needed for anything that we do, including mastectomy. And a good mastectomy is certainly better than a badly done breast conservation surgery. But having said that, it doesn't require some kind of a rocket science. All general surgeons trained in good institutions are capable of picking this up, and this should be encouraged. So it's more the bankruptcy of thoughts rather than the concept of haves and have-nots. Patients usually don't consent if provided with all the evidence. It has been proven in most studies to be absolutely wrong. When patients get all the information for which the clinician needs to have all the information, they're more likely to go for something less radical if they're convinced that the outcome is as good, if not superior. Facilities for MRI, frozen, sentinel node biopsy, mandatory. This is a regular question that is asked. And when we were doing the ABSI modules and we were trying to get a consensus, we got this question from most people. Is it mandatory? There's no guideline that is suggesting MRI is mandatory. In fact, it can be detrimental in a lot of cases because being a very sensitive investigation, you'll pick up lots of artifacts. It increases the rates of mastectomies. So what is usually called a problem-solving tool can become a problem-causing tool in those situations. Frozen is not mandatory, and in fact, it's not available in lots of countries, including UK, where you don't get frozen easily. If it's available, it's useful, it's desirable, but it's not mandatory. Sentinel node biopsy is mandatory, is a very regularly asked question. And I would once again mention that low X-ray sampling or targeted blue node sampling or dye-alone methods are reasonably good. No longer is it permitted that you have a node-negative axilla and you've taken out 20 negative nodes. You can be sued for having dissected axilla. So we moved on, and this concept has to go. Indian patients being younger with advanced breast cancer are unfit for breast conservation surgery. These are questions that were raised during that survey. Well, it's true partly, and it's correct that younger patients may have more re-excision rates, but they're the ones who need the conservation more. So this doesn't by itself becomes a reason, but yes, advanced breast cancer or the larger sizes, we need to find solutions to that. We need to get them early. Of course, that will take a while, but when you get them, it is possible to downsize them with the neoadjuvant systemic therapy and actually offer them breast conservation. So it's more in that intent. So it's feasible if if you have all those factors falling into place. Lastly, it's more expensive, requires conformal RT and rigorous follow-up. Last two are definitely on. If you have, in any cancer patient, follow-up has to be there. It's not just for the breast conservative surgery, it's for mastectomy as well. But yes, you need to more rigorously follow it up. Patient has to follow up for radiation, etc. Conformal RT, it's not available at lots of centers, can be an issue. And there are people who provide reasonably good and equal, I wouldn't say equally good, can't be, with the external beam or the cobalt therapy, but it's desirable. But expense-wise, there are studies to prove that it is not. So it's not our abilities that show what we truly are, it's our choices, and we need to make them correctly. We need to tailor it to the patient, to the center, to the surgeon, and where you are. Well, I won't take a lot of time here. We all are familiar with the Halstead's concept of the whole thing being very, very local and being therefore being extra radical, and believing that it's the echelon-wise spread of cancer. So if you take all the echelons en bloc, the chances of getting cure are there. Well, I'm not deliberately showing that slide, which is very commonly seen in most presentations, where they show the hollowed out chest, a very depressing sight. Well, full marks to Halstead for actually starting with the process at one point of time. And although we can speak against it, but it formed the basis of most of the studies and most of the realization that happened later. With 2 years data of nearly 18 patients who were mostly locally advanced, he showed a survival of, 5 years data, which showed survival of 3 years in the American Surgical Society meeting. And of course, it was too ghastly, it was too radical, but that's how we thought at that point of time. Came Fisher in 70s, and we understood. With the one great thing that happened was the trial started to find out what is it that we are actually doing, what is it that we can do, and what is it that we can do to make it less radical. And the equivalence was more or less established with B4, as I mentioned, but now it is believed that breast conservation surgery is superior to mastectomy. Well, these are the two graphs. You can see the breast conservation, the purple one going up, and it's happening world over. So the paradigm shift was cure or cosmesis versus cure and cosmesis. And it started with B4, as I mentioned. It was actually two trials in one for the node negative group, and the other one was node positive. And they found that after 5, 10 years and 25 years follow-up, the survival, the disease-free survival, the breast cancer specific survival, they were all the same. And this was basically, they were randomized into total mastectomy with radiation, radical mastectomy for the negative, for the positive arm, radical and the simple with radiation, and the other one with the simple mastectomy and radical mastectomy and simple mastectomy with radiation. So they observed that the outcome was more or less the same. And he didn't stop there. He went on to study for 20 years with the backdrop of B4, lumpectomy and the radiation, and it was observed that it's as good, and therefore it became the standard of care for early breast cancer, and today that is the standard of care. Now, B17 was applying the concept of B6 and also the in situ cancers that were paradoxically being treated more aggressively in the form of mastectomy, while the invasive cancer got conservation. It was observed that the same, more or less the same rule could be applied. One was always concerned about the multicentricity and the kind of factors associated with DCI. So the margins was initially 10 millimeters, then 5, and finally we all agreed on 2 millimeters. We had a webinar yesterday on this, and I'm sure a lot of you attended. Called GB9343 finally was based on the B6, some subset of B6 patients who did not benefit much from radiation, and now we do have a subset of patients where you can even do without radiation in breast conservation. B32 took us from the axillary dissection, the conventional one with morbidity, to sentinel node biopsy in node negative axilla. One is not trying to write off axillary lymph node dissection, which is still the gold standard against which you titrate it all. This was a randomized phase 3 trial, which actually brought out that you can do sentinel node biopsy, which is as good. And Z11 went a step further, although it has its issues, a non-inferiority study which was underpowered, which showed that even if the sentinel nodes 1 to 2 are positive in a favorable group of patients, you may actually omit axillary dissection. And Emeros was, once again, suffering from the same issues, but it did show that radiation can, to a degree, replace it. And that is where it was also observed that the lymphedema rates could be could be an issue with radiation when with exudative dissection, perhaps higher 5 years later. Now, this is the backdrop. I think I've touched it already. And one should notice, especially the Z11, the mean tumor size was 1.7 centimeter. Here, they were randomized into one where we did the dissection, the other group where we did not. But it had its issues: premature study termination due to low accrual and low event rates, the protocol non-compliance, high percentage of patients lost to follow-up, no mention for the patient in the study that had ITCs, micromets, etc. Most of them were T1 and hormone receptor positive, a good group of patients where you were supposed to have a good outcome anyway. And they all received tangential breast irradiation, which meant that axilla got unwillingly exposed. I mean, it was receiving the radiation. So the group where we were actually doing exudative dissection, they were exudative dissection plus radiation. So naturally, the morbidity had to be more. The authors themselves mentioned in their study, and also during the ACS, I happened to attend that, that discussion when it was happening, that it cannot be extrapolated to the scenarios that are mentioned here. Treated with mastectomy, those with 3 or more than 3 positive nodes, matted nodes, history of prior breast irradiation, of course, neoadjuvant chemo, something like the profile we have in this part of the world. And you must find Indian solutions to Indian problems rather than these American solutions to your problems. So you need to find your patient, your management, and usually it so happens that we extrapolate those trials, and we tend to use this as a backdrop to implement, to use it in cases where it may not be even applicable. So this is to define BCS. We are all familiar with this, so I'll skip it. It's important that lumpectomy is with clear margins in all 3 dimensions. So the lump comes out like a ball all around. And addressal of axilla, either a sentinel node biopsy when it is negative, or dissection, which is, if node negative case, up to level 2, but in all node positive cases, and especially in training institutions, it's good to expose residents to level 3 dissection so that they at least do the level 2 properly. RT is usually desired and required, and it's kind of mandatory in most of these cases. So wherever RT is not available or cannot be provided, usually this cannot be offered. That's what I was mentioning, except for that small subset. And we must achieve the good cosmesis. Otherwise, there's no point doing it. And a badly done BCS is worse than a well done mastectomy in that case. And as we all learned over our training days, and now that mastectomy, a good mastectomy gives you a 25% 5-year survival rate on the table itself. So we must learn to do that first. So it is very important to understand the context. Well, BCS maintains the quality of life, self-esteem, etc. These are the advantages. And it's not mandatory to have MRI and frozen during surgery. What is mastectomy? Well, these are the terms that are commonly used. So mastectomy doesn't always mean the kind of mastectomy one would have seen maybe 20 years ago. They moved on, and they have much better mastectomies. And invariably all over the world, when they do mastectomies today, they talk about reconstruction as well, in cases where it is possible, if immediate or delayed, depending upon whether you're going to give radiation or not. It can be modified radical mastectomy, the conventional one, the skin sparing with reconstruction, or oncoplastic mastectomy, where there are various ways to get some kind of a scar which is good for future reconstruction or even for the present appearance as they would. Goldilocks mastectomies, we do it in cases where patient is not fit to go for the kind of reconstruction which is going to take a long time, not willing for it, not willing for implants. It is possible to do it, and I would share with you a couple of slides where it may be useful. We do that in cases where we can, where we have large ptotic breast and we have a lot of extra skin going through the Weiss pattern incision. You can use those de-epithelialized flaps for building up, along with a LICAP flap or some volume to make it work. These are the regular contraindications, and pregnancy being an important one. Diffuse suspicious microcalcifications, widespread disease that cannot be excised with single incision. Diffuse positive margins, they are absolute contraindications. Relative ones include previous RT to chest wall, active CT disease. With the kind of advances in the radiation, you can offer various treatments even today, in spite of the radiation having been given previously. APBI, IMRTs, etc. So I'm not getting into the details of that, but it's possible. But that's a relative contraindication. The flaps also may not be very good. Active, of course, collagen tissue disorders, more than 5 centimeters is a category 2B, recommendation for not doing it, which means a large tumor, but it will depend. If the breast is large, then tumor breast ratio can allow it, and positive margin, of course. Now, less is more. Equivalence was established with B4, and now we know BCS with RT is superior to mastectomy. Although I said, as I mentioned, it's very difficult to explain it, but this is what has been observed. And the theory of tissue factors, etc., has also not been proven. It's a hypothesis. When performed in these cases also with positive margin, mastectomy didn't add to survival. So it didn't really matter to a great degree as long as you're getting a clear margin. The predictors of failure or the local recurrence after BCS are young age, which is very important. I'd like you to remember that. Most of our patients are younger. That's where we have a catch. Involved margins, naturally, lymphovascular invasion, large size, high grade, post-chemo or hormone therapy. These are post-neoadjuvant systemic therapy patients. Especially neoadjuvant hormone therapy is very grossly underutilized, can be very handy in postmenopausal ladies who are not fit for, or don't have a good performance status, or otherwise ERPR positive and good tumors, but they're large, can be very effective. And we must aim at trying to get some kind of a conservation possible. Well, this is higher local regional recurrence. I deliberately picked up the Asian data to highlight but Singapore is as good as anywhere in the world. And they have probably one of the best screening programs running, and the breast program also is outstanding. But they observed the local recurrence rates are higher. And as Dr. Badwe mentioned in his talk too, the avoidance of recurrence, does it make a difference in overall survival? This is the EBCTG, or the Early Breast Cancer Trial Group overview analysis. The avoidance of recurrence in a conserved breast avoids about 1 breast cancer death over the next 15 years for every such 4 recurrences avoided. So when we constantly keep pushing it down and nailing it down through the patient's head, you will have local recurrence, but survival won't change. It may actually, there may be different twists to it, as you would understand with statistics. Cost and complications were found to be lower with breast conservation surgery. We can always discuss why and what did they observe. And a common myth, the patient's choice for mastectomy. Well, we are attributing it to the patient and his information or her information about the disease, which can be very, very dicey. Now, it totally depends on how the clinician explains to the patient. And we have observed it in our own data, which we are going to very soon publish. Over a lot, in our own breast unit, we observed that the conservation rates improved with our thinking going that way. It is totally dependent on what you are thinking. So as clinicians, we need to be better informed. And that's where the difference would come. Generally, they had, most of the studies showed they felt safer with mastectomy. They did not want the risk of second surgery. They did not want radiation. Other reasons like concerns about local recurrence, and they'll heard stories from others of repeated surgeries. Well, not common with us, and especially with oncoplastic surgeries, you can get wider margins, and we don't have re-excision rates as high as usually you would find documented. They should be anywhere less than 10%. But the choice plays an important role. Patients should be educated properly. So this myth is kind of sorted. More surgery doesn't mean more cures. Bad cosmesis, yes. More physical and psychological morbidity and no better survival. So are we performing more mastectomies than we need to? The answer is yes, and that's world over. You can see the data. Spain, 64%. Some of them have different reasons, but Spain has reasons similar to ours. USA, 36%, where the risk reduction mastectomies have come in, double mastectomies as they call them. Netherlands, 48%, Belgium, 37%, Britain, 30 to 45%, and France, 28%. Now, the reasons in these, the variations were observed in these studies as I was trying to analyze. Access to radiation, doctor-patient attitudes. I think this is very important. But access to radiation is very important. Even in these countries, there was an issue of traveling to a center. And a lot of women avoided going because it meant a lot of hassle, and visiting 3 to 6 weeks for 15 plus 5, whole breast plus 5 boosts. So it meant a lot of doing. Some worried about the side effects of RT. I put queries on screening programs. They have, some of these countries have wonderful screening programs. So it's more about awareness. Even if somebody knows it, they may not go for it. So to sort out the radiation issues, this target randomized trial, one-step RT could offer an alternative, the Lancet. This is good. Now, this I would like you to pay attention.
Sorry to interrupt, sir. We are running short of time, so request you to please wind up soon, please.
I have how much time? 10 minutes?
No, sir. Time is already over, sir.
Oh, I was told more by Sandeep.
So you had 18 minutes and it's being consumed, sir.
Oh, I was told 25 minutes by Sandeep. That's why I was... Okay.
20 minutes was the allotted time, 18 plus 2 minutes for discussion. You can take 20. We can postpone the discussion. No issues. You can take 20, sir.
No, can I get 5 minutes? Otherwise, I'll quickly go through. Anyway, I'll do it in 5 minutes, please. So this is a master collaborative. I mean, this is multi-center centric trial at UK where they found out why MDTs were more mastectomies are done. What did they do? They had 89 units. This is the criteria, and they found that large tumor breast ratio was the most common reason, and the T size was 40 millimeters in most cases. And also the fact here, probably if there was time, I would have elaborated on this. This shows very nicely that a lot of it had to do with, especially when you look at 9, when NST was offered, but even with benefit, and that the conservation was not offered. This happens to a lot of us. Neoadjuvant hormone or chemotherapy, both were offered, but they failed to downsize. Central tumor was a reason. Most common reason I've already told you. So take home, despite moving in the era of de-escalation, they were able to, they were doing mastectomies more than you would expect them to do. So there are reasons more than what we generally attribute. So most is related to what the MDTs have to offer to the patient and counseling that you do. Wherever a lot of time was spent with the more mastectomy units than with the low mastectomy units. So these are the universal challenges. Some of these were addressed. Family history is no longer an issue, although we have to counsel the patient. It is believed that age 5-year survival rate was not found to be different. In fact, it was found better with breast conservation. Cost was found to be less, and also family history was not a contraindication. In India, of course, this is the last part, and I'll wind up. 50 to 70% are locally advanced. Average size is 4 centimeter, and we observe that there are 2 peaks. The younger patients have a more aggressive cancer, which is usually the one with BRCA and BRCA2 mutations, and also CYP and mutations, and also that they are triple negatives mostly. So we have an issue with the breast conservation, and the rates are very low. In good setups, we have found it to be around 20-25%, say in Delhi. And it is not yet a standard of care because the mindset has to change. And it's related to the providers rather than to the patients. But making a choice, one was not talking about these. You need to do mastectomies in these patients. Is an aggressive approach justified? It is. And these are the reasons why breast conservation may not be still happening, but we need to look at it more aggressively. The solutions are, since we have large T size, we need to be training the surgeons into doing surgery which is tailored to our scenario, including the oncoplastic breast surgery training, which can happen. The simple oncoplasty can be learned by most, and larger tumor sizes could be reduced using the neoadjuvant systemic therapy, and it can still be offered. These are round blocks. I'm just finishing. And we don't need to really take the skin off, and you can do this. These are simple ones. That's why I'm addressing. And need to orient the specimen, and we need to clip the tumor bed like in all breast conservation for the boost, and you can get good results. At the same time, we use look for localization to make it even smaller. Excision. Give me a minute, please. I'll finish. You can use ultrasound for the purpose for localization, where we mix the methylene blue with the xylocaine jelly, and the two mixed together. We can inject inside, and it leaves the stain, and we can remove it. Sentinel biopsy following neoadjuvant chemotherapy is also feasible, although it's not advisable as of now, but we can certainly do it. And central quadrant tumors, again, which the myths that I want to address, can be addressed with simple local flaps, Grissotti here. And last, maybe 2 slides. The redo this is a lumpectomy where the patient didn't come with any oriented specimen to the pathologist, and the margin, and we could manage it with light cap and round block in the same go. Well, even mastectomy is not standardized, which is what we need to look at. Wish I could take time there. This is a smile incision, which can make the mastectomy look better. I'm sorry about that. You can fishtail it to get the sagging effect go. You can use it lazy as incision, and that's the Goldilocks I was mentioning. We've used it in many patients where it's a Weiss pattern skin incision where the flaps are deepitalized, and you can actually get reasonably good in the outcome. Last slide, continental mastectomies or the risk reduction of what has led to increased incidence of mastectomies in US, while it's a false alarm where the incidence is believed to be more than 15%, while the incidence is not more than 1%. And unilateral mastectomies has gone down, double mastectomies has gone up, can be discussed. To conclude, ladies and gentlemen, in theory, there is no difference between theory and practice, but in practice there is. I'm sorry about taking those 4 minutes extra. I wasn't too sure about the time, Dr. Shetty. Thank you very much.
Thank you. Thank you, Professor Chintamani. I request Dr. Neeta Nair to introduce the next speaker, please.
Thank you so much, sir. So I think we've heard two of the stalwarts talk. Both Dr. Badwe and Dr. Chintamani have probably been teachers for all surgeons, breast surgeons in India. Dr. Badwe put the whole debate of surgery in M1 to rest, and we know that there is no evidence for surgery in metastatic breast cancer at presentation. Dr. Chintamani has shown us a paradigm shift that we've seen in surgery for primary breast cancer across the world itself, and why we as a country also need to be more aware and move towards more breast conservation. And that's going to take us forward now to the next three talks, which are primarily on oncoplasty, the new buzzword. It's great pleasure to present, to introduce Dr. Yazan Masand. Dr. Yazan has become a very popular name with the oncoplastic webinars that are going on. I think all of us have been attending them very eagerly. He's very well published and has multiple achievements. And I think his work and his talk will speak for itself. So I'm going to hand over to Yazan. The floor is all yours.
Many thanks, and thank you for the lovely introduction. Thank you for inviting me to talk in this session. I'm sharing my screen. Can you see my screen now?
Yes, we can.
That's great. First of all, many thanks for inviting me, and thank you, Sandeep, and the organizing committee for this. It's a pleasure to be part of this. So I'm going to skip the first couple of slides. So I work in Aberdeen. I am in a couple of universities here in the UK and sit on some of the committees. And some of you might know me because of the iBreast book website and webinars. So many of the videos I'll show today are already on the website or are already on the YouTube channel. And we had lots of webinars on the iBreast book. I think the 17th was last weekend. We had about 700 people online. And it's great to see many people that have spoken on the webinars, like Anand Kopika has been a great support of this, and the team from GUYS, especially Ash and Mr. Hamid is going to follow this talk. So it's great to have you all. And there is an iBreast book YouTube channel, but many of the talks from those webinars are there on the YouTube channel. So the talk that was given to me was basic oncoplastic techniques for beginners. And always the question is, before you start, there's a couple of things that you need to do to be able to get the better outcome. So the things to do, first of all, even if those are the techniques that we'll talk about are simpler techniques, they're not without complications. So you need to always have mentorship. You need to always have some sort of training. There's lots of good courses. There's lots of good degrees. And try to team up with a plastic surgeon. Many of the plastic surgeons do those techniques day in, day out for their aesthetic work, and always audit your outcomes. Now, the talk will be two smaller 5 to 10 minute talks. One is about planning and one is about how to do it. And planning is very important because you need to always factor in patient factors, tumor factors, and the breast itself. It's the material that you're going to work with. And of course, the surgeon is a very important factor in decision-making, as we've seen from the previous talk by Prof. Chintamani, which is a great talk. We influence the patients on what to do. And sometimes the influence is partly because of what we can do. And choice is very important thing for patients. So if you look at patient factors, age is very important. You're not going to do the same operation for a 20-year-old or for an 80-year-old. Comorbidities, habits like smoking, drinking, and profession are also very important. And it's very important to manage expectations. Those are not aesthetic procedures. Yes, many of them are based on aesthetic procedures, but they're mainly done for cancer work. And the working material that you have to work with is the breast, and they all come in different sizes and shapes, because there's the A cup and there's the H cup, and you can do different things with those breasts. So the size, the shape, the ptosis, the skin quality, the previous scars, previous radiotherapy, patient's wishes is very important, and the contralateral breast is also very important. There's some tumor factors like the site in the breast, the biology of the tumor, and other treatments. So what does that all mean? We need to put all those in an equation that works. So if we look at the patient's factors, for example, so a 55-year-old lady with a 3 centimeter microcalcifications in the upper quadrant with a 1.5 centimeter lesion on ultrasound scan, which is IDC with DCIS. So will your planning will be different if she's a non-smoker fit and healthy, or if she's a smoker fit and healthy, or if she's heavy smoker and controlled diabetic on steroids for her COPD. So yes, it's the same tumor, and yes, it's the same breast, but the patient factors are completely different. While I'll do the WISE pattern for the first patient that has no risk factors, I might opt out to do a lateral mamoplasty or a racket for the second lady. And the third lady with a high risk factor, you just need this minimal, so you do a simple wide local excision. And so the techniques that we'll talk about are not only for beginners, they are very important de-escalation techniques. Sometimes and many times less is more, and that's what we're learning in breast surgery. And there's different bra sizes and breast sizes and shapes. And what you can do for the lady on the left side is completely different than what you can do for the lady on the right side. So tumor factors like site in the breast, biology, and other treatments are important as mentioned. For example, if you go back to this lady, 3 centimeter, if she had a 3 centimeter triple negative breast cancer, will your decision be different than a 3 centimeter microcalcifications with DCIS? Or if she had a 3 centimeter microcalcification centrally going to the nipple with DCIS? So this actual lady had a 3 centimeter triple negative breast cancer. So we did chemotherapy first. She had near complete response, and this is her result after her surgery, after her cancer treatment. If she had a 3 centimeter DCIS, then most likely you start with surgery first, and you can try to resurface the chest wall with a lateral chest wall perforator. While if she had a 3 centimeter microcalcifications that is centrally, then you're more likely to end up with a mastectomy. While this lady, and there's a lovely talk about after this about Anand Kopika about extreme oncoplastic breast surgery, she had multiple tumors in the left breast, one in the upper outer quadrant, one in the lower outer quadrant, and she had a mammoplasty because you have enough tissue to work with. So you need to balance all of these factors to be able to plan the best surgical option. Always think about the whole treatment journey for the patient, and if there's indication for chemotherapy after, why not to give it up front to de-escalate your surgery. Try to decrease complications by choosing the best surgery for the patient, and try to improve your aesthetic results, but this is not a cosmetic operation. And the key thing is less mastectomies, which I think was the message also from the previous talk. And also you want to avoid those types of results. Remember, at the end of the day, it's not what you see, it's what the patient sees. So I always tell my trainees when the patient comes after the operation, you ask the patient, what do you think? Because many ladies, you think, I haven't done a great job, and they are really happy with the aesthetic outcome. And many ladies, you think, oh, I've done a great job, and they're not happy with the aesthetic outcome. So always ask the patient first, what do you think? Scar placement and planning is very important. And I always say, plan your mastectomy and reconstruction when you do your breast conservation. And the majority of patients need only simple procedures. For anybody who's doing oncoplastic breast surgery or any breast surgery, they need to have a look at this paper. I think this is one of the most important papers that have put everything into a nice little atlas. There's many other papers that have come after that from the same team and from other teams, but this is a simple, easy read, talks about level 1, level 2 indications, and gives you the different quadrants with the simpler operations, what you can do and what you should consider for those patients. And most of the time, 70–80% of patients, they need simple wide local excisions. So the author of the first paper is Krishna Kloff, and I had the pleasure of visiting him for a couple of weeks when I was a trainee, and he does what he preaches. So most of his patients that are suitable for breast conservation, if he can do it with a simple glandular mobilization, simple excision, you mobilize the nipple, you mobilize the breast, you close the defect, then he will do that. And he always look at incision placements, periareolar incision, just a bit of lateral extension will give you a greater exposure. Inframammary incision is a very good planning incision, and lateral incisions are great. But sometimes there's simple differences in the breast, like if this lady had a tumor on the right side, you'll do a little crescent to give her that slight uplift, and you'll do the wide local excision doing that, and give her slightly better symmetry. And always you plan your mastectomy during incision. So this lady had her wide local excision. Unfortunately, the tumor was thought to be 5 millimeters, but was about 30 millimeters of DCIS. This is the first post-op result after a chest wall perforator for her. I've already planned the mastectomy when I did the first surgery. So when I did the mastectomies or the prepectoral implants, I did not struggle with the incision, while this lady was sent to me by a colleague. And unfortunately, the first incision was very poorly planned. It's in the upper inner quadrant. She needed the mastectomy and she wanted the nipple off, which made our life much more difficult when we plan things. But in many ladies, the incision should be on the breast. Aesthetic outcome is important, but it's not as important for some ladies. And many ladies that will need, if they need a completion mastectomy, they wouldn't want or need a reconstruction. And that's the incision placement will be completely different. Now, it's the how to do it part. I hope I'm still on time. So let's look at the central tumors first. And while many of the central tumors, like this lady had a central tumor in the right side, you can do them with the therapeutic mammoplasties to remove the tumor and still improve the shape of the breast. You can do things like a Grisotti flap, which has been touched on by Prof. Chintamani, but also when you do a Grisotti, this lady, the tumor was lobular, it was much bigger than what we were expecting, so she needed a completion mastectomy. When I do my Grisottis, I'm always mindful about how high you put the nipple, so if you need a completion mastectomy, you don't complicate your scar, you always have a nice low scar in the inframammary fold that will close. Now, let's look at central wide local excisions. You don't need to have those complex techniques because many of the times the ladies, all what they need is just a simple ellipse. And this is the first video. And the ellipse is just a simple operation to do. But you need to, it's a bit more than what you need, what you see. So you do your excision first, and your first thing is to do your cancer excision. So you go down to fascia, you do your cancer operation, then you start thinking about your aesthetics. For our ladies, we don't have frozen section, unfortunately. Pathologists are not easy to find in the UK, so we have an X-ray. Once you do the excision, you're happy. Always mobilize the breast. If you've seen before, I've just mobilized off the chest wall. That will keep and contain the shape of the breast. Then you close the defect in the breast. And I always find that when you do those central wide local excisions with this ellipse, that it flattens the breast. So before closing the breast for this young lady, I mobilize the breast tissue just below the skin and then close the defect. That will give them a much more better natural looking breast. Yes, there is no nipple. You can do a nipple reconstruction later, but many ladies will not want a nipple reconstruction. And if that little projection they want just in their clothes, sometimes you can have a stick-on nipple that will do the job. We always close in 2 layers. And you'll have a reasonable aesthetic outcome. You haven't excised loss of her breast, and I think that's a much better result than a mastectomy and reconstruction. Now, for round lock resection, it's a nice, simple technique. I use it for small breasts, mainly for quadrants like upper inner and upper central quadrant like this lady, but sometimes for large breasts that will need de-escalation to decrease the chance of complications. I use it also. It's not a bad technique. Yes, they will not give you a perfect result, but it'll give you a much better result than a simple wide local excision. So with a round lock, I always de-epithelialize the area around the nipple, the whole area. And then when you do your incision in the skin, if you notice, there's about a ½ centimeter to 1 centimeter before the skin. So all your retraction is on that de-epithelialized part of the skin. Then you do your dissection in plane. Always when you do the round lock, do all your mobilization in the beginning. So not only the cancer mobilization. For this lady, I've done the whole mobilization in the beginning. Then you deliver your wire, and when you deliver your wire, you need to fix the wire with one clip and then deliver it with the other so it does not move. You do your oncological excision down to chest wall. You X-ray. Many times I always mark the specimen while it's in the breast so I don't lose orientation. And after that, for this lady, for example, I've already mobilized most of the upper half of the breast. And you need decent mobilization to maintain shape, otherwise the breast will cone. I close the defect most of the time, but not all the time. So this lady has a dense, good glandular tissue. The sutures will stay in, so I close the defect for her. Then I do the local infiltration. I don't use any adrenaline in my infiltration, and always close in 2 layers. I usually use monoclip for the closure. It gives a very nice aesthetic outcome, and the complication rate is much less with non-braided sutures, though there's some recent publications suggesting that we should use the plus sutures that have the antibiotics in them will decrease the chance of infection. Those operations, though they seem simple, they are not without complications. This is just a simple technique for the dressing. I use a bit of the scrub sponge. I put it on the breast and press it with a clear pad. That gives them a bit of negative pressure. So I find it sometimes useful. The lateral mount plasty is also relatively simple. It's mainly the idea from that is for the lateral tumors, when you do a big excision from the lateral part of the breast, the nipple will lateralize. And we see many ladies from old days when they did simple excisions that the nipple is really nearly in the axilla after the radiotherapy. So you need to close the defect in the lateral part to decrease the amount of lateralization of the nipple, and you need to medialize the nipple, which is very important. And that's the main concept of this. So if you see this lady, the tumor is exactly where we mark our lateral mount plasty or racket. You detailize the area around the nipple, and then you do your excision. And when you do your oncological excisions, you don't think about the aesthetics at all. You just do your oncology. Then after that, many times all what you need is a bit of mobilization of the chest wall, and that defect will close nicely and the nipple will medialize. In some ladies, you might need to do a secondary pedicle to be able to close the defect nicer. This lady, just everything was quite nice and smooth. And many of those ladies, I use this quite a lot for de-escalation for ladies that are smokers, a high risk of having wound problems. So I try to avoid a wires pattern. So I try to do a lateral mount plasty or sometimes vertical scars. I think they're less scarring, is less likely of having wound complications and problems. And this lady did not have big differences between both breasts. I would not symmetrize them immediately. I would just do one side usually. But for example, this lady had a bit of asymmetry between both breasts, but she did not want to have any symmetrization procedures. The omega or the batwing and the hemi batwing, also a simple procedure. I also use it for the escalation type of surgery, but you can use it as it's a very good option. It's done with one of my colleagues. I've done one side and she's done the other side. Same principles. One thing about the omega is when you mark, you need to mark the central part of the tumor, and which is the horizontal plane, and I mark that when the patient is lying, and then I mark how big is the tumor, and that will be the distance from the top of the nipple to the top of the scar, and then I mark the other scars when the patient is standing up. And then you do the de-epithelialization. When you do the de-epithelialization, like previously, keep about a centimeter of the de-epithelialized skin to retract on. Always try to use sharp retractions to decrease the chance of having wound problems. And then you go on your oncological plane. This is not an aesthetic operation. So you go on your mastectomy plane, you go to your wires, and this lady had a large area of DCIS, so had 2 wires. We delivered the wires and we did our oncological excision down to fascia. This lady, if you notice, we haven't mobilized lots of breast tissue because this is de-escalation surgery. So we wanted to decrease the amount of mobilization. If this lady did not have other risk factors, we would have mobilized the lateral and the medial part. But she has lots of risk factors. So what we have done is we've done the excision. And after we've done the oncological excision, then we looked at the breast and mobilized as much as we need to be able to close the defect. So the mobilization was after the excision. Then after that, you just close in 2 layers. Most of the time, the amount of tissue left on top of the nipple will close the defect, and with the lateral and medial mobilizations, things will close. So this is the last video, and there's not much, I think 1 or 2 minutes and I'll be done. I think because I'm just coming to time now. So the closure will be in 2 layers as usual, and that's it. I'm not going to show the wires pattern mount plasty video. We've just run out a bit of time. This is a bit more complex. I'm not saying that this is something for beginners, but this is something if you team up with a plastic surgeon, for example, most of the lower quadrant tumors with a superior pedicle mammoplasty, you can excise them. Most of the upper quadrant tumors with inferior pedicle wires pattern, you can excise them. So it might be worth teaming with a plastic surgeon and see if the tumor comes out usually in what they would have excised for a breast reduction. That's something to consider. But always remember that those
So you need to wind up, your time is over.
I'm done.
Maybe 1 or 2 slides.
There's no slides, I'm done. So what we need to say is that for all those patients with the mammoplasties, always try to plan things with people that have done this type of operation before. Always get mentorship, always get courses. Our next webinar on the iBreast book is on mammoplasties, and we have great speakers and panelists. So if anybody wants to join, if you don't know where to find the links to register, please email me at info@ibreastbook.com. Many thanks for the invite.
Thank you. Thank you, Dr. Yazan. Thanks a lot for an interesting talk. We should quickly move over and we'll wait for the questions to the last, or people can come online and put the questions on board. So I'd like to ask Dr. Hisham Ahmed, who is affiliated with the guys and the St. Thomas Hospital in UK, London. Without going into all the details, he's a well-known breast cancer and breast surgeon in the UK. We'd like to ask him to take over the next talk. Thank you, Dr. Hisham.
Thank you very much indeed. And I don't know why I hear an echo.
We can't hear your voice. You'll have to come a little.
Yes, I hope it is better now. Thank you so much for the introduction, and it is truly a pleasure and a privilege.
Dr. Hamid, can you increase the volume of your laptop because your voice is not very audible?
Right.
Or probably you need to be closer to your laptop to be heard. Either way.
Right. Can you hear me a bit better now?
Slightly better, but we can hope for more.
Right. I am trying to look at the setting and the input volume. Does this sound any better now? I don't know.
Chairpersons, can you all hear, or I am the only one who's not able to hear it clearly?
No, it is quite muffled.
Chairperson?
Quite muffled.
Exactly.
Mr. Hamid, are you with us?
Yeah, I think his signal is lost.
So,
Dr. Hamid?
Should we ask Dr. Kopikar to take over so that meanwhile he can get his?
Yeah, we can. I think we should. Ramesh, in the meantime, see if you can sort it out with Dr. Hamid on email or whatever.
Okay.
Ramesh, yeah. Chairperson, take the next speakers.
Dr. Neeta, please introduce Dr. Kopikar.
What we're going to do is go ahead with the next talk. I don't think any oncoplastic forum in India happens without Dr. Kopikar as one of our speakers. He's one of the most eminent oncologists that we have working with plastic work. Kopikar has achievements to his credit. He is one of the pioneers for breast oncoplastic work in India at the Breast Health Center in Pune with the Orchids Group. And I think his presentation is going to be on extreme oncoplasty. And I will give you a word of caution, is that this is something that needs to be done in trained hands. Dr. Kopikar's floor is all yours.
Sorry, can you hear me now? Or?
Thank you so much, Neeta. And
sorry, just a moment, Dr. Kopikar. Mr. Hamid, we're going to just go ahead with Dr. Kopikar, and we're going to come back to you.
Absolutely fine. Absolutely.
Sorry.
Thank you.
Thank you. Go ahead, sir.
Can you see my screen now?
Yes, sir, we can.
Okay, thank you so much, Neeta, for that introduction. And I hope, again, I'm doing it very quickly. As far as you're concerned, you're going to get bored because it's probably about the same. So greetings from Pune. Can you hear me? Yeah.
Yes, sir. Yes,
greetings from Pune, from the International School of Oncoplastic Surgery and the Center for Translational Research. We have global evidence that impact of mastectomy is that there is a lot of depression. there has been an evolution from mastectomy to oncoplasty, thanks to a lot of workers like Veronese, Fisher, and many others. Then the NIH consensus, and we know today that BCT is standard of care. However, there has been some data suggesting that even a 10-year survival benefit for BCT by the Netherlands group, then from the Danish Breast Cooperative group, and then from the Swedish group very, very recently, as well as there is one report from India, which suggests that probably BCT has even better survival now, which has been challenged by a lot of purists. But then, well, at least BCT is as good as mastectomy. Bad cosmesis also leads to bad depression, and hence oncoplastic techniques came about. And I think the evaluation of an oncoplastic technique is best done by what the patient says about it. So the patient satisfaction is most important when reporting on your oncoplastic outcomes. Therapeutic mammoplasty for patients who have got larger breasts, who have moderate size breasts to large breasts, with some varying degrees of ptosis, patients can be offered therapeutic mammoplasty techniques, and where larger excisions can be done, larger volumes of excisions can be done. Now, this is a patient with a scar placed outside, and basically probably after radiation, as all of you know, radiation with large breasts, the side effects of radiations is definitely worse with larger breasts, especially when surgery is done in this way, the nipple is deviated. So you basically, such a patient can be offered therapeutic mammoplasty. Now, therapeutic mammoplasty are of various types. I'm going to just to introduce, because I think this is something that has not been covered, that simple therapeutic mammoplasty, when you use the three pedicles, the superior medial, the superior medial, the superior and the inferior medial pedicle, and then whatever tumors that arise within the reduction pattern is simple therapeutic mammoplasty. Whereas if the tumors lies outside the reduction pattern of a normal reduction pattern, then you need to do a complex procedure. So either a dual procedure, dual pedicle, or you need to do a whole breast mobilization, central cordon mobilization, etc., etc. So basically, these are various techniques of therapeutic mammoplasty, and there is a lot of literature, as all of you all know, and probably more and more coming every year, which is showing that oncoplastic surgery has better clear margins, has less re-excision rates. It's probably very useful after post-NACT. Larger volumes are possible, better cosmesis, and better, happier patients. Therapeutic mammoplasty, our report of 171 patients has just gone out for peer review. Out of 241, average 155 grams and 1% local recurrence rate at 2 years, margin positivity 3 out of 176, and good cosmetic scores. But the most important part of our presentation was that the satisfaction scores amongst our patients was excellent in all of them at 1 and 3 years of, we have reported on the 1 year, but even at 3 years, the satisfaction scores are very, very good with acceptable complication rates. Now, the new kid on the block is the perforator flaps, and these are flaps that are from the lateral chest wall, patients with small to moderate breast with or without ptosis, and someone who and with a little larger breast with a large tumor without with ptosis, but doesn't want an opposite breast symmetrization would definitely warrant either a wide excision only, or if the defect is big, then maybe some sort of a perforator flap. So perforator flaps have really over the last 3 to 5 years have become very, very popular. And in the past, as Yazan showed you a beautiful video on lateral mammoplasty techniques, this was the lateral mammoplasty we would do in those days for a tumor which was away from the skin. But today, for a similar tumor, either a LICAP, if it is on the outer side of the tumor of the breast, or a LTAP if it is higher up on the breast, or a ICAP, which is at the lower part of the breast, and the MICAP, that is the medial intercostal perforator flap, could be used for medial side tumors. And therefore, this is a patient with reconstruction with the perforator flap. Therefore, can cosmetic oncoplastic surgery, which is a new paradigm, give more choice? Can it increase the rate of BCT and reduce mastectomy rates in all these indications, which otherwise we were dogmatic about being, indications for mastectomy? Radical conservation was first thought of by Professor Silverstein. Then he thought radical conservation is a very odd term because it is antithesis, radical and conservation. How can it go together? So he named it extreme oncoplasty. This is where breast conservation, because it has all its advantages, using oncoplastic techniques for patients whose tumors exceed the standards for breast conservation, and who in most physicians' opinions need a mastectomy. Most of these patients require a post-mastectomy radiotherapy. So this is the definition provided by Professor Silverstein. Why radical conservation? He said because it yields better quality of life, and if it is possible, even in an extreme situation, it is going to give you equal survival. And if the patient is going to have an MRM with reconstruction and radiation, because most of them will have radiation, then their quality of life is going to be terrible. And therefore, he advocated the term and the process of extreme oncoplasty. Some patients, many times, you all will also come in, many of you will come in, they insist on BCT, and that's how actually our extreme oncoplasty program started. It is one operation, less pain, looks better than before, are sensate, more functional, better body image. And many times patients even forget they ever had breast cancer. First of all, let us look at the large tumors. Lorenzi, Dongen, Clark, and even Veronica showed that if you have a large tumor in the breast, but you get a good margin, the OS is similar whether you do a BCT or you do a mastectomy. Therefore, oncoplastic approach was safe as compared to mastectomy in large tumors. Now, what about the multifocal multicentric cancers? There are only 3 studies initial in 1987 to 1993, which showed a high degree of local recurrence. After that, there have been a multitude of studies which have shown that in multifocal multicentric cancers, the BCT 5-year survival rates are the same. And Woods et al. Is one to mention, where he actually did a comparison between his patients between BCT and mastectomy, and showed actually a trend towards a better survival in the patients who had a breast conservation. Silverstein, there is a growing interest in extreme oncoplastic surgery. Professor Silverstein first published twice on this. Then we published in 2019, and then there have been many more papers. And I think this year too, there is a new paper on extreme oncoplastic surgery. Extreme oncoplastic, he showed that at 24 months, it was comparable between extreme and standard patients. The local recurrence rates were the same. He went on to present his data after 5 years of 122 extreme oncoplasty patients against standard, and again showed equivalent oncological and surgical outcomes, as well as local recurrence rates. They were equivalent in the 2 arms. And this was our paper where we also showed this very safe oncological and surgical outcomes, as well as we reported on the patient-reported outcomes, which were excellent, which I will show you a little later. Then came Crown et al., Nebril et al., Nebril and colleagues, who also collected their data and showed that EO was safe. Pierce in 2020, and then the most recent investigation by Savioli also showed that the complication rates were acceptable and showed a 5-year survival of 97.5%. There are limitations to all these studies. They are small cohort studies, as you have noticed, and may have patient selection bias with a trend favoring BCT for multifocal multicentric disease. They included patients with better prognostic indicators, probably. Large-scale studies, such as the Miami study with long-term follow-up, are essential to assess the safety of EO surgeries. Variability in the study design, differences in classification and definition between multifocal and multicentric cancers is also another issue. Dissimilarities in reporting outcome measures has prevented extreme oncoplasty from becoming standard of care. Acceptance in India is again going to be a big issue, because anyway, most of the centers probably still practice mastectomy. And therefore, acceptance by the patient and the surgeons is going to be a problem in India. The future trend is that we need to have some sort of prospective randomized data to emphasize on the inclusion, and with the emphasis on inclusion of prompts in all the studies. Such an approach will evaluate oncological outcomes as well as cosmetic scores, and will assist in informed decision-making. Such long-term studies for extreme oncoplasty are necessary given the potential of extreme oncoplasty as the most suitable surgical choice for the management of advanced BCCs. Now, this is our paper and our 40 patients with the same indications as I had earlier said. And I'll just take you through some of the cases. Now, this is a large multifocal disease. This is the first patient who totally refused a mastectomy. I had advised her a mastectomy with reconstruction, but she said, if I'm going back, I'm not going to take treatment. And anyway, she was delaying treatment because she thought she was going to be mastectomy. Now, here is the patient. You can see these outlying tumors were easily made out on the ultrasound, so we did not need wire localization. We did a Weiss pattern. We had outlined the tumor looking at the mammogram, and then on ultrasound, and we were thinking we were going to do a lower medial pedicle to fill up that gap. And basically going in through one of the arms of the Weiss pattern, we went in and excised the tumor after localization with the ultrasound on the table, and basically then did an ultrasound on the table again to be sure that all the tumor was removed. Then the frozen section was done. The nipple areola was cored out to see if there was disease there. But now you can see the nipple is going somewhere else. So the nipple areola was removed. The whole mound was then mobilized into the defect. The Weiss pattern closed, and the nipple areola brought out as a nipple areola graft. And she is doing well now, her 6th year. She's in her 6th year post-treatment. And you can see her photograph here. There is a slight partial necrosis of the nipple in this situation. Another patient with a similar thing done about 4.5 years ago, extreme oncoplasty with a similar sort of lesion, and that is her with a therapeutic mammoplasty procedure. Now, this is a patient who was excised twice outside for breast conservation. Both the times were margins were not clear. Then came to us. She had advice for a mastectomy and with the therapeutic mammoplasty. Now here you can see there is residual calcification around the cavity, and basically we did a therapeutic mammoplasty for her with a Weiss pattern incision. And I'm sorry. Yeah. So that is on the other side, there was microcalcification, which we did stereotactic biopsy, which was negative. Anyway, we put clips there and we were going to excise that in the reduction pattern itself. We have deepitalized the medial part of the lower pedicle, and the superior pedicle is carried on a superior medial pedicle. I'm sorry, there's something going wrong with my... So that is the pedicle, and then we are excising the medial part of the lower pedicle along with the excision of the tumor, which was extending into the upper outer as well as the upper inner quadrant. Then this medial pedicle was mobilized into the defect, which was marked out with Liga clips for the tumor bed. And then she had a ER/PR and HER2 positive disease. And then this is fixed in place. The Weiss pattern is closed, and she is at 4-year follow-up without disease. The nipple areola is brought out in its appropriate position. Opposite symmetrization is done. In all our cases, our symmetrization is done at the same time because none of our patients are ever going to come back for a symmetrization later on. Now, this is not a cancer, but it was a pseudoangiomatous stromal hyperplasia in a 22-year-old just married girl, and was advised a mastectomy. But with therapeutic mammoplasty, with all the some amount of residual breast tissue remaining in the pedicles, we were able to, save her breast. And she's doing well now. She's now about 10 years older and still comes for a follow-up. She's fine. Here is a patient with a scar in the lower quadrant, and you can see there is a Parrott's peak deformity already developing. And this patient needed a re-excision because the margins were not, reported upon. So we did a mastopexy, and that is her at 2.5 years after surgery. And then this is a large multifocal breast cancer with microinvasion, and where we have done a LICAP for reconstruction. Now, all our extreme oncoplasty patients went through prompts again, the patient reported outcomes, and you can see the reported outcomes with satisfaction of breast, psychosocial well-being were all excellent at 1 year of follow-up. The post NSCT surgery. Now, extreme oncoplasty has a big role in, I feel, in post NSCT residual tumors and residual calcifications. Only most of the systematic equals mastectomy. However, the EBCTCG of 2018 showed that there was increased IBTR, but there were reasons. One thing, that they included studies that had not done removal of the residual tumor. All those that showed a clinical response had no surgery at all. Then there was no careful tumor localization, proper pathological assessment was not done, intra-op or post-op was not mentioned, appropriate radiotherapy techniques were not described. And therefore, and there is this study from Chen et al. From the MD Anderson that has shown that whatever the size of the tumor pre-NSCT, it doesn't matter, the 5-year survival, etc., the outcomes are the same. In our 135 patients cohort, we had a 76% breast conservation surgery. LOBC, LABC, we had a 71% conservation after downstaging with chemotherapy and using oncoplastic techniques. And again, the surgical and oncological data was satisfactory, as well as the PROMS data was good, and it shows that it was better in the OBS arm. Now, what was our approach? We did local staging, of course. We use a lot of ultrasound intraoperatively. We clip the tumor after it shrinks after 2-3 cycles. Place wires for residual calcifications. Remove all suspicious clinical findings. Intraop rad path analysis is done on every case. We ensure margin negative status for frozen, excise widely, especially if residual tumor, shave margins if positive, excise further, and if scattered tumor reported by the radiologist, by the pathologist, excise further margins. So we have a very aggressive approach to getting our margins negative on the table. And this is a patient who came with a large tumor. You see how she is shrunk here with chemotherapy. Then we have done a medially based flap, which extended pedicle to cover the defect. And she is well at now, this is an old slide, 3.5 years after surgery. She was an triple negative breast cancer, 68 years old.
Dr. a few more slides.
Yes. So this is another patient. There are similar patients, except that I will show you one last case, which is based on a perforator flap. And that is, have I already finished the time? Then I'll stop here. So this is a large residual.
You have, sir.
Okay.
You have 2 minutes
slide.
of discussion left if you want to use it.
Okay, so this is the large excision of that patient, and then you take a LTAP and a large LTAP flap to rotate into the defect, and that is her post-operative how she looks. So basically, what I've tried to show is that again another perforator flap, but this is a patient, the last patient, which actually had dual tumors. And we used a LICAP and a MICAP. Again, a patient who was totally deadly against as a mastectomy. Also, she had only 2 tumors in the breast. So she qualified for a breast conservation. And this is her large tumor being removed on one from the medial side. And then we do an ultrasound on the table. We do immediately the localization with Liga clips. And after ensuring that the margins are clear, went on to the other side, removed the other tumor, and then rotated a LTAP from the lateral side. A LICAP from the lateral side into the defect. So again, with the ultrasound confirmed, so that's the LICAP and the LTAP being put into place. And finally, the MICAP coming up, and you can see the vessels going in from there. And the MICAP placed there, and basically that is the closure, and that's her after the surgery. So I think with that I will conclude the talk, because I have run out of time, and I would only say in my last slide that oncoplastic, I think I've shown that oncoplastic surgery is a new paradigm where more choice, less mastectomy, and most of these indications for mastectomy have now become relative. Thank you so much.
Thank you so much, Dr. Kopikar. Dr. Shetty, can we get Dr. Hamid back?
Can you hear me now?
Yes, we can. Absolutely.
Okay, perfect.
So, Mr. Hamid, floor is all yours.
Thank you very much indeed. Again, thank you so much for the introduction, and it's always a pleasure to be part of these meetings and webinars and the conferences. And I would like to thank Dr. Sandeep and the organizing committee for inviting me. So I hope it will all now go well. I need to share my slides. I don't know why. Can you see the slide?
I'm unable to. I'm not sure if everybody else is able to.
Sir, not yet, sir.
Can you see it now?
Not yet.
No. What about now?
Yes, now we can.
Oh, perfect. Thank God for that. Right. The subject I'm going to talk about, as you can see, that I was asked to talk about contralateral risk reducing mastectomy. But as you probably realize, that may be a misnomer or misleading title, because as we will see later on, that not all the cases or all the patients who actually embark on the contralateral mastectomy are essentially having it for risk reduction. So there has been undoubtedly an increased incidence of the contralateral risk reducing mastectomy, as we are just going to call it, and this increase in the incidence has been significantly demonstrated over the last couple of decades. That was an interesting observation because, as we heard earlier, that from the early 1990s, there has been the evidence to show that breast conserving surgery is equivalent to mastectomy, and there has been an increase in the chance of avoiding mastectomy instead of and replacing it with breast conserving surgery. However, for various reasons we are going to discuss later on, there has been almost a shift back to having mastectomy, and consequently the bilaterality of the procedure has become popular. And we can see that from the data from the NSPB, that there is almost an 150% increase in the incidence of contralateral excision. And again, it seems that most of this trend has been seen in younger women. The other interesting thing is that there is almost a global variation in the practice. The highest probably rate of contralateral mastectomy takes place in the United States. It is less observed in Europe, but again, we see it probably in Britain now more than in other parts of Europe. There are, not surprisingly, a lot of drivers to embark on this practice, not the least from the patient's perspective, but certainly as we see, and as I will talk later on about the important role of the physician and the surgeon looking after the patient. So from the patient's point of view, and as we heard that the patient's desire and wish to embark on mastectomy seems to be the most important driver. There are many reasons why the patients would want to embark on mastectomy in place of breast conserving surgery, even when they are suitable for breast conserving surgery. So understandably, if a patient is going to embark on mastectomy or she will need a mastectomy, it is very reasonable that she will request the to have the contralateral side removed. But we often meet patients where the requesting the contralateral side for other reasons, such as, for example, the fear and an anxiety of the future. Majority of the patients, and a lot of data has shown that the patients tend to increase or exaggerate their appreciation of their own risk. We all have seen patients where they have different perspective to how they deal with their cancer. Some of the patients actually worry about a future events which will put them through, as we can see for on further treatment, going through the emotions of further diagnosis. But there are other patients where their main worry is about dying from the disease, and certainly the approach will be different between these two cohorts of the patient. The other driver is certainly that if a patient is going to have unilateral mastectomy, then it doesn't matter how, most of the time, how perfect the reconstruction is, whether it is implant or autologous reconstruction. It is, you do not achieve a perfect symmetrization as if you would carry out bilateral mastectomy and reconstruction. There is also the personal experience of the patient in terms of what happened during the first diagnosis and the journey they have been put through. All this is very important and obviously understandable, but that is, there are obviously, as we will see later on, that the having unnecessary radical surgery, it is not without its risks. And that's where the physician and the surgeons or the carer as who is dealing with the patient play a very important role, and has been alluded to how important the information provided by the carer to the patient to be able to reach an informed decision. Certainly, the patients are now encouraged by the availability of reconstructive surgery and the improvement in the quality of the care. There are other obviously factors which are again play a very important part in the decision making, as we can see from the introduction of modern imaging and the impact of that on early detection of the cancer, the stage of the disease, the availability of genetic testing. There are lots of other factors which play part in driving this decision. So even within the, as we say, that within the patient's cohort and the driver and perspective, even there are some subgroups of patients where probably are going to embark more on contralateral mastectomy than others, because the level of education, the socioeconomic status, and the work has shown that this is possibly because these women would like to end up if you like, the journey of their cancer as early as possible, so they can, in actual fact, get on with their life without future interruption, whether this is really gets fulfilled based on the sort of the patient's oncological aspect or not. But that is what actually the patients would like to consider. And quite often we hear from the patient that I would like at least to be in control of the aspect of my disease which I can control. There is no question, obviously, the family opinion and the support they get from the relatives, and the experience they've had within even the relatives who experienced breast cancer before. It is very interesting that even now the genetic testing is available. Some of the work has shown probably the patient has already made the decision about her to go for contralateral mastectomy, regardless of the result of the genetics, and we see it all the time in our practice. And only the genetic testing has, in actual fact, affected the decision making in a smaller percentage of the patients. But that is where the most important factor in avoiding, as we heard earlier, avoiding compromising the patient's quality of life, where the physician ability to communicate the treatment options, with particular emphasis, I think we tend to, as also been alluded before, that we tend to mention the positive aspects of certain treatment, and underplay the disadvantages. And I think in situations where there is no clear oncological indication for the procedure we're going to carry on, then the disadvantages and the complications and the problem with the procedure has to be emphasized and not underplayed. So for us to advise the patients, we really need to understand the cancer behavior. And it is important that if we are going to embark on preventative surgery or risk-reducing surgery, then we have really to be convinced that the risk is of the new cancer in the contralateral side is high enough at least to justify the discussion and embarking on the procedure. And we can see here, obviously, this is not surprising, and it is well known to everybody that in the high-risk penetrant genes, that the risk of contralateral side is significantly increased over the years, and compared with the sporadic breast cancer, which we will see later on, that they remain at a very low level. So the advice I'm going to give to the patients who is a carrier of the high penetrant genes will be slightly different, or at least we can say that the support we are going to give as carers and the level of information we are going to provide in support of the decision of contralateral mastectomy will be different between those at a very high risk of new cancer versus those who are at low risk. There is also some aspects which we tend to probably either omit or overlook, which is not only the absolute risk should be looked at, but what are the modifying factors, and particularly in patients with breast cancer. They are now receiving various forms of systemic treatment, which clearly and has shown repeatedly that it does reduce the risk, even maybe halving the risk or even more than that. So that's also has to be highlighted before we reach the decision to carry out the contralateral mastectomy. There are, as we have several factors which will be associated with this, with such an increased risk over and above the other factors. Certainly early onset and the early young age onset of breast cancer, that will play a part in the decision making, particularly if we are talking about patients where they have good prognosis from their initial cancer. Also, particularly in the high-risk women, we can see that the annual risk of contralateral breast cancer is at about 4 or 5 times that in sporadic cases. So again, that will be a factor to be considered. The other obviously well-established observation is that the contralateral risk-reducing surgery, or call it contralateral mastectomy, still achieve a significant risk reduction of contralateral cancer, almost similar at the same level of the bilateral risk-reducing mastectomy in high-risk patients. And again, the role of adjuvant treatment to play in reducing such a risk is very important. What is also will be important to highlight and address is that the incidence of an occult cancer in the opposite breast is very low. And it's not just in the opposite breast, it is an actual fact that the incidence of occult cancer in the high-risk patients who undergo risk-reducing mastectomy is very low. So that is one of the aspects the patients is always worried about. What if I have cancer which you cannot detect by imaging? So that is all very well that we are, even if we are going to accept that there is an increased risk of the breast cancer in the contralateral side, it is very important to know what is in actual fact the impact on preventing the cancer from developing. And the argument is that it will be obviously of great importance if all the cancers we are going, or the majority of the contralateral breast cancer will be at a high stage of the disease. And this is a very large study from Sweden, which has looked at over 42,000 women. And it was very interesting to observe that the risk of contralateral breast cancer seemed to be significant in actually patients with poor prognosis unilateral breast cancer. And it was also interesting in this study to observe that the majority of the patients who had contralateral breast cancer actually did not present with advanced stages of the disease. As you can see, that the larger tumors was under 3%, and in actual fact, they have quite a high percentage of patients with node-negative disease. So it has also been shown that the risk of dying and the poorer prognosis from the contralateral breast cancer has actually been shown in the patients where their contralateral disease has emerged at a short time interval from their unilateral breast cancer, or the primary or the contralateral side, the ipsilateral side. And therefore, it has been speculated that it is probably the contralateral breast cancer in this cohort of patients may be an metastatic event rather than actually new primary. And therefore, the conclusion suggested that the best practice, based on the information we have now, is to continue with the observation of the contralateral side rather than embarking on radical surgery. Understandably, that the subject has been obviously with the increased chance of risk reducing the incidence of risk reducing surgery, then the several studies have looked at the benefit in terms of disease-free survival and disease-specific survival, as well as overall survival. And as you can see, that quite a number of the studies have shown benefit both in terms of disease-specific survival and overall survival. However, most of these studies have just focused on the aspects of the survival without looking at the confounding factors. And one of the interesting study from the National Cancer Database, in actual fact, highlighted this and acknowledged the fact that there are lots of studies of various size and various type of diseases, and have looked at the advantage of the contralateral breast reducing surgery, and they come to the conclusion that in the most of these studies have not looked at the in-depth details and looking at other confounding factors. And the strength of the National Cancer Database study is in actual fact it is probably the largest study looking at patients with breast cancer with unilateral mastectomy and contralateral mastectomy. We can see that the incidence in their study of contralateral mastectomy was in overall 7%, but again we can see the trend increasing, almost again doubling or even more than double in the late 90s to the early 20s. The follow-up wasn't was very long, it was 5 years, and they have shown that if we are actually just looking at the benefit of cancer.
Dr. Hisham, shall I request you to please wind up soon, because we are running short of time.
Right. Okay. I will do that. But when we looked at the other confounding factors, then they came to the conclusion that the actual fact that absolute benefit is very small. So there are points in support of what is actually being highlighted in the NCBD study, and even with all the other information which has been even supported by a model from Narrow showing that in actual fact that the risk of mortality from contralateral the breast cancer recurrence outweighs the mortality as a result of the contralateral breast cancer. So again, that is another study from the series, and basically again because of the limitation of time, that has actually looked at whether there has been any selection bias in the studies which have reported positive outcome from the contralateral risk-reducing surgery, and the overall conclusion is that it is if you take out the contralateral breast cancer out of the whole series, then you will find that the observed survival benefit as a result of the risk-reducing surgery becomes negligible. In high-risk patients, this is
please wind up.
Yes, in high-risk patients, it is less controversial, and even within the high-risk patients, there has been some indication that there is more benefit in risk-reducing surgery in the BRCA1 patients versus than the BRCA2. As being highlighted, there is no question that we have to consider and highlight and discuss the impacts of contralateral surgery and more radical surgery in the context of the pros and cons. And we can see that some of the patients will be dissatisfied as a result of the corpus the body image, the sexuality, and so on and so forth. The cost effectiveness, particularly in countries where it is like the National Health Service in UK, you cannot really afford to ignore the financial aspects and the physical aspects of whatever service you are providing. And in actual fact, in calculation, it was found that the contralateral risk-reducing mastectomy is not considered as cost-effective. So in conclusion, as you can see that the contralateral mastectomy practice is increasing, and I think it will continue to increase. It is a very complex issue which we have to address very carefully. I cannot emphasize enough the role of the physician in advising, discussing, informing the patient before reaching the decision. And in my sort of observation, that there is really in this situation, there is no right or wrong, but hopefully we, with careful discussion with the patient, we get it right for the patient's welfare. Thank you very much indeed.
Thank you very much, Mr. Hamid. I'm very sorry about the little mix-up and the delays. We've had excellent speakers, very lucid talks, and I think we run a little short on time. So we are going to thank our speakers for their fabulous deliberations. Word of thanks to our organizers for setting up a great talk. And Dr. Shetty, if you'd like to say something too with it.
Thank you so much. I think we should, in the interest of time, we'll quickly move over to the panel discussion. Thank you, Neeta, for being with me.
Thank you.
Thank you so much.
Thank you so much, all the speakers and chairpersons. And now we are moving to the next session, the panel discussion. It is a management of breast cancer, and the moderators are Dr. Vinay Deshmane. Dr. Vinay Deshmane is a breast surgical oncologist associated with the D.T. Hinduja Hospital, Breach Candy Hospital, and Asian Cancer Institute, Mumbai. He is a medical director, trustee, and joint honorary secretary of the Indian Cancer Society. He is among the first in the country to have set up a specialized breast service dedicated to the treatment of breast diseases at a private institute. He has pioneered the use of breast endoscopy in the country, made numerous presentations and publications. So it is our honor that Dr. Vinay Deshmane is here as a moderator. And along with him is again moderating Dr. Shishi Shetty. We have introduced him previously. So please take over, Dr. Shishi and Dr. Vinay, please.
Thank you. Thank you, Ritesh, for those kind words. Our panelists, we got a we got a good esteemed panelist. We have one Dr. Suraj Pawar from Kolhapur. He is the chairman and managing director of the Kolhapur Cancer Center. He is more known for his thoracic work and for his Pawar technique, which has been quite famous. Last 25 years of surgical oncology, and he's a great friend. Our next panelist is Dr. Anil Heror, who is the head of surgical oncology, Fortis Hospital, and runs 2 courses. One is a DNB surgical oncology and a fellowship in colorectal surgery. He's done great work in robotic colorectal and breast surgery. The third panelist is Dr. Rucha Kaushik, who specializes in breast cancer surgery, breast reconstruction, and oncoplasty. She spent the last 10 years in this field. And our last panelist is Dr. Bharat Bhosle. And I think we got one more. Dr. Bharat Bhosle is a senior medical oncologist who practices in Bombay Hospital, Jaslok and HN Reliance. Is also the director of Sunrise Onco Daycare, which is operating in Malad, Thana, and Goa. So a lot of good work in medical oncology with Dr. Bharat. And I think we have a radiation oncologist in our panel, Dr. Nikhil Kalyani, who is associated with the Jaslok Hospital, Mumbai. He's got a good 15 years of vast experience in the field of radiation oncology in IMRT, IGRT, SBRT, and VMAT. I think without wasting any more time, I would like to ask Dr. Vinay Deshpande to start the panel discussion if all our panelists are ready. Dr. Vinay?
Yeah, thank you, Shashir.
Thank you. I made it quick.
Yeah, thank you. And I'd like to thank the organizers for giving me this opportunity to conduct this panel discussion. And a warm welcome to all our panelists. Can I share my screen? Can everyone see the screen?
Yes.
Right. Okay,
yes, sir.
Okay, let's start with the first case. I've got 3 cases, but I think we should be able to go only, probably finish only 2 of these. But if we can, then we'll go through the third one. The first is a very common presentation in the clinic, a 54-year-old postmenopausal, asymptomatic woman, no family history. I just noticed a lump in the right breast. She has a moderately sized breast. It's a 2.5 centimeter lump in the lateral half of the breast. Skin nipple areola is normal, no obvious axillary supraclavicular lymph node. Okay, who'd like to take it up from here? How do you proceed? Any of the surgeons?
Shall I start, sir?
Yeah, please.
Yeah, Dr.
Anyone.
Yes,
I think
sir.
we'll keep the discussion open. So whoever wants to really make
Yes,
a comment can make it interesting.
Yeah. So 54 postmenopausal with right operable breast cancer, as we define clinically in our clinic as operable breast cancer. First, with triple assessment, after confirming clinical examination, we do mammogram to confirm that it is a solitary lesion and there are no other non-palpable or microcalcification present. And ultrasonography along with mammography to know the exact size and any other cyst or any other solid lesion, followed by yes, sir.
Yeah, so on imaging, you're seeing a slightly irregular lesion. It's 2.3 centimeters, hypoechoic on ultrasound, no axillary lymph nodes, BIRATS 4. And the patient's already had an FNA when she's come to you. And it's not really contributory. They say there are some cells with atypia, which are suspicious.
Yeah, so I would like to go ahead with true cut biopsy, sir, to confirm the diagnosis. A true cut biopsy will give the histopathological diagnosis, grading, as well as immunohistochemistry, ERPR, HER2, and Ki67 status.
Anybody else does something else rather than a core biopsy? I see a lot of patients coming to us who have had incisional biopsies outside. Very often the tissue is taken out in bits and the tumor size is not available. I'm sure all of you have come as surgical oncologists, we see this. So
Vinay, I also agree with your experience. We have the same experience, or maybe more so in tier 2, tier 3 cities. And since the audience today is mostly general surgeon and PG students, I think it's a very, very important point you made here, that never to do an incision biopsy.
That's
Never.
right.
I
So
mean, always
incisional,
never. I don't remember the last time when I did a open incision biopsy, because you can almost always get a tissue in true cut, and the incision biopsy does more harm than benefit, and especially for the further planning. So
right.
this should be the take-home message to the general surgeons.
Right. So no incisional biopsy.
Yeah.
What about, we also see patients who have excision of tumors and then they come to us. So would anybody, any on the panel, advocate an excision of the tumor for diagnosis rather than a core biopsy? She's already had an FNA. Core biopsy adds to the cost. Does anyone advocate this?
So we don't advocate it as a primary investigation, but if your FNAC or TrueCut is really inconclusive, then the option, and clinically, if you're suspecting it to be a malignancy, then it's sort of as a last option might do an excision biopsy, but that should be with a clear margin.
Okay,
So
that's a very important point. It's excision with a clear margin for diagnosis is although not what we would really like in today's era. It's a core biopsy, but in certain cases we do see excision biopsies, and as long as they're taken out with a margin, that's fine. What about excision with the frozen section to proceed? Anybody?
Vinny, can
I come in, Vinay?
Yeah.
Hi, Vinay. So I think it's one of very, very pertinent questions that you have asked. I think there are two, three things I would like. First, as far as FNAC is concerned, can I play the devil's advocate here?
Yes.
I think FNAC is something that has been condemned. I think if you are very confident of your pathologist, it's an experienced pathologist doing an FNAC, you can still go ahead, because as far as I am sure we'll come to the discussion of neoadjuvant chemotherapy later. But in most of the places, you can probably patients are going to go ahead with upfront surgery. Though I would agree that you would require an immunohistochemistry, but still, I think the jury is not completely shut on as far as neoadjuvant chemotherapy is concerned, even in triple negative. And I'm sure Bharat is going to jump at me and put some sense into me.
Let's not get into that area just now.
The second thing is, I think, as Suraj rightly said, incisional biopsies are just to be mentioned, to be condemned. Excision biopsy with frozen section, I think, as far as most centers are concerned, we do not have the expertise for the kind of frozen section that is required. I would really not encourage people to go ahead with frozen section as far as getting a primary diagnosis is concerned. So TrueCut or a core biopsy still remains a very good procedure to do, and especially when aided with radiology.
Right. So the take-home message here is that core biopsy is what is generally advocated. There is a cost problem especially in certain sections of our society which have to be taken into consideration. But yes, core biopsy is the way that we proceed today. What about pathological subtyping? Do you always want a subtyping before moving ahead?
Benny, can I just add something, please? It's Hisham.
Yeah, quickly, Hisham. Yeah, hi, how are you, Hisham? How are you?
I'm all right. Nice to see you. I mean, I think it is. I don't think there is any place nowadays for fine needle aspiration cytology. Secondly, yes, the subtype is very important if we're going to manage the patient properly. We can leave the local issues aside, but we really need to tell what should be done rather than what we can and cannot do. And thirdly, I think the surgeon who's going to do the excision, it has to be the surgeon in charge of the case, not having at one place wide precision against injury.
Yeah, Hisham, unfortunately, the practice in India is fairly different from what happens in the West. So these are problems that we are facing on a regular basis. So it's important to bring out one, that incisional biopsy is not the way to do. Don't take out tumor in bits. If you're forced to remove the tumor, then take the tumor out completely. And excision with frozen section, again, is not something which we generally do. And that a core biopsy and subtyping is what is advocated in today's era. Okay. Right, so this patient, how would you proceed? She's had a biopsy. she's had a biopsy which shows that it's a cancer, it's a cancer, and let's say it's a 2.5 centimeter, 2.3 centimeter invasive ductal cancer, grade 2, ER positive for the time being. What investigations do we do at staging routinely? Anybody in their own practice?
Yeah, can I come in?
What are they doing? Anybody? Yeah, quick.
Yeah. So
we don't have much
basically,
time, so may I just suggest that everyone don't repeat what somebody else has said. Just add to what others have said.
Yes, so I will not go into the details. So message is very clear because our audience is from 2-tier and 3-tier, and what we do in Mumbai, and we have a privileges to do that, and that's why we do it. So excision, you rightly said excision biopsy inside the OT process section and go ahead. So I would not do so I would not do a PET CT scan, bone scan for clinically node negative post-menopausal lady who is ERPR strongly positive. A simply chest X-ray and USG is enough for me to do a staging workup. If I have CT and abdomen in my institute, we have a multidisciplinary team and we do take a call. But for node negative disease, the message is very clear. You do not do PET CT scan and bone scan.
Okay. Anybody feels differently on the panel?
I agree 100%.
Right. What are we? Breast MRI. Does anybody do an MRI as a routine?
Well, it depends on, again, we have to be very clear about the indication for MRI scan. So
No, Hisham has a routine. I just wanted to say routine because that's
absolutely no.
All right. Okay. So this lady doesn't have any spread of the tumor, and she what sort of surgery would you offer her? Anyone, Rucha or Anil, whoever
If she's
wants to.
suitable for breast conservation, sir, by imaging wise, I would like to offer her breast conservation surgery with sentinel lymph node biopsy or axillary sampling.
And what if she refuses? She says, I met some other doctors and other people, like which happens very often in India, and they're saying that, well, mastectomy is the best way to go.
Yes, sir. But we need to counsel patient and explain it to them that the chances of recurrence are exactly same, and overall survival will be. It doesn't depend on the type of surgery, but the grade of the tumor and rest of the factors. So if
she hears you out and she says no. Yeah, she says no.
Then we have to respect, sir, her decision.
Yeah, I think I think that's the important point. It's not really always the surgeon's choice. It's the patient's choice, and you can't tell them that you have to have a breast conservation. I think that's a very, very important point.
Yeah. Vinay, can I add just one small point here? Even in even in tier 2, tier 3 cities, even our experience at Kolhapur Cancer Center, at my place, almost around 70% of the women end up having a breast conservation surgery. Even women who are old, maybe 70 plus, 75, if you give them an option and you explain to them properly, I think the counseling and proper explanation by the surgeon himself is extremely important, and how you put the data in front of them. So almost more than 75% of my patients, they opt out for breast conservation surgery, even not considering the age bar as well.
I must admit that my experience actually has been exactly the opposite. The more we counsel them, the more I find that a lot more are actually going in for mastectomies. And I do have a very high social class clientele who can afford to go abroad for treatment, most of them. And it's interesting to see that even people from stage 3 people want to sometimes have a mastectomy. They don't want to. It all depends on their priorities. And anyway, the point I always wanted to make is not BCT or MRM, because as Rucha has rightly pointed out, there is nothing which says that you should have to do a mastectomy. But the patient's choice needs to be respected, and patients need to be counseled. Hisham, sorry, you were saying something.
I was going to say exactly the point you are making. I think we are obliged to give the options to the patients when there are options. And there are patients who would want mastectomy, no reconstruction. There's nothing wrong with that. The others who will refuse mastectomy at any cost. So, but we have, when there are options, I think we are obliged to give it to the patient.
Correct. Okay, so you're doing a breast conservation. How much do you take out?
It's a
because of the tumor. I mean, basically, I'm asking for the margin. That's what each one's practice.
Well, it is for invasive disease now. I think it is universally accepted that your margin could be 1 millimeter, and that is very adequate. And in some places, based on the tumor biology, they may even accept the ink on tumor.
That's fine. Anybody feels differently? They want wider margins or do that in their regular practice?
No, sir. Usually, free of ink on margin is good enough. I mean, sometimes when we are not sure or while operating, if you feel that the surrounding area is looking little not so well, then you may be taking 1 or 2 centimeter extra and would like to check it on frozen or imaging. But otherwise, routinely, if it's a well-defined, then I think free of ink on margin is sufficient.
And Suraj or Anil, do you feel differently about this?
Oh yeah, I agree with what is being said, but in practice, to take a 1 millimeter or 2 millimeter margin is not practical. So we usually end up taking at least around 5 millimeter to 10 millimeter while you are actually performing the surgery. You don't really measure whether it's 2 millimeter or 5 millimeter. So we tend to err a little bit practically on the side of
Safety. All right. Yeah, I think that's a very important point. What about frozen section of the margins on table? Does anybody do it?
I don't do frozen sections, sir, for margin when if I can feel that okay, it is well covered and the tumor is not exposed anywhere. So I usually don't.
Suraj and Anil, your practices?
No, we
Not
don't.
routinely.
We don't know. If you're satisfied on table, you remove the tumor and have a look at it. And if you're satisfied while performing the wide extent lumpectomy itself, you'll come to know if you're experienced enough that your margins are clear. So as a policy, we don't do it frozen on table.
All right. I must say that as my practice, I do it, but it doesn't have to be done. Okay. Axilla, what's everyone's approach to the axilla? This is a lady who has has nothing palpable in the axilla. Ultrasound has not picked up anything. So it's N0 clinical axilla, your approach?
We do a sentinel.
And do you freeze the sentinel?
Yes.
Or do you send it for histology?
No, we do freeze it.
Okay. And if it comes back as, let's say, micromets, what do you do?
As of now, we complete the axilla.
All right. So and for a macromet also. And
yes.
Hisham, how do you people manage it?
We certainly, for micrometastasis, we do not go back. Although the evidence, as I'm sure you're aware, that it showed that it could be up to 16% non-sentinel node, but that has not been translated.
And if it's a macromet?
Macromets, that certainly we will, with the patients, will be subject to either further surgery or the radiotherapy to the axilla. So there is further treatment being offered to the patient.
And if it's if you've taken out, let's say three nodes in your sentinel node, and just one is positive, 2 are negative, how much more axilla? If people go in, how much more axilla do you clear?
Well, if we believe that if we are actually going to embark on axillary clearance, it should be level 3 axillary clearance. If you have alternative, so for the morbidity, then these patients will be suitable for radiotherapy according to the AMROS trial. However, now we are waiting for the results of the trial to look at whether we can actually omit surgery at all. But we do not actually embrace the Z11 if that's what you're asking.
Okay, now I'm just going, just for the sake of discussions, we've come to the pathology. She's had a surgery, uneventful recovery. She has a 2.3 centimeter grade 2 LVI and no perineural extension. Lymph nodes are all negative. Got an ER positive, HER2 2 plus, Ki67 of 70. So how do you go ahead planning adjuvant treatment?
Again, that it looks straightforward. She will have radiotherapy to the breast and will go on endocrine treatment.
Right. Well, Anil and Suraj. ER positive, HER2 2 plus, KI of 17.
I think Bharat can take this.
No, I want you to first ask, both of you.
Sorry, I missed the 2 plus. So obviously you have to do fish.
That's
to
right.
confirm. Yeah.
Okay.
Yeah.
All right. Let's say fish is negative here.
Right.
Right. So that's an important thing, that we look at these parameters in the tumor, the hormone receptors, the HER2, and HER2, if it's 3 plus, then it's considered positive, but 2 plus, you need to check its the position because by something called FISH, fluorescent in situ hybridization. Now in this case, it's positive, so we have come to ER positive, HER2 positive with a KI of 17%.
I think.
Sorry, FISH is negative. In this case, FISH is negative. Sorry, your
Okay.
FISH is negative. HER2 negative, and KI of 17.
Yes.
That's why I want the surgeons first. I want to hear the surgeons first before Bharat comes in.
Well,
Sir,
I mean,
adjuvant radiotherapy with endocrine therapy.
Right, radiotherapies are given, we understand it's breast conservation. I'll come to the radiation therapist in a couple of minutes, but let's go on with the adjuvant treatment.
I think in this case, if it is not strongly ER positive and not strongly PR negative, you may argue that something like the oncotype could be carried out to ascertain the benefit.
Yeah, so that's what I want to head for. Does anybody do the genomic test? Does anybody do it?
Yes, sir. If patient is affording, and sometimes patients are more keen to take chemotherapy, that whether should I take? I
think the question here is, how do you counsel patients? Let me get Bharat in. Bharat, are you around?
Yes, I'm around.
Yeah.
So this kind of a situation is very interesting, and I like to face this situation more often. Straight away, I would not say the patient to go ahead with the endocrine therapy unless and until the patient is properly counseled. As you rightly mentioned about the recurrence score, I would explain them what is the recurrence score, what is the traditional way to get it. For me, KI67, 17%, again, it's a borderline. For me to be safely, for a non-affordable patient, sometimes I end up in prescribing the endocrine therapy. But here, ER is 40%, PR is only 20%. It is not 8/8 or 6/8. So directly, I would not.
Okay. Let's for the sake of this thing, let's say ER is 65%, PR is 30%. Okay, let's go. Let's take it there.
So I would like to answer it the other way. So if I have a similar postmenopausal lady who is relatively young without diabetes, hypertension, and she has ER/PR 8/8, PR 8/8.
Okay, all the patients we are discussing are medically absolutely fine for all treatment.
Yes. Yeah. So I would like to know, because the tumor size is also 2.3, grade is 2. So preferably a recurrence score. And in the absence of recurrence score, my choice for a fit lady is 4 cycles of AC and then endocrine therapy with the radiation.
So without a genomic test, you would give chemotherapy.
Yes.
Okay, that's anybody else feels differently? Patient turns around and says, I'm really not very keen on chemotherapy. Doctor, can you tell me how much will my lifespan increase if you give me chemotherapy or if I just take hormone therapy?
In this scenario you have given, it is very low benefit of chemotherapy.
Does anybody use Predict at all in their practice? There's an online program which is free of charge and easily available, which gives you some sort of a prediction rather than us sometimes talking to a patient.
Yes, I do use for all the patients. Use for all the patients, and let the patient know what is the benefit. If the patient still says no, then no, with that caveat of whatever, 2%, 4%, 6%, put it on paper and write the endocrine.
Fine. So anyway, there is a role for a genomic test in an ER positive, HER2 negative, low KI67 patient. And if you do an oncotype DX and in this patient, she comes back as low risk, would you then still consider chemotherapy?
Certainly not.
For low risk, no.
Okay. All right. So basically, yeah.
So I would like to come here. There are many index available. So the best.
I'm saying I specifically said here oncotype. They've done oncotype.
Yeah.
So I don't want to go into the discussions of all the genomic tests. In principle, there's a genomic test which is available, which is classifying this particular patient into low risk.
For low risk, answer is no.
Okay. All right. So basically, the take-home message is that every single patient does not require chemotherapy. There is a group of patients who are ER positive, HER2 negative, lymph node negative, who probably do not benefit very much with chemotherapy. So the message is that everyone doesn't require chemo. Okay, let's say now this patient doesn't have that. She's now got a HER2 positive tumor, ER of 15% and a KR of 25%. What should be the adjuvant treatment in this patient? Lymph nodes are still negative.
So in a fitter patient,
she's fit. Let's not discuss fitness at all. Yeah.
Yes.
Very fit.
For why I'm bringing this issue, because if an unfit patient, there is a no, you can de-escalate the chemotherapy into weekly paclitaxel and trastuzumab.
That's why I don't want to get into that. Just what is ideal chemotherapy in ideal patient?
Yes. So here, no, there is an option of avoiding anthracycline. You can use taxanes, carboplatin, and trastuzumab once in 3 weekly regimen. If the patient has no problem with the travel issues. Otherwise, no, the other regimen, which is weekly paclitaxel with trastuzumab. Prior to that, you can offer AC, 4 cycles of AC. So any of the 3 regimens which are available, you can choose based on those circumstances and feasibility for the patients. But 1 year maintenance therapy is not ruled out, even if the tumor is 2.3 and it's in the grade 2, like previously. So for smaller tumors, there is a latest data and meta-analysis from the Tata Memorial. They have showed that 6 months versus 1 year is equivalent. But that is for no negative. I would still consider that regimen for before experiment. But my preference is 1 year maintenance.
So basically chemotherapy and anti-HER2 treatment.
Yes.
Okay, how do you counsel the patient about side effects? 1, 2, 3, 4. What do you tell them?
So, respected moderators, may I just interfere, please? We request from the organizer side that please finish the session by around 4:30. You have 5 minutes more left, because we are running short of time. Thank you so much.
Fine. Okay, Bharat, quickly, and I want to ask the radiation therapist.
So side effects, it's a long discussion. No, it's very difficult to. Yes, patients are all the patients.
No, just what I want you to is just enumerate the side effects so people know that chemotherapy is not without its side effects. HER2 is not without its side effects. So what are those that you just enumerate?
So for HER2 targeted therapy, if you ask me the usual side effect, that is very safe as compared to the chemotherapy. If you compare with the chemotherapy, there is a reversible problem with the heart. Reduction in the ejection fraction, which reverses immediately. We stop the moment we stop the HER2 targeted therapy. That is why you have to check on the cardiac toxicity every 3 monthly 2D. That is mandatory, because you have to pick up the drop in the ejection fraction, and if that is more than 10%, you have to stop. So you have to have a baseline, and every 3 monthly 2D.
So one is the heart. What else?
Yes.
Anything else?
Specific to trastuzumab asking, or about chemotherapy?
For this regimen that you are giving this patient. So just 1, 2, 3, 4, 5 quickly.
So
because I want to ask the radiation therapist something.
Yeah. So what is very important here is the hair loss for every woman, and I think everybody has. Most of them, yeah. The nausea vomiting is usually, but with the newer generation of antiemetics, they are very well managed. Some of the patients, because of the antiemetic, they have a lot of constipation. These are day-to-day complaints by the patients.
But basically, side effects are very easily manageable in today's era.
The most important side effect I'm coming to is the extravasation. Most of the people don't go for port. I'm not the promoter of port, but extravasation is very, very important, because the drug doxorubicin is sometimes creates big problem for all of us. So
thanks, Bharat. I must ask the radiation therapist something before we finish. So Nikhil, can I get you in, please?
Yes, sir.
Yeah. So this is a breast conservation, which is run-of-the-mill breast conservation. Can you just talk to us about the radiation, the side effects, something about the newer techniques, and do you have any difficulty about radiating post-oncoplastic conservations?
So being
you just saw the extensive oncoplastic things, so do you have concerns or no concerns? That's all. So then we can wind up with that. So Ritesh will also be happy.
Okay, sir. So only concern with the oncoplastic technique is to delineate the tumor bed properly, because whenever we plan a boost to the tumor bed, we need to delineate the cavity and the tumor bed. So that is the only issue with oncoplastic procedures.
So no problem. Any problem? Do you think the proton beam has any great advantage over what is being presently done?
No, sir. I don't think so. The proton has an additional advantage. APBI, yes, maybe that is the candidate for APBI because the size is less than 3 centimeter post-menopausal ER positive, HER2 negative. So APBI can be either with a brachytherapy or an external beam therapy, which you can plan, or traditionally like a whole breast radiotherapy with a boost.
And can you avoid the boost?
Not really, sir. In elderly, sometimes we do avoid the boost more than 65, but she is a 54-year-old lady, and the boost is not going to make much of a difference with the cosmetic outcomes. So we can.
And when you counsel these patients, what do you tell them? Because it's surprisingly, when in the clinic, I don't know what the other clinicians find, but most patients think they're going to lose their hair with radiation.
No, sir.
That's a very, very common thing. Yeah. So quickly we'll that and we'll wind up. Yeah.
So what we counsel is radiation is like a surgery. So wherever we give radiation, you are going to get the side effect at the same area or local side effects. So no hair loss with radiotherapy to the breast. We do counsel them regarding the skin toxicity, which is common with radiotherapy to the breast. And if we need to treat the supraclavicular area, then there is some kind of mucositis and the difficulty in swallowing, which occurs during the radiation.
Do you like to use these creams which have come out in the market now post for radiation, and during radiation?
So during radiation, after around 10 to 12 fractions, we start the local steroid cream like Betnovate and twice a day, and they continue for around 2 to 3 weeks after completion of radiation.
Hisham, what is being done there at Guy's now for radiation? Are they applying all these creams?
No, these, I mean, guys, that would be actually a straightforward whole breast irradiation. And if the margins are adequate, then boost is not usually delivered.
I think we'll have to wind up here because we've run out of time, as the organizers have said. And I'd like to thank all the panelists for a very interesting discussion. I mean, I don't think we can even touch the surface of breast cancer management in 35 minutes, but at least we've got some idea. Thank you very much.
Thank you, Vinay.
Thank you, sir.
Thanks.
Thank you so much, everyone. Thank you, Vinay sir. Thank you, Shishi sir. Thank you, Dr. Suraj. Thank you, Dr. Anil. Thank you, Dr. Rucha, Dr. Bharat, and Dr. Kalyani. It was such a lovely and interactive panel discussion. So from now, we are moving towards the final session. This session is of master videos, how I do it. So the chairpersons of this session are Professor Shilpa Rao. She is the professor and head of unit and in charge of breast services at SGS and KM Hospital. She started the first multidisciplinary breast services in a public hospital in Maharashtra. And the next chairperson is Dr. Samir Rege. He is an associate professor and unit chief of the Department of Surgery at KM Hospital, Mumbai. He has independently performed various major and complicated emergency and elective general and gastrointestinal surgeries. He was awarded FMAS at MSCon 2008 at Chennai and has numerous national, international, and publications to his credit. So over to Dr. Shilpa and Dr. Samir, please.
Good evening, everyone. Thank you, the organizers. It's been a wonderful session since morning. Our first speaker for the day, Professor Somshekhar, really requires no introduction. He's concise, he's precise, he's crisp, and he continues to be a scientist. I think all those major achievements that have been described are well known to all of us. So without much ado, may I invite Professor Somshekhar to start his video on sentinel node biopsy techniques.
Thank you very much. I thank the organizers. It's a pleasure. I really enjoyed the panel discussion. My close friend Vinay did. So I'll keep my video-based talk to quite basics. I bring warm regard from Association of Breast Surgeons of India as its president. Sentinel lymph node is the first echelon lymph node which drains the primary tumor. For each breast, each patient, there is a different sentinel node. It's never fixed. Don't go with the notion it is always in level 1, it is in level 2, level 3. No, it is different for each patient. Traditionally, there are 3 techniques to do. One is blue dye, second gamma, and then ICG probe. So you can inject, intradermal, subcutaneous, peritumoral. Now there is a meta-analysis. All of them are same. So now we give single intra-areolar, retroareolar SAPI. Blue dye, you can use any type of blue dye. Lymphoxylin, methylene blue, vital blue, all are same. Handheld gamma probe, there are 2 main companies. I have 2 probes. One is a Neo probe and another one is a probe from Europe. But most important is the settings. If you use technetium 99 nanocolloid, the probe setting should be 1:1000. Primary SLNB is 1:20 of the primary. After you remove that node, 1:10 background. This setting is provided by the company, different for each. Radioscintigraphy is not mandatory. In learning curve, you can do it. You can see here the primary site injection and the sentinel node has been found on a scintigraphy. You can use a commercially available filtered and then sterile methylene blue. It is same. Enormous paper are there. We have published 10 years back a large study which is same. Now, if you use Europrobe, I told you, you can inject peritumoral, retroareolar, upper outer quadrant, all are same. If you're using methylene blue, beware, don't inject intradermal, necrosis can happen. 1% anaphylactic reaction can happen with vital blue dyes. It is rarely reported in methylene blue 2 or 3 cases. As soon as you inject, before you start, keep the probe and mark what is the hot spot. Now in this case, 9,937 is the reading. Then you keep a lead shield to separate the radioactivity to prevent the shine through effect, and see 1:20. Probe setting is 1 in 1000. So you mark the sentinel node. Depending on which dye you use, now totally you can use single 3 ml retroareolar, or you can also use peritumoral. All are same. So remember, the blue dye duration is 7 to 8 minutes. It goes very fast, so it is done on table. Depending on what surgery you're doing, I'm showing 3 short videos. If you're doing mastectomy, raise the upper flap, follow the lymphatics, straight go to the axilla, use this lead shield to prevent shine through effect from the primary site. Then use the handheld gamma probe, see the lymphatics, how it is going, navigate the axilla. Remember, primary reading to 1:20 is the sentinel node. After you remove the sentinel node, you check the activity, background activity, it should be less than 1:10 of the highest positive node. So navigate in the axilla, identify 1:20, that is the definition. And probe setting for sentinel node is 1 in 1000. For roll, radio-guided occult lesion localization is 1 in 1 lakh. So 1:20, you navigate and mark that node. That is the highest node. You may be lucky, 96% of the time, the hot node could be the blue node, not necessarily always. 3 to 4% it would be different. That's why combination of both is superior. More than 98% identification rate, sensitivity specificity in excess of 95%, false negative rate less than 3.4%. That's why it is recommended by ASCO to use combination of both. So once you do that, it could be blue and hot same node or 2 different nodes. Most of the time, it is found that it is a single node. About 11% it could be more than 1 node. In the disguise of removing the sentinel node, don't do axillary sampling. Then the benefit of SLNB is totally lost. Still you end up with lymphedema, you will end up with brachial neuralgia, you may end up injuring the intercostal brachial nerve. So a badly done sentinel node is worse than a properly done axillary sampling. So don't do this. It's a quality basis technique. So now you can see that that is 1:20 node. There are 2 ways. You remove with a small rim of about 1 millimeter fat. So in case it is positive with extracapsular spread, you had a small margin. You can also use a high bipolar pinching effect to remove minimal disturbance in the other axilla, both in vivo, in vitro. You can see that it is more than 1:20 of the primary site. Once you measure it in vivo, in vitro, both confirm 1:20. Now you record the reading of the highest hot node, blue node. Now you go back with the probe, navigate the entire axilla, and then look at it. No background activity should be there. Any background activity more than 1:10 is counted as other sentinel nodes. So that's exactly the reason your nuclear medicine department should give 280 to 300 nanometer. If you give less, all nodes take up. If you give a higher particle, nothing takes up. Depending on the nanocolloid, 2 hours prior to surgery you can do. Or if you use albumin bound colloid, it's a overnight. If you use a technetium sulfur based nanocolloid, it is 2 hours before. Blue dye is on table. The same thing is done if you do breast conservation. You can see that the site of injection, mark, the probe setting is 1:1000. Navigate in the axilla, keep a lead shield to prevent the primary shine through effect from primary. 1:20. If you're doing breast conservation, we first harvest the sentinel node, send it for frozen section, use CAP guideline. The microtome is set at 2 micron. So only micromats could be missed. So the frozen section report otherwise is good. We published 10,000 cases of sentinel lymph node with frozen section, false negative rate less than 2%. So we in our institution use CAP guideline, 16 sections, 2 oncopathologists. If it is negative, we close. Indian solution for Indian problem, you can use a sterile methylene blue, which is available already. Remember, it is not the normal methylene blue used in OT. It is a sterile methylene blue available in your intensive care unit used in methemoglobinia toxicities. Pinch the nipple, retroareolar SAPI. It is not intradermal, not parenchymal. Single injection, Initially, there were reports from Pittsburgh that you can take 2 cc of saline and then flush it. It is not mandatory. A gentle massage also is not mandatory, even though they're all practiced. So it doesn't matter which quadrant the tumor is. You can actually, inject a single 3M. When you go to axilla, you will see this. If you use blue dye alone, 86% to 85% is the identification rate. Now, the third technique in last 1 minute of video is a ICG fluorescence. There are commercially available and Indian probe. Indian probe is very economical. You can use, I have 2 Indian probe. There is a common probe which has an optical detector with ICG. Also, the same probe is integrated with, the radiocolloid. So gamma probe and ICG integrated in one for evaluation of sentinel node. You can see that it has got 2 parts. Can you see that? One picks up the gamma rays and the other one identifies the ICG. So you can give ICG with colloid. You can go same technique. 1:1000 is the probe setting. 1:20 primary to the axillary node. Fluorescence tracing, you can go back and then do the fluorescence tracing, identify the fluorescence image, and then you pick up the node. So the other option is available is an Indian probe, which is very economical. ICG is available, made in India. It is available from 2 sources. So you give a single, the advantage of ICG is it's a dynamic scan. It is not a static. Even before you keep a skin incision, you can see the lymphatics real time. So you don't pick up second echelon node and wrongly think they are the first node. So you inject 5 minutes. You can see this. This is a real time. I will show the video. Retroareolar SAPI bloats up. See this? Fluorescence. In front of your eye, the lymphatic channel goes in few seconds and stops in the axilla at the first lymph node. It is a dynamic scan, real time, seen in front of your ear. You don't need a blue dye, you don't need a handheld gamma probe, no nuclear medicine therapy center, no radioactivity, not dependent on a nuclear medicine doctor or a center. You can see that straight away the lymphatic goes and stop, and you can see the lymphatic, and quite often, 69% of the time we found in our study, you can find a node seen through the skin even before you keep an incision on that. So now you mark where that firefly SLNB is. As soon as you open, beautiful big fluorescence. And also because ICG is light greenish blue, the node also is there. You can see that retroareolar SAPI in front of your eye. As soon as you inject, you can actually put a fluorescence camera and then see the fluorescence. Few seconds, it's a dynamic scan, not a static. So you can do it after GA because the patient is then not under discomfort, unlike the radiocolloid, which causes burning sensation. Here you can see even before an incision is kept, a sentinel node is very well seen there. You can go there and pick it up and fluorescent node. And once you pick it up outside, both in vivo, in vitro, you can go ahead and do that. That completes my video, but I'll just say 2 things. The same probe is also used for primary lymphovascular anastomosis. When a sentinel node is positive and frozen, we do ALND to prevent lymphedema. And this is a trial which we had done, a prospective 2-arm 100-patient study comparing ICG alone with our Indian probe with standard, published in the prestigious Breast Cancer, which showed ICG alone was superior to both in false negative rate, superior in sensitivity, specificity, and also identification rate. Now I have total 100% switched over in last about 2000 cases. And this is also published and presented in conference, and it is included in the recent Oxford meta-analysis, which is published. So this was the Indian solution for Indian problem, can be practiced in 2nd tier, 3rd tier city independently with low cost to all the patients. Thank you very much.
Yeah, Dr. Somsekhar, always a pleasure. Just a quick question. In case we are doing it in patients whom we have given chemotherapy and the sentinel nodes have disappeared, is there any difference in identifying them?
Yeah, we did a study on that. Number one, before we give chemotherapy, we do an axillary high frequency probe ultrasound. As per the SOUNDS trial, if they are suspicious, we do an core of that node. If it comes positive, we clip that node. And when you finish chemo and go and do sentinel node post neoadjuvant chemo, as long as you do targeted SLNB, then the false negative rate is still less than 4%. If you don't clip the axillary node and do targeted SLNB, false negative rate are 10%. Then we found in our study of 1,600 patients, there is no difference. Still the lymphatic channels are present. Identification rate is still in excess of 98%.
Thank you. I think you've made it so clear. I don't think I have any questions. If there are any questions from the forum, we could have them asked. I don't know if Samir is there. He wants to ask something. Else we move on to the next speaker.
I think we can take Dr. Sandeep Bipte because he's waiting. We are already short of time, madam.
Okay. Yeah. All right. Samir, would you like to introduce him? Yeah. Thanks, Dr. Professor Somsekhar.
Thank you.
Wonderful as always. Bye.
Yeah. Thank you, Dr. Somsekhar. We have our next presenter, Dr. Sandeep Bipte, who is a consultant breast surgeon from Mumbai, has many fellowship with lot of oncoplastic training, and today is going to talk about port placement techniques. So over to you, Dr. Sandeep, who is also a convener of this meeting.
Thank you, sir. Thank you, sir. So am I audible?
Yeah, loud and clear.
Lovely. So let's move on to the further topic, and that's a port insertion. I think it's a very, very basic topic, need to be learned by general surgeon, because we need to see this issue. A lot of about 80% people come from periphery and had chemotherapy outside, and they come up with this complication. So why not suggest this the port insertion when they require chemotherapy to start with? So I learned with this experience last 10 years how this distribution has started, where in 2012, we annually do around 200 to 250 cases annually. And the graph we started in 2012, so initially we were putting 50, but today, in last year, we have put almost 300 cases. So this is what the trend is changing. A lot of patients have chemotherapy. If you say complication rate, it's very, very less because it's more of practice, and with the training, it comes the lesser complication rate. So initially we used to take around 1.5 hours to put the classic position and the localization, everything. But today we can finish in 10 to 15 minutes time. And we have started this educational programs for the surgeons to periphery who can train and do this surgery outside. So let's move on the video. This is what the port is done. So this is presence cavity port, and this is it comes detachable port. It has got the metallic part, and one is the silicone tube which is fixed at this part, and we have this cap on this. This is a protective cap, the metal cap, and on top of that is the plastic sheet which will protect this in case of a slippage. There's a cap which can protect this tube and the exposition. So once you fix this, we need to flush this port with the heparin solution. We use 1 ml of heparin in 100 saline solution, and we flush. This is syringe, and take the saline, flush this with the port needle. So this is to check the patency. Sometimes we may get some leakage from the tube, so we need to confirm before putting the port. When you flush it, the tube is patent, and you can see the other end saline is coming freely. Right, so the port is the tube is patent, and then we go to the next step. So marking, the marking is very, very important. We can put it on the any side, preferably in the right side. Right, I do prefer right IGB in 90% cases. So this is a clavicle. This is 2 centimeters below the clavicle. We have able to put. I'm palpating the carotid artery. I'm keeping this patient, I don't put any bolstered or head position, just keep in neutral position, 30 degree head on left side. I mark this carotid artery. This is just lateral to it, is ITB. The clinical ground. This is a local infiltration. This I use 2% local anesthesia. Generally, we do port under local with some sedation, or some patient require maybe TIVA. So this is local infiltration at the site of the pocket, and the few cc of local in the tract. So this is the local is injected. This is tract, and this is the how we the palpate the position of the artery, and just I place this artery and push it a little bit on medial side so that it avoid the carotid puncture. Go bang 1.5 centimeter just below it, and you aspirate. You bang on. In most of the cases, you can get IJV, and you can see the color of the blood. It's a dark red color. It's a dark color, which is venous blood, and you can see the amount of trickling down, like a drop by drop. If you arterial, there will be spurt. So these two things will confirm the its ITV. This is guide wire. There's a technique of putting guide wire. Just go gently, and once you go, you can see that when the 2 mark is gone, you can see the arrhythmias. You can see the ectopic bits here. This will confirm your. You can see the ectopic here. This confirms on table that your guide wire is the right side properly. So in some cases, we can just check it out the CM to get the correct position. In most of cases, right side is not required. This is incision. Take a small around 2 cm incision, 2 to 1/2 incision, depending upon the cavity. Dissect the fat. In female, we don't have to go to such deep level because a lot of patients, I've seen the port was fixed to chest wall, but it's very difficult to put needles in. Just dissect as much we can fix the port inside so that it should be accessible from outside for chemotherapy as well. So I created a little pouch here, and creating the pouch, I'm putting this metallic and take out from this another end when the puncture is there. Take 11mm knife, make a small cut, and just take out this metallic slit from the other end. So once this is out, give a traction on this side and take it out a little bit. I try to bend this. I learned this technique a little bit bending so that it will avoid the trauma to the on head side, and just pull it back. That's how this port, this box is fitting inside snugly properly. See, the cavity is adequate, and it is covering nicely. It has got small layer of fat which will be there to help out. So after that, I generally took the Prolene 20 for fixation. Early days we used to fix with this Vicryl, but eventually the Vicryl get dissolves, and we used to face the migration of the port, slippage of the port. But after using the Prolene 2030, there are hardly any cases which has there's a slippage of the port. There are 3 holes here, so just fixing to the underlying tissue. You don't have to go really to the deep chest wall. Just take a proper fixation. So there are three switches. So once the switches are fixed, I'm just going a little ahead. So put this port in the pocket, fix it properly. Once it fixed properly, the fixing is very, very important. Sometimes some people take 2 switches, but I have seen that it has to be established from all the side. If there are 3 switches, we should put 3 or 4 so that it should fix the. Sorry, something happened. This is fixation. The important part here, how to calculate the length, because every hospital has C-arm. Generally, I take out the second intercostal space as a landmark in every patient, second intercostal space, and generally it tends to be around 20 centimeters for the male in average. And I cut down here. I take this mosquito just to widen this entry point, because I have seen most of the time the catheter to get stuck there. Take this plastic catheter, the sheath over the guide wire, and there's a technique of putting this. So once you put this sheath over the guide wire, just make sure that you are going slowly in a round manner. How I just go just in a round fashion so that it won't stuck up, and just take out the guide wire every time. See, when I'm putting inside, I'm taking the guide wire. Whether my guide wire is stuck inside, it's really moving. So that's the correct way. See, the guide wire is moving, gone inside. Once the cage is gone inside, I will take out gently the guide wire. This is another technique I learned. This is 12 and 6 o'clock technique. Take out this stellate, put this catheter properly, and keep this 12 and 6 o'clock position so that the guide wire will make a nice U-turn. Otherwise, in most of the cases, you see there is a thing at the side and which will disturb the flow. So this technique will say 12 and 6 o'clock position technique will keep this U in a proper way. So I'm putting the pressure of the thumb, just pull it out the sheet, and the catheter is gone inside properly. This is heparin solution. So this is, we always check on the table. Put this needle. First, either push it or aspirate. So it's going freely. I'll see the backflow. The backflow is fine. Perfect. The backflow is nice. And this is closure with anything, either by proline, either with the monocryl or bicryl. One stitch here and few switches are down. Right, and the few stitches, this 3 stitches at the subcutaneous plane so that the pocket get closed. And once you fix, always is always better to check these backflow once again. So this is, I'll go ahead. This is how, and finally the subcutaneous switches, and one is, sorry for, I think almost had done.
It is a good presentation, Dr. Sandeep. One question for you. Do you always recommend doing without the CM? Because I always thought it's a better way that you can calculate where the tip of the catheter remains.
Yes, sir, but initially I started with the CM, but right-sided I haven't used the CM because once the technique and second intercostal space technique I using, and invariably I'll show the poster photo is invariably a proper position. Left side, yes, definitely one should use the CM. Especially there is a, when you stuck up with this thoracic tumor, mediastinal tumor, we should have a CM. So we can have this evaluation and we can get CM in this cases. This is a final Excel I will show you. See, nicely it come properly. I was talking about this U-turn, this and this is second intro exactly at proper position. I think this is all the purpose then.
Yeah. What happens if you get a kink at that level, subcutaneous or subdermal level, at the entry point, or you have taken the puncture?
So every
correct it?
Yeah, every point is very important. You can get the X-ray post. So we see the kink and just open that one single stitches and put a mosquito and just you can dilate that area, and under CM then you have to check it out again. There should not a kink. Then that time, yes, we need to have CM then.
Thank you, Dr. Sandeep. I think
you,
we are short of time. It's a good presentation.
Thank you,
I
sir.
hardly see any questions on the chat box. Thank you.
Thank you, sir.
Shilpa madam, would you introduce the next speaker, madam?
Sure. So for the next talk, we have Dr. Geeta Kalyarpet. She's a good friend. And again, she's very enthusiastic, excellent in her field. So without much more to say on this, she's going to tell us about microdocectomy and the techniques that she adopts. Dr. Geeta.
Thank you, Shilpa. Good to see you. So COVID has ensured that this is the only way we interact. So let me just share screen and quickly go to the topic. I think I need to just give a quick background before I go to the video, because this is essentially about managing nipple discharge. Greetings from my institution, which is Max Hospital. And just to understand that pathological nipple discharge, you could possibly see it in the SS, single breast, single duct discharge, serous, serosanguinous, spontaneous, and with significant amount. So that's a very easy way to remember pathological nipple discharge. And the commonest cause of nipple discharge is something which is benign, usually a papilloma, and sometimes you see cancer as well. Very important to take a very good history as to what is the type of discharge, and don't get foxed into those discharges which are expressed. So here we're looking at spontaneous single duct discharge. And of course, examination will also give you a lot of clue as to what you're dealing with. You should be able to identify the duct which is producing the discharge, locate the trigger point. You press on the areola in line with where the discharge is coming. That could possibly be the trigger point, and chart it on your, document it in your chart before planning surgery. Squeezing is not the ideal method to elicit nipple discharge. So for imaging, you would land up doing a mammogram, and mostly normal in about 80 to 90% of patients with spontaneous discharge, there may be nothing on mammogram. Ultrasound is the tool that is very, very critical to identify abnormalities within the ducts. In as many as 20% of malignant lesions, you would be able to see an ultrasound abnormality, while 80% of papillomatous lesions would be associated with abnormality on ultrasound. So that's an intraductal papilloma. You can see these solid little things which do show color on Doppler, and there sometimes you could get inspissated secretions, soft tissue nodules with no associated flow. This could be just duct ectasia. And in the kind of high resolution ultrasounds that we have now, you can also pick up microcalcifications. So there is a lot of talk about MRI, whether MRI would be an important tool in fixing the limitations of mammogram and ultrasound. Well, it is not a recommended tool, primarily because it has got good sensitivity but poor specificity. But with better spatial resolution, again, MRI's role is getting redefined as we speak. So this is a patient, I just want to show you, she had this little microcalcification, very strong family history of breast cancer. And here you would get more information on the MRI, some microcalcification in the duct on the ultrasound, and a very significantly enhancing duct on the MRI. Again, nipple fluid cytology is something that is discussed endlessly, and pathological examination of nipple fluid is not an easy task, and you need a very good trained cytopathologist to be able to make any sense at all. However, nipple fluid cytology is not a reliable method, and that is where we come to the technique that I'm going to tell you, which is duct excision. That is the preferred technique to arrive at a conclusive diagnosis. And the other diagnostic modalities which have been used, ductography and ductoscopy, but these are of limited use. So coming to the surgical procedure, if no specific lesion is identified, excision of that discharging duct is recommended, and in older women you can possibly go ahead and remove the entire ductal system. In young patients, microdicectomy is preferred, especially those who wish to keep their lactational ability. And in some patients, the benign discharges can also be a huge source of nuisance, and there a duct excision is required. So what you need to do is press the trigger point to identify the duct for cannulation with a lacrimal probe, and try and use the largest size of probe which eases into the duct as you are entering, and do not push, as you can create a false track. Alternatively, you can inject the duct with methylene blue. I sometimes think that is kind of messy, or you can even use these stiff nylon sutures number 2 or number 3 to enter the duct. So there are various methods to identify the symptomatic duct. You can palpate the lacrimal probe through the tissue at the base of the nipple, or you can identify it by identifying the dilated duct on dissection, or visually if you've injected methylene blue. So one must remember that the specimen increases in diameter as the dissection extends into the deeper breast parenchyma, and the transected duct should be identified, should be marked with a suture towards the nipple for later excision, for identification, and if required, any future excision. And once the specimen is excised, careful hemostasis should be undertaken, and close the nipple over approximated glandular tissue to prevent the collapse of the nipple. That could be quite unsightly. And now I'm coming to the video. So this is the nipple discharge in a 50-year-old. So this is beginning with identification of the offending duct. You insert the lacrimal probe into it, and I would fix it with a 2-0 silk suture. Like I said, you can use a stiff nylon thread also to keep identify the duct. And I would use a periareolar incision to access this duct. So that's the periareolar incision, and you have to raise flaps. This is the skin flap being raised behind the nipple. You don't have to really raise it completely, just the area of interest and to the extent of the incision. So identifying the duct with the probe in situ, that's the duct that I'm holding with the probe inside it. And now I would be raising the lower flap. So you can apply hooks, and that is where that is how much of breast tissue I would like to take, because beyond that I cannot feel the probe, and it is dissected in a cone-like fashion. So what you're removing is a triangle of tissue. That is how your specimen should look like, narrowing towards the offending duct. And once you get down to the offending duct, just narrow it down and expose the duct. So you can see the duct with the probe in situ. And this is where I would like to place a little nick on the duct, and that is the probe coming into view. Sometimes what I do is it's like playing around with the catheter. This is just to make it easier for the pathologist. I try and put in this little the cannula, intravenous cannula that we use, and use the sheath to enter the to mark the duct. But sometimes you're not able to do it. That's okay, so long as you marked it with a suture, it is fine. So it, like I struggled with the 22 gauge, so I gave it up, gave a nick over the duct, and then I tried to put in a 24 gauge cannula, and that happened successfully. You can do this, or you can completely omit this step, provided you tell your pathologist, and your pathologist knows that there is a suture where the offending duct was. This just makes it easier for them to identify the offending duct. So now the probe has been removed, and now I'm cutting off the bits from the cannula, and that is the length of the duct which is affected, and that's the breast tissue which has come out with it. That's the triangle that I was talking to you about. And now you must fix the specimen. So one stitch is good enough, but if you have any suspicion that there may be DCIS or anything in this patient, then you can do a conventional orientation also with a stitch which is a loop stitch that I like to place for the anterior identification, and maybe a medial stitch or a lateral stitch as you may like it. And then I'm closing the subcutaneous fat just to create a bed for the axilla, because it is very unsightly to see the nipple sink into the breast if you don't do that. Subcutaneous closure with Vicryl 3O, and then subcuticular monocryl stitch for the skin closure, and that is about the microdecectomy. This is how it looks like on the table. Thank you very much. The final histopathology was an intraductal papilloma in this case.
Yeah, a very simple demo. It makes it look very simple, Geeta. I just wanted to know, how often is it likely that one would miss a papilloma which was a little more distal, as compared to what is usually seen? How often in 100 would you say?
The single duct papillomas are usually periareolar, very close to the nipple, and that is the commonest thing that you would see. The trouble is with the multiple papillomatosis. These are the ones which tend to be peripheral, and you may possibly get an idea as to it was multiple papillomatosis when you do a major duct excision. That is when you would get to know that it is multiple papillomatosis, and such patients you need to keep them on close follow-up, because multiple papillomatosis is also a precancerous, it's a high-risk lesion. But there is no way you will be able to address peripheral papillomas unless you pick up something on imaging, and usually you land up picking up nothing on imaging.
Right. Any time that you've picked up an intraductal carcinoma when you were doing something like this?
Yes, several times. I would not say many times, but yes, we have picked up DCIS, and so that is the commonest finding. And sometimes you do get these invasive papillary carcinomas, solid papillary carcinomas, which again is yes. So these are things that you do pick up when you're doing a major duct excision or a microdecectomy.
And then you'd progress as you would do for a
yes.
CA breast.
Then of course, if it is high-grade DCIs, then I would possibly even go ahead and do a sentinel node biopsy.
I think that's great. Sameer, do you want to ask anything?
No, madam. I think we are short of time. We are already exceeding the organized will be behind us. It was a nice presentation, madam.
Thank you, Shilpa. Thank you, Dr. Sameer. Thank you, Sandeep, for this opportunity. Thoroughly enjoyed being here.
Thank you so much, Dr. Shilpa, Dr. Sameer, Dr. Somashekar, Dr. Sandeep, and Dr. Geeta. The videos were extremely excellent, and we are all honored that you have presented such a nice videos. Thank you all. Now I hand over mic to Dr. Niranjan Agarwal who will take over the proceedings and vote of thanks also.
Dr. Rajesh Yadav, is he around? Dr. Rajesh? Rajesh, are you around? Is Dr. Abhay Dalvi around? Yeah.
I think
Yeah, he's there.
Dr. Abhay Dalvi?
I'm there.
Yes, sir. May I request you to say a few words in conclusion of this day?
I think right from the start of the program at 8:30, it has been a wonderful knowledge sharing experience as far as I'm concerned, because I have been a little away from breast and thyroid, but so much has changed as far as the treatment management and investigations, etc., of both these organs, important organs, common organs that have taken place. And all the faculty, including chairperson, have stuck to whatever they were expected to. So congratulations to Mumbai Surgical Society and the state chapter for a wonderful day-long program. Thank you.
Dr. Soma Shekhar from ABSI, you would like to say a few words?
Thank you very much. It was a wonderful event. Sandeep always organizes extremely well. It's honor on behalf of Association of Breast Surgeons to be here. It's done extremely well, very well covered. Most of the faculty are our ABSI office bearers, are EC, everybody. So it's honor to be with you. It's a fantastic event. We should do such more academic event. Congratulations to the whole organizing team, especially to Dr. Sandeep, and thanks all the faculty.
Dr. Paul, Dr. Paul, are you around?
That always connects to the audience better than only speaking.
Is Dr. Paul?
No, Dr. Paul is not here.
Dr. Ganeriwal?
And somehow
Dr. Ganeriwal is around?
Bottom corner.
Pramesh, can you stop sharing your screen? Is Dr. Ganeriwal around? Okay.
No.
I just saw Rajesh. So friend, this brings us to the end of this wonderful day, day well spent in updating ourselves on 2 organ-based, theme-based program today. As Dr. Abhay Dalvi said, I would also accept that I am much enlightened today as far as breast and thyroid are concerned. So many new things and so many simple ways of doing difficult things have emerged for better patient care. I must compliment both my conveners to have conducted this program efficiently. 8 hours program on a virtual platform, and to stick to the time, we are literally finishing well in time. 10 minutes is not something which is called delayed. The Almighty must have been with us, because nothing went wrong, neither sharing of slides nor sound. Maybe 1 or 2 speakers sound were any issues over it. So thank you, the Almighty. Thank you all the delegates who have been there till the end, and this is what pushes us to conduct more such programs, the interest shown by the members. And we did take this program nationally, and I would still request those who are from Mumbai and MMRA region to become members of Mumbai Surgical Society, because there are many more things which are coming up with Mumbai Surgical Society in days to unfold. And Dr. Girish Lad, who's the MMC observer, who has been here for the whole day, unlike many observers, I have seen him here for the whole day. Sir, you would like to say a few words?
Yeah, that is, I am very grateful to you, Dr. Bipte and others, to organize such a elaborate but concise webinar. And every speaker, I would appreciate that every speaker gave maximum what they could give. And another important thing, organizers, I thank organizers for seeing it that it was completed properly in time, because usually otherwise it gets exceeded. And really what is said by Dr. Dalvi is there are a lot of things. I am a general surgeon, but still that's what I'm saying, that newer things are coming up, and we are really enlightened about, and that especially the panel discussion, that in multiple sessions, that was wonderful. So I'm very much grateful to MMC for making me observer, and I'm grateful to the team for giving such an elaborate session.
Thank you, sir.
Thank you.
Thank you for being with us, sir, today. And I must apologize on behalf of myself and my two conveners who may have intervened and stopped many speakers, telling them that time is over. But we had to do this bad thing or whatever you may call it. But there was no intention. It is only that the last speakers, justice is done to them. And thank you, Fresenius Kabi, for supporting this activity, as well as Vama event for streaming it so well. And so many hard hours have been gone in arranging this program. Pramesh, who's from Vama, has been very active over here. So thank you, Pramesh. I can see Rajesh. Rajesh, you are here. Dr. Rajesh, your photograph is seen. So anyway, thank you, everyone. See you more in more such interactive sessions in future too. Thank you, everyone.
Just a minute. Before winding up, it's our honest duty to thank, first of all, and in the last, Dr. Niranjan Agarwal, who has taken so much pain in the last many months for organizing each and everything, taking care of each and every speaker, timings, and guiding us every time in taking so many meetings and giving his precious time also. So it is he who has made this program a huge success. Thank you so much, Niranjan sir.
Completely. I second with this. I second the opinion with this, Ritesh. And as our captain was very nice and excellent with ideas and everything, he was the one who has started this program 3 months back, but due to some reason could not do it. He was waited for me about 2 months to have this program, and today I can see the really success for this program. Thank you, Niranjan sir, and thank you, Yadav sir, for this giving opportunity to us.
Thanks a lot, and a good evening to all of you.